falls. And Newmark is located near the central station. And the characteristic of Newmark is that the elderly living there, the population of elderly living there has nearly doubled in the last 10 years. And this aging population trend is not specific only of Amsterdam or of Netherlands, but actually is a worldwide trend. And the World Health Organization estimates that by 2050, the number of elderly living worldwide will reach 2 billion. And 28 to 35% of elderly fall outdoors every year, and we expect an increase in these fall numbers. This leads to increased costs to society on one hand, and on the other hand leads to decreased quality of life for elderly. Current fall prevention emphasizes with mobility, behavior, participation, and activities.
Cool. Hi. Let me show you the study outcomes. So, we had a total of 52 independently living elderly with an average age of 75 years for our study. We found that in the last 2 years, nearly half of them experienced a fall outdoors, and that 25% of them are recurrent fallers. The average fear of perceived to cause falls and fear of falling. Again, there's a visible relationship with places elderly visit most. Let me show you on the next slide the identified risk factors. Oh, here we go. Okay, so these risk factors can be further divided into built and social environment. Walks that turn slippery when wet, large crowds of tourists and cyclists, sidewalks blocked due to parked bicycles or rubbish, the large terraces of these cafes and bars in the inner city. Okay, so now we also investigated how the perception of the environment can affect the elderly's outdoor mobility and behavior. Elderly seem to adapt or to avoid certain situations. For example, they watch the ground with every step, they start using a walking aid or choose a different route to their destination or make a detour. However, a detour is only possible if they can walk a longer distance. And we also found that activities and participation are affected. This graph here shows the activities affected by fear of falling by a previous fall in red. It shows that the elderly quit cycling most often, followed by starting to use a walking aid, going for walks less often, or going outside less altogether. So Caroline will show you, Monica will show you the methods.
Thank you. Yes, so thank you. We start with both using quantitative and qualitative methods in our research. And this is known as a mixed method approach and has its own qualities and limitations. We started with the quantitative approach, and this was done by the means of an interview survey. And I would like to specify that the questionnaire we used was made by us. We performed a recruitment procedure and a screening. And we can elaborate a little bit later about this if you are interested to know. Following the quantitative phase was the qualitative phase, and the qualitative consisted of focus group meetings, a case study, a narrative, a full narrative, and an expert interview. And the reason we used the qualitative part was mainly for two reasons. Was to verify our own data from the quantitative phase and go deeper into it, and then secondly, to confirm the themes that we have discovered during our quantitative phase. During the quantitative phase, so during the interview survey, we noticed that people's answers were not really what we expect and were contradictory to what we observed. For example, participants walking with difficulty or even walking with two canes, they were telling us, yeah, but we don't have any problems. We are not afraid of falling. Also, we noticed that people were not really able to identify risk factors in the environment, and we start wondering why do we get these odd answers. And we identified these four themes through a cyclic process that was based on our own interpretation and connected people's answers to our observation. The first theme, independence. We all know that falls can lead to loss of independence and a downward spiral towards nursing home and even death. Therefore, wanting to stay independent is very important to elderly. And what they do, they either adapt or avoid. Adaptation is a strategy they use in order to continue their activities and participation. For example, the elderly told us that they might walk from bench to bench. But in order for the adaptation to occur, benches need to be present in the environment. Otherwise, avoidance occurs. And avoidance has a negative effect because it leads to a decreased activities and participation, and this can lead to an increased fall risk. Self-perception. Perception of the environment relates to self-perception because self-perception influences people's ability to deal with risk. This has been investigated by Lumbar and colleagues in 2010, but at the moment the topic is still currently unexplored. And if you would like to know more about this, we can discuss it during the question time. I will pass it to Caroline.
Thank you, Monica. Wow. Okay, so let's continue with the conclusion. So what we've told you till now, or from what we've told you, you can actually deduce and understand that the environment is important in falls prevention. So environmental factors, as you've seen on the maps, for example, cause falls, and they cause fear of falling, and through that they affect activities, participation, outdoor mobility, and behavior. As you may not have seen, the environment can even be a decisive component because it affects if people decide to engage in activities or not. And that is linked to this adaptation, what Monica mentioned, because if the environment does not offer people the possibility to use their capacity for adaptation, they will start avoiding. And that affects their outdoor behavior and if they go out at all in the first place. We already mentioned two examples. For example, people's action radius needs to be large enough in order to be able to make a detour. And walking from bench to bench is only possible if benches are present. Monica highlighted it already. We also found this complex relationship with biopsychosocial factors. So self-perception is an example of this. So self-perception is really about if people, how people see their own capacity and ability to deal with these environmental risk factors. And how they see their own ability determines how they perceive these risk factors in the environment, and that's closely related. And all of this, these mechanisms, these complex mechanisms, are actually driven by this fear of losing independence. So what can we do about this as physical therapists? Now you know inclusion of the environment in falls prevention is important, but how? Well, this is something that future research needs to actually investigate, because we don't know how to do it. We have no answer for this, unfortunately. But future research will need to focus on linking known personal factors like medication, shoes, eyesight, and depression. So all these personal factors that we know that are important in falls prevention need to be addressed and linked to these environmental risk factors. You as physical therapists, you can act on this in different ways, and a combination obviously is the best. You can enhance physiological variables, so muscle strength, balance. Those are the things we can train. You can also address cognitive factors by enhancing people's self-efficacy and enhancing people's self-perception in order to reduce this fear of falling in the environment. And finally, this can, for example, be done by enhancing people's adaptation strategies. And now that you know, for example, one of the things that we've shown you, which factors in the environment are important, you can educate your patient on this and show them, how to deal with these factors and train them, and also check which of these factors are present in the direct environment of your patient. So thank you for your attention till now. That was it. We can imagine that you have many questions, so please. Deadly silence. You say.
No, but if you could repeat the question back.
Okay, well, I have many questions, but I just asked a few of them. It's an interesting topic. I was wondering, from the people that you interviewed, how many of them did fall and where did they fall?
Yeah, go ahead.
I mean, I know this number by heart, so, right. We had 48% in total that fell outdoors in the last 2 years. What's the number? 17. Oh, no, that's the 33 in the new market itself. And then on top of that, it's 48 of 52. 30.
Yeah, nearly half.
Nearly half of them. So it's quite a high number, and that correlates with literature.
Yes. Okay. And then if they say the answers are driven by fear of losing independence, is that something that you know or that you think about?
Yeah.
Oh yeah. I mean, that's half.
Yeah, so what is actually, and we didn't highlight it much because our methods were actually quite complex, and as Monica explained clearly, a mix of quantitative and qualitative methods. What we used was a method called interpretative team finding. This is a method where through a cyclic process we actually went over our data. We had diaries, we had an audit trail of everything we've done, both quantitative and qualitative. And so we went over it, we thought of themes individually, then sat together, discussed, thought, okay, how is it possible that people are unable to identify these risk factors? Or why do these answers that they give do not seem to make sense with how they walk, how they talk, how they behave? We only made observations because we were not allowed to touch them, let's say, and do measure, for example, physiological fall risk. But from this story, we came up with these 4 themes, and independence was one of them, because in the focus group, people mentioned that a lot of times. And even during the quantitative phase, where we had an interview survey, so we spoke to them directly, we had a questionnaire, but there was also room to, discuss and talk and have an actual interview. So it was, let's say, semi-structured. And through that, independence came up a lot as an item, and that's how we identified this team, and we back-checked it again and again against our own data. Yeah.
Independence is important, but does it lie to you?
Lie to us.
That you say, okay, I
Yeah.
have problems with the environment.
No, the thing is, and that's where self-perception comes in as an important second theme, because the difficulty that we encountered was that many people actually did not say certain things. And that has nothing to do with lying, because many times also it's an unconscious process where people are actually in denial of their own fall risk. Fall risk is most of the time, and that's also what many studies show, something that is external. It doesn't concern them, so it's keeping it out of their comfort zone. And realizing that you're at fall risk yourself is not very comfortable thought for many people. So, and that's what Monica quickly mentioned. Delbare et al. Is an author who actually explored or started exploring the topic of self-perception and how self-perception relates to falls and fear of falling, and how people perceive their own ability to deal with fall risk is really, really important, and also seems to be important in addressing this problem and coming up with treatment and preventing falls. Yeah. Bob says we need to stop.
Ja, ik ken alles. Okay, well done.
Sorry, Bob, there was something about the microphone.
Yeah.
Disturbing.
Yeah. You should clip the microphone on, huh?
Okay.
Because the whole world is hearing all the noise.
Yeah.
All right.
Oh well. So yeah. Oh.
Yeah, so clip it on. No. You need this one. Yeah.
You go first.
Put it in the back and clip it on, please. It makes too much noise. This one is hearable in the room itself, but not on the television. That's why we need it. Coach you. She goes over there.
Yeah.
Okay, good.
Thanks. Okay, good morning, everybody. Me and Shahaf are going to present a literature review about the effectiveness of malignant mobilization with movement in treating subacromial impingement syndrome. Shahaf will start giving you an overview about the pathology. We will give you a little insight about what was the process that led us to choose this topic, and go on.
I need the mic. First of all, thanks for joining so early in the morning, and excuse us for the notes for the same reason, because it's a bit early. Also for the viewers all over the world. And probably many of you are asking yourselves, okay, so what is subacromial impingement syndrome? Basically, the classic definition you can see is the encroachment of subacromial tissue in the subacromial space. That happens when the humerus elevates, usually inside the glenoid fossa, and these tissues are trapped. Now, it's important to realize it's not one pathology, but rather a range of pathologies, which you can see here. So we're talking about rotator cuff muscle tears or tendinosis to them. We're talking about pain syndrome, which is a bit of another wider definition. calcific tendinitis to the tendons that pass through the subacromial space, bursitis, glenohumeral instability as a result of labrum tears, for example, and dyskinesia of the scapulas. So there are many interventions which are commonly used to treat them. You can see them. I'm not going to go into all of them because of time, but many of them have their advantages and disadvantages. None of them are perfect. Exercise therapy, we can say, is one which gives us better results than the others, but also not specific enough. Corticosteroids, we get the short-term relief, but then the long-term effects are undesirable. We all know them. We can scan through this later, and also we can get into this deeper. Just want to move on because of time. So basically, many people go to the healthcare providers regarding musculoskeletal conditions. More or less 1/3 of the musculoskeletal conditions are shoulder-related, and within those conditions, by far, subacromial impingement syndrome is the most common diagnosis when we're talking about function. So we can see that the prevalence is very high, and yet there are no clear guidelines either regarding treatment or other. And we see that it's a huge burden on the system, because even though there are so many different treatments, still after 1 year, many of the cases still show the symptoms.
Okay, so after seeing a little bit what is the relevance of the topic, the main point is that there are a lot of treatments available, but there are no clear guidelines about what is the best combination of them. Especially there are no treatments which can provide immediate pain relief and immediate gain in the active range of motion of the patient. So, Mulligan mobilizations, Mulligan developed a concept. He further developed the manual therapy concept of Kaltenborn by adding more translatoric movements, and by adding different plane of treatment compared to Kaltenborn. For example, Kaltenborn, let's take the example of the joint of the thumb. When we have a problem in flexion or extension, Kaltenborn used to mobilize in the same plane of the movement affected. Mulligan adds some more movements, and it changes the treatment plane from being the same treatment plane of the affected movement to be to treat the joint in the perpendicular plane. Now, the goal of performing a manual mobilization with movement is exactly to have a immediate gain in the active range of motion of the patient, and to have a sustained improvement. The basic principles of the application of Mulligan can be seen here. I'm not going to go into the details, but the response that the therapist is trying to elicit during the trial treatment, and it's also the indication that makes the technique to be used as a treatment or not, is the immediate pain relief and immediate gain in the active range of motion of the patient. If this pain-free response and immediate gain in range of motion is not created, then the movement, then the treatment, the mobilization with movement is thought to be not indicated. Now, this is based on the most recent literature available, but the evidence, it only supports its immediate short-term effect. To make a summary, the goal of using this technique is to apply a necessary pain-free mobilization during the simultaneous active movement of the patient. The treatment plane to be chosen, the glide is applied perpendicular to the plane of the most affected ADL movement. In the specific case of the shoulder, if, for example, we have a problem in abduction, scaption, and elevation, we identify what's the movement that is most impaired. For example, if it's forward flexion of the shoulder, then the treatment plane will be perpendicular and the glide will be applied perpendicular to the impaired movement. One of the basic principles is that the application of the technique has to be pain-free. It has to be pain-free at the moment in which the glide is applied, and it has to be pain-free throughout the whole range. So it's fundamental, the cooperation between the patient and the therapist to make sure that no pain is elicited. The failure to achieve an immediate gain in the active pain-free range of motion and decrease pain, it means that malignant mobilization with movement is not indicated to solve the problem. Now, when is it indicated instead? It is indicated when during the first assessment and during the trial treatment, we managed to create these three responses, which is immediate decrease in pain, immediate gain in the active range of motion of the patient, and that these two items are sustained after the application of the technique.
So, yeah. Basically, the purpose of our study is to, now you've heard a bit about impingement syndrome and also about the Mulligan principles. What we wanted to find out is, regarding the immediate and short-term frame, is it an effective treatment for treating subacromial impingement syndrome compared with the list of intervention that we showed you earlier? So, we did quite an extensive literature study. I think we got almost all literature that was published in this case about this topic. And then we see two studies that support the efficacy in the immediate time frame, also compared with other treatments. And then 4 studies which are talking about the short term. Again, the list of references is there. But you saw one of the main principles of Mulligan is the long-lasting effect and sustained effect. We didn't find any literature to support that. That's something interesting to study in the future. So here, this is just a table to see the main characteristics and the main intervention that were used to compare with Mulligan mobilization with movement. You can see most of them are either sham treatment or Mulligan plus something else, supervised exercise program, etc. Basically showing the superiority of Mulligan over all these. This was not the main focus, but we found this also. We were not searching for the mechanism of actions, but we found 2 main theories. One is the biomechanical, that fault correction creates better movement and less pain. And the other one is the neurophysiological mechanisms that's a whole huge, that's enough for a couple of other thesis projects, but that's just a byproduct of our findings.
Okay, the limitation of the studies, there were of course some limitation in the literature we performed, and the first and most important one is the screening for the Mulligan mobilization with movement eligibility for the treatment. So one of the basic principles is again that the treatment to be indicated should create this specific pain-free range of motion gaining response. But in a study, in an RCT that is studying the efficacy of the technique, of course, one of the main prerequisites it should be to having done the screening before selecting the study population. So to include only participants which have already passed the screening and which are already eligible for mobilization with movement treatment. Now, the heterogeneity of the studies that can be seen again in these slides before, it's quite wide because some of the studies were including a sham treatment, some were including a control treatment, some were mixing, so they were applying, for example, in Tace et al., in the first one in 2013, it's only a comparison between mobilization with movement and mobilization with movement plus kinesiotape. So the time frame measurements are one of the other main limitations because they were not consistent throughout the studies. So some studies did perform the outcome measurements in like right away after the end of the treatments. Some they performed it after a few weeks after, but none of them performed it to find application for long-term pain relief. The sample size of all the studies were rather small, between 30 and 40 participants, and the methodological quality of some of the studies, it was low. Future research should investigate its long-term efficacy, and it would be interesting to understand if it means that it's so efficient, also for how long are the improvements maintained. So the conclusion of this review of our literature search was that MVM application decreases pain and improves range of motion in patients with subacromial impingement syndrome in the immediate time frame, and it is superior to other commonly used physiotherapeutic intervention in decreasing pain and improving ROM in the short term when indicated. I guess we don't have time. We want to make a short practical demonstration of the glide, but from the audience we get signals of finishing the presentation. Thanks a lot.
Questions?
Do you have any questions?
Do you have any questions? I have a mic now. I hope it works.
You can ask.
How do you define short-term and long-term?
How did we define short-term and long-term? We defined it also according to the measuring time frames that were taken, because some of the studies performed the measurement after a cycle of, for example, 8 treatments. Some, they had a baseline, they took measurements right after the cycle of the treatment, and then they had a follow-up after 1 or 2 weeks. The definition of the short term, so basically the immediate time frame is we considered it to be right after the application of the technique, so right after the treatment. Whereas the short term, it was defined as
24 hours max.
Yeah. So the immediate time frame is within maximal 24 hours, and the short time frame is up to 2 weeks.
You said that when it's indicated, but do you do any special tests to determine that
One of the principles is when you perform Maligan, you perform first of all an assessment trial, and that if you get results in the assessment trials, so either reduction in pain or increasement in ROM, then the trial is indicated. However, this assessment is also actually part of the treatment. So this is also something we didn't have much time to get into, and some of the RCTs defined that and some didn't. So we consider it has to be done. The trial, in order to determine if malignant is indicated, it has to be done, this assessment. And of course, if it's a successful outcome of this assessment, then it's also considered already part of the treatment because you treated it already. I hope that answers your question. Okay, any other questions? Okay. Thanks.
Thanks a lot.
Yeah.
Yeah.
Look at you, coach.
Weiß ich eh nicht.
Take it or just all right.
Yeah.
No, I don't want it. Sorry. Okay.
Okay. Good morning, everybody. My name is Karen, and this is Maggie. And this morning we're going to present to you our PAC presentation on the topic of osseointegration prosthesis in patients with amputations. So our research question, just to give you some information, is what are the advantages in the performance of gait, range of motion, strength, aerobic capacity, and overall functionality in patients with osseointegration prosthesis when compared to socket joint prosthesis? We completed this thesis in relation with these patients in Nijmegen, in a hospital that is specialized in this area. So just a quick schedule. So I'll explain first of all what is osseointegration and clinical relevance. Maggie will speak to you about the methods and our findings, and she'll also show you an example of our product. So our interest first came about by the Amsterdam Wheelchair Rugby. I had a really nice experience there, and I worked together with a player that had a traumatic amputation, transfemoral, after a road traffic accident. At the time that I was working with the team, he had just completed the rehabilitation for osseointegration. I began researching a little bit more into the topic, and I shared my information with Maggie, so we just thought that it would be interesting a topic to do for our thesis. So a bit about the clinical relevance. In 2005, there was an estimated 1.6 million individuals living with the loss of a limb. And by 2050, this figure is expected to increase to 3.6 million. And amputations will affect nearly 1 in every 120 individuals. 97% of these patients who are currently using socket joint prosthesis reported that the socket joint negatively affects the quality of their life. So regarding physio-relevance, we find these numbers quite scary actually, that there will be this amount of individuals living with amputation in the future. So we wanted to develop a protocol, an exercise protocol to help in the rehabilitation of these patients. So our mission and our primary focus was to explore the most suitable exercises to improve the functionality of patients with osseointegration when compared to socket joint prosthesis. We did a systematic review to gain some scientific evidence to support the preference of our exercises for our protocol. So you're probably wondering at this stage, what is osseointegration? So osseointegration is a new and innovative prosthetic device. It was developed in the 1960s by Professor Brännmark in Sweden. It was initially developed for dental implants, and in the 1990s then started to work with upper and lower limb amputees using this prosthetic device. So it's defined as a direct structural and functional connection between living bone and the surface of a load-bearing artificial implant. So here you can see a couple of pictures. This is a patient that has had the osseointegration prosthesis. Here you can see the external fixation, and inside the residual limb there's an internal fixation whereby the external fixation is connected. And you can see here it's the internal fixation. It's inserted into the marrow of the bone of the residual limb. And here you can also see a more clear picture that it's actually directly into the marrow of the bone. Okay, so the results of this technique is a firm and permanent anchorage for a prosthetic reconstruction. The direct anchorage of the implant to bony tissue increases the overall strength of the fixation. And the osseointegration, when related to socket joint prosthesis, it decreases a lot of the negative side effects which occur in socket joint prosthesis. For example, breakdown, muscle atrophy, and poor biomechanics, just to name a couple. So just briefly, I won't go into too much detail, but there's two types of osseointegration. First of all, the screw fit. This was developed by Professor Brännmark in the 1960s in Sweden. His process contained 2 stages, but it actually took quite a long time. So patients had a rehabilitation phase of 18 months. And at the end of the 1990s, the press fit was developed by Professor Hans Grundy in Germany. This procedure is the one that's used most often now, and there's only 4 countries in the world that use the osseointegration in total, the Netherlands being one of them. So we were actually really lucky to get to work with this kind of procedure and rehabilitation. So Maggie will now discuss something about the methods of our systematic review.
All right, for the methods, we undertook a systematic review, and we used the following database: PubMed, Pedro, ScienceDirect, Sinal, and Cochrane Library. This is a list of keywords and mesh we use for our PICO. Really quickly. And the inclusion criteria were the following, and one important one that we just wanted to use transfemoral amputation patients, so no transtibial and anything else. And we wanted to use just high quality articles, so randomized control trials, cohort, and cross-sectional and observational studies. You can see the list of inclusion criteria here. This is the list of the exclusion criteria. So we didn't want to investigate any infants or adolescents, and articles before 2002, and all the other parameters stated in the inclusion criteria. Okay, to grade the articles, we use these tools according to the Cochrane library. So for the observational studies, we decided that we are going to grade them with AMSTAR checklist. For the cohort studies, we were going to grade it with the EQUIPS tool. Cross-sectional studies with the QUADAS tool, and randomized control trials with the Pedro scale. This is our flowchart. We started with 302 articles, and we ended up with 7 articles, which 5 of them were cohort studies, one was an observational study, and the last one was a cross-sectional study, sorry. Unfortunately, we were not able to find any randomized control trial. for the result. We found, according to our variable that we wanted to investigate, in the articles we found, for example, with the gait, the measurement instrument was a 3D motion analysis system. For the aerobic capacity, the article stated the 6-meter walk test and the PCI, which that stands for physiological cost index, and it's a measurement tool that measures the energy expenditure. Then for the range of motion, we found articles talking about the hip range of motion assessed through the goniometer, and for the overall functionality, we found articles talking about the QTFA, which is a specific questionnaire for transfemoral amputation. Unfortunately, we did not find any article talking about strength. So these were the findings that we were able to find. So for the gait, we see that with the osseointegrated technique, the cadence was quicker, the stance phase was shorter, and the swing phase was longer. The range of motion on the hip was better with osseointegration technique, and the flexion of the arm was 115 degrees compared to the socket joint prosthesis, which was 105 degrees, so we had like an improvement of 10 degrees. For the extension, we had a 15 degrees of extension with osseointegration technique, and started with 8 degrees of extension with conventional socket prosthesis. The external internal rotation actually with socket joint prosthesis was 0, and we found an improvement of 25 degrees with osseointegrated prosthesis. And the 6-meter walk test improved from 280 with socket joint prosthesis, arriving at 300 meters with osseointegrated prosthesis. And the QTFA questionnaire improved by almost 20 points. And the entire duration of the gait cycle was shorter with osseointegration. So, as a conclusion, we can say, that gait was a variable which, even if improved, did not improve at the same level as able-bodied people. And as a recommendation, we would like to say that further research should be done, especially about strength and especially about range of motion about the ankle and range of motion about the knee, because we weren't able to find any article. Because we found that the gait did not improve as much as the other variables, and this individual failed to reach the same level as the able-bodied population, we decided to found our protocol on walking techniques and gait training. So, the layout of the protocol is divided in 3 sections. Section 1 is characteristic of gait. Section 2 is walking with and without crutches. Section 3 is advanced exercise. For the section 1, this is one example of one exercise that we wanted to show you, but we had like 20 or 20 exercises. And this is section 1, and we are here. The patient is doing a partial weight shift forward and backward. This is important for the initiation of the gait and for the gait pattern itself. So it goes in forward and then to the neutral position and backward. For section number 2, this is like an example of functionality. So how can you walk with the crutches and opening a door, for example? You can see that he is using 2 crutches and he can push the door without not leaning a crutch somewhere else. And section number 3 is actually walking over obstacles. So there's another functional exercises, and we can see that to walk over obstacles, always the prosthesis leg goes before and then after the good leg. Voila. This is it.
Thank you for your attention. First of all, just before the questions, we would like to thank our coach, our client Rue Linedecker, and our patient Jack Healing. So we'd like to invite any questions.
We're going to do this a proper way. My way.
I guess in literature we know that the majority of amputations are due to diabetes and circulation problems, and this is obviously the patient is traumatic. So is this a protocol for just the traumatic osseointegration, or can it also be applied to diabetic patients that have had a transfemoral amputation?
No, that's a good question, thanks. Yeah, it's actually a protocol that it can be used for all amputees that have gone through the osseointegration. So generally it's quite important actually to note that the patients that are receiving osseointegration have had many issues using socket joint prosthesis in the past. For example, our patient, although he had a traumatic amputation, he did use a socket joint prosthesis for approximately 12 years. He ended up being a wheelchair user because he had so much pain and there was so much negative effects from the socket joint prosthesis. That's not only because of the traumatic injury, but it's also related to patients that have diabetes, that even were born without a limb, for example, and other diseases and other deformities as well. So it can apply to all populations of patients with amputations.
Let's do it. Thank you very much for this nice presentation. I've been your coach, of course. You did a great job. I still have a question for you. What would be the main difference between an exercise protocol for osseointegration patients compared to the socket joint patients? Because the exercises you've shown, they are functional, and my question is, how would they be different from other amputation techniques? Is there a difference?
Well, actually, this is a good question, because according to our findings, we were not able to provide like a good answer. So we were not able to find we discovered that our thesis is not enough to refine the rehabilitation protocol for osseointegration patients compared to the socket joint prosthesis. Right. This is one of our weakest points.
Would that also be the reason that there's hardly any RCT to be found, taking into account that
it's difficult to blind.
It's from 1960.
Indeed, we didn't find any randomized control trial because it is really difficult to blind patients, of course, because it's really clear what is socket prosthesis, what is osseointegration. So that's why it's not possible to blind patients.
Although, just to add a little bit onto Maggie's answer, it's also important to note that we did find a lot of exercise protocols for socket joint patients, so just amputees in general, although there was no exact protocol for patients with osseointegration. The client and the hospital that we worked with, they made up their own exercises and protocols, which we adapted into our protocol. So we didn't use the exact same exercises as in other protocols, but we rather did it in a lot more detail. And also something that we didn't mention, we didn't really have time to go into so much detail. We also in our protocol spoke about implicit and explicit learning, which was something that we learned when we were in Nijmegen, and had a really beneficial effect on patients with osseointegration. Now there's no reports to say that this works with socket joints patients, so that's what makes our protocol a little bit different than other protocols.
Thank you. There's time for one final question. No? Thank you very much for this presentation.
Thank you.
Brilliant sticker management.
Yeah?
Keep an eye on your coach, yeah?
Yeah.
Thanks.
Yeah, T-A-N-E, there. Jesus. All right, guys, welcome. Today we're going to be talking about rhythmic auditory stimulation during gait training with hemiplegic stroke patients. And before we go deep into the presentation, I'd like to ask if there's anyone in the audience that runs as a hobby. All right, over there's some people. And does anybody run while listening to music? Yeah, you do, Martin. Well, why do you listen to music while you're running?
Sometimes if I do like a long distance running,
right,
15 kilometers, then it's sometimes nice to have music on. But also, it's maybe you're able to that the rhythm of certain music also makes me running better, or it feels like that.
Right. So that is basically the thought that got us going in this thesis. So I want you guys to hold on to that thought. And before we change the slide, we'd like to thank our coach, Janneke, for being here, and our client, she's in Finland, but she's watching online, so thanks. Hi.
So a little bit of our personal background. I have played violin since I was 6 years old, so music has been and still is a big part of my life.
And I have had a very strong interest in neurology for several years now, so that's why we chose this patient category. And together we've made a really good team and worked on several different projects together. So when we started thinking about this project, we asked ourselves, okay, what is a tool that is available to everyone or can be available to everyone, is cheap, is easy to use, and doesn't require fancy technology or infrastructure?
We believe in power of music. Music can be very personal, and it's very impactful because it can make us sad, it can make us happy, it can make us relaxed.
One more. All right. So there's some previous research done in this area using rhythm with training or rehabilitation in Parkinson's. There was a study with patients with Parkinson's disease that showed that using rhythmic auditory stimulation actually helps them have more symmetrical step length and width. And this is due, it helps them decrease the freezing movements that are typical with Parkinson's disease as well as akinesia, and therefore they show an improved gait.
With stroke patients, it is proven that rhythmic auditory stimulation has an effect on cerebral activity. So when RAS is applied, the concentration and motor control are promoted, and when the movement is synchronized the rhythm, so this improves the gait.
So our aim of our project, of our literature review, was to find the effects and benefits of rhythmic auditory stimulation, what effects and benefits RAS has on gait parameters such as cadence, stride length, and velocity when used during overground gait training with hemiplegic stroke patients.
Annually in Europe, 94.6 women and 141.3 men out of 100,000 are affected by stroke. It is estimated that to the year 2030, there will be 77 million stroke survivors, and more than 2/3 of them will have some kind of a disability. And only 7% of those that who are discharged from the rehabilitation meet the criteria for community walk, which includes a 5-meter walk, ability to walk 500 meters, and a continuous speed so that they could cross a road safely.
So for our study, we followed the PICO. Our patient category was stroke patients with hemiparesis or hemiplegia. Our intervention was using rhythmic rhythmic auditory stimulation compared to, with gait training compared to just conventional gait training. Our outcome measure was cadence, velocity, and step length. And we included patients anytime from the mobilization period or soon after having a stroke to 2 years post-stroke. And for our inclusion criteria, we used articles only published in English and that we could find on reliable databases, like you can see on the slide. We used randomized controlled trials, systematic reviews, and cross-sectional studies.
On the right here you can see our flow chart to the exclusion process. So how we got from 197 articles to the 11 that we included. In the included articles, the post-stroke time varied from 2 weeks to 2 years. The total duration of the studies was between 3 and 8 weeks. The control groups had gait training on a treadmill or overground, and intervention had gait training with the rhythmic auditory stimulation. And some studies included additional treatments such as NDT, and that was offered to both of the groups.
Here you can see half of a table with included articles in our study. And what I want to point out here is we use a CASP score for the to include articles for the quality. But so the statistical relevance per outcome measure translated to clinical improvement or practical improvement, and the post-stroke inclusion time. So these are the three things, most important things to keep an eye out on. And I want to point out, for instance, on this slide, article number 7 by Thought et al. For instance, on stride length, they showed a p-value of 0.049, which translated into clinical improvement. Patients showed a 35 centimeter stride length improvement with using RAS. And the most important thing is that this article included patients that were only about 21 days post-stroke.
The earlier the better. So as Tana said, the biggest improvement was found in studies that had the shortest post-stroke time, and it varied between 21 days to 3 months. And on the other hand, those studies that had the least improvement, they had a longer post-stroke time.
So what this tells us is that, as Kia said, the earlier the better. And this brings us to our suggestion, and that is that RAS should be used in conjunction with overground gait training after the patient has been able to or has finalized body weight supported treadmill training. That is the picture that you see on your left. And that's the patient cannot yet walk on their own. They need the support of the harness. You can see on the bottom of the slide, that is a progression timeline that we used or that we came up with. Why do we say that it should be used then? It's because the stimulation provides the patients with a rhythm that they can focus on and pays their gait to, as opposed to just focusing on the activity and the rehabilitation.
Music or rhythm supported therapy has significant improvement in motor control after stroke or any other neurological condition. It also improves cortical connectivity and activates the motor cortex.
So besides our thesis, we came up with a brochure that is being used by our client in Finland, and you guys are free to use it if you want. This is one of the 2 sides of our brochure, and what you can see here is a very short summary of our literature review, our findings, together with our practical recommendations. And on the bottom you can see the same progression timeline that we used before.
And here we have divided this other side of the brochure into 3 sections. So there is the earlier the better. When the patients can bear their weight, they can start using RAS with gait training. And then there are free apps that therapists can use. They can pick up a song that is important and personal to the patient. They can change the tempo with the app. And then increase the tempo of the song, which helps the patient to pace their gait. And by study by we suggest that the therapy sessions would be 5 times a week, at least 30 minutes, and minimum of 3 weeks. And then we have a video. Do I have to put the computer here on, or does the sound?
I think it's ready.
So this lady had stroke last June, and here we see
her normal preferred gait speed.
And then plus 10% from her.
Oh,
it doesn't have sound. And this is now plus 20. Well, there is a really nice ABBA song, Dancing Queen, that she was.
Unfortunately, you guys can hear it. This we checked yesterday. It doesn't work today.
What she said immediately when I increased or like I put the rhythm to plus 10% from her preferred speeds, she said that it's easier. She feels more stable, and it's nice to focus to the music.
Can you play it again? And since you guys were probably distracted because of the lack of music, but I just want you to look at how the lady walks. And notice if there's anything that you find, different, and if you notice any improvements right away by her listening to the music that you guys can't hear. Okay, so here's the list of references that you can find on our thesis too, and some of the feedback we got from our client and a specialist in neurology back in Sweden that works at the Karolinska University. And I'd like to thank you all for being here and listening to our presentation, also to those watching online. And if you guys have any questions, please ask away. Yeah, Martin, should I bring the microphone?
Just repeat the question.
Okay.
Otherwise, I try to speak out loud. Thank you very much for this really nice presentation. I have a question about the transition from
you can go back.
The auditory training to functional life, because I can imagine that those stroke patients often also suffer from cognitive deficits.
Right. Mm-hmm.
So how should I see it? Should they just wear earphones while walking on a busy street while listening to the music and at the same time pay attention to traffic? Or should this just be considered as a training in a physiotherapy setting in order to improve motor function or whatever?
Yeah, right. So our focus was to see what effects it had during training. So while physiotherapists are present and while we can control the environment a little bit. It's a good question though, and it's actually something that the patient discussed when we made this video. I think it's gonna be down to a personal decision whether they feel safer while listening to the music, kind of like with Parkinson's patients, that they have this stimulus constantly, or if they feel like they can just listen to the rhythm in their heads and also focus on the rest.
So I would say start from just doing it at a practice with the physiotherapist, and when the patient improves, they become more confident. Maybe then they can use it in their everyday life.
Thank you.
Yeah. Any more questions, Bob?
Of course, I'm more interested in cycling.
Yeah.
Is it applicable there?
I think so. I think that our findings, together with the previous research done on Parkinson and other research done on stroke, it means that the rhythm helps coordinate the movements. So not only walking, but any sort of movement, and cycling is a rhythmic movement, so I do think that it can be applicable. Now, whether the patient can safely get on a bike and go, then that's another question, but I don't see why not.
So you need to test it out and how it feels, and then we can.
I had too many injuries already.
Yeah. Other questions?
Yeah. Just one. Because there's, I don't know if you know something about it. This is mainly focused on auditory training, but
right.
We also have, and that's already implemented, also the visual input. That patients
right.
can put on a treadmill, and that obstacles are
come
on the
right.
treadmill, and they can just. Is there any? Do you know any information about how those two approaches relate to each other?
No, necessarily. We don't know anything because it was not one of our comparison criteria or anything, but
the auditory stimulus is a little bit faster than a visual stimulus. I think it was like 20 to 50 milliseconds faster than a visual. So, but of course you can start combining them when the patient first masters one, and if they're adjusted to it, and maybe then combine them. But we didn't look into that, so I cannot.
And I think the fun thing about this, as well as visual stimulus and everything, is that they're tools that can be added to different treatment methods. And that's what was interesting to us, is that you can see what works for different patients, because as you mentioned, patients might have different cognitive abilities or physical abilities, or maybe they can't see very well, so then the auditory stimulus is better than the visual. So I think that it's fun to be able to use these different tools to see what works for your patients. Anyone else? Yeah. Do you want to answer? Or?
So the question was if there's a correlation with decreasing falling. Yeah, we tried to. We thought about it. It was
in the back of our heads.
Process, but I think the articles that we looked into, they didn't inform that.
It was not per se what they looked at. So our conclusion, and I think that we can all agree that if the quality of gait improves, and if patients have a better and more symmetrical gait and better base of support, then the risk of falling decreases. So we can think that it will decrease the risk of falling, but of course further research needs to be done more specifically in that field so that we can really conclude that. Yeah.
Thank you.
Yeah. Thank you guys.
Okay, perfect.
Did you check yesterday?
No, because we didn't receive the email actually, but about the tryout.
Okay. What's your?
It's on Prezi.
You sent it to Bob?
Yes.
Yes.
Who sent it?
Me, Corinne.
It should be working.
It should be.
It should be working.
Yeah.
It's not working. Yeah, never mind.
I'll go with
It's going to check.
No.
I can also.
You want to check again? Or
no. I'm just gonna get this sound going. But used to you guys drivers.
okay. Yeah, start presenting.
We need to use it. Can we use this?
Can we just use this one?
No, because then our live audience will not be watching.
Oh no. But then I can breathe. I'm just gonna hold it. Maybe I can just. Like that. I'll try to see if I can do it. Okay. Shall we start?
Yeah, let's start.
Okay. So, ready? Stay.
So, hi everybody, I'm Gaetano from Italy and my partner Corinne from Israel. We just want to introduce you to our project, which is called My Dance Physio. With our, let's just go back.
Just a sec.
Yeah, with our client, which is Intrudance. It's a professional modern ballet company based in Arnhem. So we made a study with them and we will tell you more.
So the purpose of our PAC was to create an evidence-based dance screening tool for pre-professional and professional modern ballet dancers in order to prevent musculoskeletal injuries. And we're going to show you a short movie now, and we want you to look at the physical aspect and demands of the dancers. So I'm just going to do it like
Of our clients. So a bit of background information about this population. So it's professional dancer, and in the literature we found that they are considered actually as performance athletes due to the physical demands that are required. Also, the dance company reported quite a high injury rate for this population. About 67 to 95% of the injuries occur in the lower extremity. Particularly about the dance style, we focus on modern ballet dance because there are different dance styles, which is different in classical dance, so it has more degrees of improvisation and also other risk factors which are not involved in classical dance, which are the floors or scenography, so things that can provoke an injury. Also, we look for some evidence of screenings available for dance, and at the moment there are no screenings. It's not a common trend. Only one is used in the US.
So this is a research question?
Yeah, so where are the most common injuries in the lower extremity and lumbar spine amongst pre-professional and professional modern ballet dancers?
And now we're going to go to the method. So for the methods, we use the mixed method approach. So we had qualitative and quantitative studies. And then we use the sequence of prevention model from Van Mechelen as a guidance throughout the PAP.
This model is consists of 4 steps. So the first step is to establish the extent of the injury problem, such as injury incidence and severity. For this, we had 2 studies. Our main study is a retrospective prospective surveys that we did with the dancers of intradance, where we looked at the injury profile and management of their injury. And we did a supplementary study, which is a literature review about injury prevalence and characteristic among the same population. Then we went to the second step. With these 2 studies, we answered the question of the etiology and mechanism of injury as well. And the third step, which is our product basically, which is the MyDance Physio, the screening tool. And we did another supplementary literature review about the functional movement screening, because we wanted to include also a screening, a tool that predicts injury and can tell us more about the risk to get injured.
Yeah, so regarding the study we did with insurance, which is our main study, so 31 over 33 dancers participate to the study. We provided an online survey which targeted different aspects which we wanted to know. So it had these 6 sections which addressed mostly, like you can read, and then dance activity, for example, the injury profile, so how many injuries they had during their dance career, dance exposures, and also musculoskeletal complaints in terms of severity and frequency during their lifetime career.
So now we go into results. This is a bit of the general demographic data. You can see, and we didn't find any significant difference between male and females. Now if we go into the results, according to Van Mechelen, so step 1, we looked at the incidence. We found that the incidence of injury was 2.58 per dancer for his whole professional career. And in the literature, we found an incidence of 1.95 of injuries per dancer per year. In the graph, you can see that most of the dancers in intradance reported 2 injuries in their career, and the rest of the distribution.
Yeah, then more specifically in the same step, we just looked at the incidence per anatomical segments. You can see here that ankle is the most targeted site, followed by the foot, and then this matches what we found also in literature available, where ankle and the foot, self-reported and reported, are the most common injuries in the lower extremity. More specifically about medical diagnosis, we found that lateral ankle sprain accounted for 36% of the injuries, and the same was found in comparison in the literature review that we had.
Then the second part of step 1 is the severity. We measure severity in time loss, and actually 80% of the injuries reported were time loss injuries. More than half of them were severe, so it means that the dancer had to lose more than 10 days from their dancing activities. And you can see that out of 75% out of the ankle sprains that we found were severe. So lost more than 10 days.
Going to step 2 of the Van Mechelen model, so the injury prevention model, is establishing the cause. We found that 52% were overuse injury, followed by traumatic and recurrent injury. You can see that in the also body parts, so ankle was the most, followed by the other body parts. Then we also calculate a correlation between certain variables that we ask in the survey and the injury incidence, and see if we could identify some of the risk factors. And we only found a moderate positive linear relationship between the psychological state of the dancers and the injury incidence.
Yeah, and for step 3, so now we will introduce our screening tool, but before we also did a literature review about the functional movement screening, and we find that it good to high inter and intra-rater reliability, and that a cutoff score of 14 and under can predict a risk of injury. And this is now the product of our PAP. It's
So you can see, it doesn't matter because there is no, yeah. So this is my dance physio screening, which is divided in 3 parts. The first part is the list of all the tests that we included. You can see that we included a psychological questionnaire, according to what Gaetano just said, some range of motion test. Then when we'll scroll down, you will see also the functional movement screening, which we included dynamic dance technique assessment to assess their technique, some strength test, where you can see that we included the single leg calf raises due to the majority of ankle injuries, endurance test, and balance and proprioception.
Yeah, then the second part is more the scientific argumentation for the tests that are included in the screening. So you can see for each section that we targeted the explanation and a bit of reference to the literature. And then as the last part, so the third part is the protocol, so where you find the description for each section of the test. And I will show you just an example. So you will see, for example, for the calf raises, you have the goal of the test, normative values, so you know how much they need to score, the duration, and then the procedure, how you need to do the test, and probably a picture. So that's our products.
Yeah, and our POP has a little bit of limitations, of course. So retrospective, prospective study design, which is not the highest quality design. Also self-reported injuries, which we know from evidence that it's not the most accurate way of reporting injuries.
Yeah, in general, also in dance medicine, there is a lack of standardization, which made it difficult sometimes because of inconsistency in the definition we use, for example, for injuries, complaint, severity, frequency, and also about the method of reporting, which also is important to have an overall idea of the injury profile of this population.
And going back to Van Mechelen, step 4, which is basically the recommendation, and it's to be continued when we implement the screening tool and checking its validity.
And the effectiveness of the screening, basically.
Yeah.
Any questions?
Questions?
Yeah.
Microphone.
The reason why I repeat the questions back is for our live audience. So, what's the validity, or do you have any information of the validity of the functional movement screen for that specific population?
No, we don't. There was only one study that that tested the functional movement screening on dance, but because dancers are athletes, and this is something that is really important now in the dance world to kind of understand that the physical demand is really, really high. So we thought that it is valid at the moment to use the functional movement screening, even though it was tested more on other kinds of sports and not on dance, because there was only one.
The literature review was on the same population, so pre-professional and professional athletes. As we assume that dancers are performing athletes, we also just investigated that.
Yeah, okay, no.
But there is not yet a study specifically on dance, like there would be two plans at this point, because also the literature available is very little.
Yeah, because a big part of the functional movement screen is, of course, mobility or flexibility, and it could happen that, of course, there's a ceiling effect.
Yeah, so what we said is you always need to, the cutoff score is an indication, and the conclusion of our literature review, we say that you need to combine that, of course, with subjective examination and also have an injury history of the dancer, so you know also the compensation strategies, and then you have a better overview of the score that you get. So not only the score, but also the other elements. Yeah.
More questions? Martin?
One with the microphone. Thank you very much for this presentation. I've been your coach, and I know how much work you've done to create this. Actually, almost a PhD thesis if it comes to the amount of work you've done. So my compliments for that. I have still a question about what Bastian addressed already. Is it true that you could say that professional dancers are equal to athletes, because if I look at your introduction movie, the type of movements dancers are performing is different, completely different from other, let's say, top athletes. So is it right to assume that those are the same if you look at baseline characteristics, but also to like the type of injuries they have?
I think in terms of types of injuries, yes, like because most of it depends also which sport and athletic discipline we consider. But I think in most of the things what we found is that there are a lot of similarities in terms of physiological demands. For example, for the aerobic and intermittent training they need for strength, and that's why we also saw that many elements, for example, strength, proprioception and stuff, matched. So then that's the reason also why we wanted to include the functional testing. And also inside the screening, besides that, there is a more specific testing for dance technique, which is also important. So you have also another perspective.
Thank you. Can I ask one other question? What is, according to you, the reason that there's hardly any movement screening done, or like let's say standardized screening done, injury screening done in professional dance? Because if you look at the incidence of injuries, it's actually amazing, right? Yeah.
Old-fashioned way of thinking, and this is what now they're trying with the Dance Association to kind of promote, and this is also why dancers are not seen as athletes, but they are working. Intro-dance dancers are working every day from 10 to 5. They have 50 shows a season at least, which is in 10 months. Sometimes their physical demands is even more than Usain Bolt, because they work non-stop, half an hour break every day. So, and I think that the dance world doesn't acknowledge it, and this is also why you're now asking why the functional movement screening is good. We think it should, like, maybe now in these 7 tests is not the best way, but after doing step 4 and repeating it maybe once or twice, I think that it will be, something need to be implemented. Yeah.
Last question, short. How did the medical team of Introdance receive your work?
They liked it.
They appreciate it a lot because they didn't have a screening, of course.
They use it.
They will use it, yeah. We had a meeting last week. They will start implementing it from next season because they are about to finish the season from September, and then hopefully we can also do our follow-up study to see and check the effect of the screening.
Good luck with that.
Yeah.
Thank you.
Who did you send it to?
It's in the email, but it's also in the program. The links that I have are in it.
Put it somewhere a bit lower if you can. Where is your partner?
He is coming.
I don't know who to give that to. No, sorry.
down?
Yeah, please. Thank you. Okay, I'll go this side. Okay. Okay, guys, so welcome to our PAP presentation. My name is Peter and this is my colleague Spencer. We cover the area of concussion. So most of us here might have an awareness or some knowledge of what concussion is, and I'll go into that in more detail shortly, but first I just want to show you this image. It's quite a powerful image of two American footballers clashing heads, and you can see here how fragile the human brain is. And to give an example, imagine I had a glass bottle with a tomato in it and I was to violently shake that jar. You can imagine the tomato might get slightly damaged, and in the same way the brain can get damaged in a clash of heads. There is no natural safety belt for the brain in the skull. But also, this is a very powerful image as well. It shows, again, a real image of two American footballers with a helmet, with skull protection. But although the helmet will stop the physical blunt, it won't actually stop the brain shaking inside the skull. Another powerful image, again, it shows it's a natural response to trauma. This man obviously is after a head injury. But of course, not every sport has head protection. This image here, and also another rugby image where it shows something quite distressing about this image, but again a powerful image. But for me the most powerful image of all is this one. It's where medical professionals are coming to the player's aid, the physio and the doctor. In sport, concussions will occur, and our thesis wasn't about stopping them happening, but we wanted to investigate what should happen before they occur, and crucially what should happen after a concussion incident. Our presentation, our PAP, was concussion assessment, recognition and recovery management, and Spencer will now go through it.
Okay, thank you. So we worked alongside Physio Holland and Sports Services and our coach Martin, and we put this literature review together and this product at the end. First, I just wanted to know if anybody can shout out or knows by any chance, out of all sports injuries, what percentage of them are considered concussion every year? Anybody? Just yell a number out. Nice. Okay, it's 5 to 9, so close. And then also, we just wanted to let you know that the complexity of concussion comes from a lot of things. One of the main points is that symptoms may not occur for the first 48 to 72 hours after a concussion. So it's not just at the point of event that we were looking at, it's along the whole rehabilitation process. So for the academic side of it, concussion is defined as a complex pathophysiological process affecting the brain or from an impulsive force transmitted to the head, or from a direct blow to the head, face, neck, or elsewhere on the body that results in a new neurological sign or symptom. So that's a big, complicated definition of concussion, and that's the world's generally accepted view right now. But it just means that it's very complex and there's no definitive test to diagnose right now. So our objectives for our project was to research the most up-to-date guidelines and systematic reviews and cohort studies in our chapter 1, and then we moved along to a second portion where we did 2 literature reviews on project management and how to better implement processes to manage the whole concussion process that could take up to 3 to 6 months typically, and then finally arrive at some evidence-based objective assessment tools. So as I said in chapter 1, we did our 3 literature reviews on concussion management. Our methods for our chapter 2 was a literature review on project management topics, mostly in general healthcare, and also in concussion management specifically itself. And finally, in our chapter 3, we brought them all together under 4 major topics of concussion assessment, return to play, stakeholders, and communication. And this is just a little example of one of our results page. We couldn't show them all because of time, and it's not the most exciting part. But this is just one of our 5 literature reviews of the results we had. So by the end of it all, we got down to 28 articles that we referenced throughout our articles, or throughout our PAP, sorry. And then we had 4 guidelines, 6 systematic reviews, 4 cohort studies, and then 14 systematic reviews for project management in those 2 different categories I talked about earlier.
Good stuff. So in terms of our main findings then, based on the guidelines, systematic reviews, The recommended tests for the best tests for diagnostic tools for on and off pitch testing were these ones we see here: the Sports Concussion Assessment Tool 3, the Impact Test, and the King-Devick tests. Again, more information about that is in our product here that anyone can view afterwards. And the Sports Concussion Tool 3, that was from a couple of years ago there. There's a new one out shortly which shows the evolving nature of concussion. Another main point that we came at was concussion remains a very complex injury to diagnose, assess and manage with no universally reliable test. It shows that concussion evidence is constantly changing, so if you're in that field, it's very important that you keep up to date with the new research. And also return to play decisions, RTP, they're very complex due to both medical and non-medical factors. For instance, a doctor might want a player not to play for 2 weeks, but his coach is putting pressure on the player to play because it's a big final, and these are situations that need to be addressed. Also, due to many stakeholders in concussion rehabilitation, excellent communication is required. A trained professional isn't always available pitch side, so it's very important that coaches, players, anyone involved in the team is actually aware of concussion and their symptoms so that they can take someone out of a match if they have any concern at all that the player might be concussed. And also return to play needs to be individualized. The new idea that we had to this thesis as well was the idea of project management. So it's about stakeholders, timeframes and communication. Having a project manager, having one person in charge who has an overview of what the whole project entails is a very important aspect of it. And a structured and specific approach to individual management can then be had. So for instance, in concussion, you might have a doctor, a neurologist, other specialists, physios, all these medical people dealing with the patient, but who links them? And then you might have different teams the player plays for, his employer. There's so many stakeholders involved that need to be managed. And based on this, we had some specific recommendations.
Yeah, so after all of our research and creating the PAP, we decided to have these kind of guidelines for Physio Holland, and it's much more in depth again in this product there. So the most important part is the full education of all of the stakeholders. So again, as Peter just said, that's coaches, parents, all the healthcare professionals, so your trainer, your GPs, anything like that. If it can happen, having a medical professional, so that's your, again, physios or trainers or doctors at pitch side for every match and training session. Also, to have all of your athletes, if they do have a concussion or suspected of it, to go through a full graduated return to play protocol, which a lot of the guidelines, so the new international guideline from Berlin in 2016 is a good one to follow, as well as all of the World Rugby Associations. They all have the same thing. Also, again, the team doctor or the physiotherapist should probably be the project manager because they're going to be the most in touch with the patient and they can liaise with all the different group members. And finally, just to show you again that it's a changing process, the newest guidelines came out on May 5th, so they're only a month old. So yeah, it's changing all the time, and there's just kind of updates to the SCAT-3 of what we've already referenced. Finally, we got our product, so we got a first part, we have our overview and our assessment for return to play flowcharts. Then we also have standard operating procedures for how to use these flowcharts. And the return to play protocol, and then we have a concussion leaflet, which I believe some of you have in the audience that you can look at. And then finally, there's a concussion PowerPoint that can be given to athletes or any of the healthcare professionals involved, and that Physio Holland will hopefully be able to use. So I'll give it over to Peter now.
Yeah. So again, just to kind of, based on time again, this is one of our flowcharts, and it just shows, for instance, when a concussion incident occurs, two things can happen. For instance, a Physio Holland representative will perform an online test, on-field test. If it's negative, the player can go back to the game, and afterwards the physio will just explain to the player that concussion symptoms, it might be 2 days later that the concussion symptoms come on, so to be aware of that. Again, if it's a positive or inconclusive test, the player is taken off, an off-pitch assessment is performed. Again, there's a flow chart with this, and again, if you can kind of follow it there, different timelines. But I suppose just to quickly go through the return to play bit then, in the blue section here, the blue square, the project manager will keep a record of all the data from the concussion. He then, in the black square, full return to play will actually happen, and the project manager, the physiotherapist, can actually liaise with all the doctors, the neurologists, etc., based on our employers, whoever is needed. And then when the return to play is complete, the no or yes box, either the player can go back to play, or he needs to go back onto a certain stage on the return to play process. And it just means that one person has an overview and one person is in charge. We've also got standard operating procedures that link to this, and also the concussion leaflet that we had. So we'd now like to welcome any questions that you have. Thank you.
Somebody asked us a lovely question. Sure. Yeah.
Has this been put into practice yet, or is this was there a pilot period of the sort of operating procedure, or is it just...
No, not yet with Physio Holland. They've received it. I'm not sure if they've started using it yet. I know from working with them that it goes into like their sports services toolbox, and they have meetings every month on like a certain topic. So it should get put into that toolbox, and I just don't know if it's happened or not yet with them. We'll be meeting with the Physio Holland people this week sometime, so I can ask. Up at the top.
Considering you know the consequences of a concussion, and there's a certain limit that a human brain can withhold over time, has any of these guidelines, or has anyone actually come to a statement saying maybe we should not play any contact sports?
So that's the big question, and this is why, like for instance, SCAT5 was released recently. It's constantly changing. The area is so complex, and so there's different advice out there. But again, it's up to everyone if they want to play sports. There's, it's a very individual thing. It's a hidden injury. You simply don't know, and very often concussion can be subclinical as well. So the simple fact is there isn't a test available at the moment to say definitively yes or no. And of course, the illustration we gave with the glass jar and the tomato, particularly over time, the brain can get damaged. And there is a different disease called chronic traumatic encephalopathy, which is actually kind of a disease that gives dementia-style symptoms. And that's been linked to a lot of NFL players who have had a career. But again, the evidence is quite new, is always changing on that as well.
Thank you very much for this presentation. I've been your coach, and I know that both of you have a business administration background, a business management background, I have to say. And I think the innovative part of your thesis was that you implemented a project management approach into your method section, and that deserves some more explanation, especially to the field of healthcare. What would be your recommendation with your background as business management people? How could that project management approach be applied in healthcare in general?
In general? Yeah. In general, it all comes down mostly to the environments you're working in. So even our frameworks, they can be used by a private practice physio who's working with outside other massage therapists, doctors, and it's mostly about you just need to have your communication set up and be working on the same level of your assessment, so you don't have your doctor assessing just balance and do you have a headache and your physio's doing a whole bunch of eye tests, and so you don't have overlapping data. So it'd be mostly communication within whatever group you're using. And it's also a big thing of informing your coaches and the parents and getting them in the process. So who is responsible for that in the process? Is it the doctor or the physio? So setting a key knowledge broker, the central person, is very helpful in dealing with all these people that are involved usually. So
That's what you've done here in the concussion-specific area as well, because there are many stakeholders present, right?
Yeah.
This whole
approach. Yeah. So that's why we think the physio should just be the center, and then they can follow our flow charts and through the standard operating procedures. There's a more in-depth, step-by-step guide of what they should, who they should contact, when they should. Yeah.
Thank you.
Do we do anything with that?
That's it.
Set it up. Hold this. Yeah. Yeah. This. No, otherwise it's too close. Otherwise. You send it to Papa?
No, we have it here.
Oh, you have it here. Okay. Go ahead.
Yes.
Pet presentation, final. Yeah, I just need to check.
Are the mics on? I don't hear myself from the panel.
It won't work with the PowerPoint. What? Oh no, it should.
Yeah, it should. It is. I can see it.
Yeah. Still seeing it? Fingers crossed.
We'll just wait for our coach. Janneke, good Bob is going. Come over.
Can you actually watch the YouTube video back?
Yes.
Where's your receiver?
To the back.
Yeah. Just show it me.
Well, this is awkward.
Millions of people watching.
Mm-hmm. In that case, I don't give any permission to show this on YouTube. Shit.
She's here, huh? Yeah.
Oh, she's here. Oh, welcome. Hi. Okay, so welcome everyone to our presentation. This is Bram Daan and I'm Lester Bakker, as you might know. We will give you a short overview about the presentation. Our coach is Janneke de Vries, sitting right there. Our client is Shinta Maarten, who could unfortunately not be here today. And our overall topic is lumbar segmental instability. So it started all with a discussion with our client, and a few questions came up. What is and what significance does lumbar segmental instability have within physiotherapy care? How can you diagnose lumbar segmental instability? And what are the most accurate diagnostic tests when compared to each other to diagnose lumbar segmental instability? Just to make it a bit easier, we had the question, what are the available diagnostic tests to diagnose lumbar segmental instability, and what are the most reliable tests of these? So how did we answer these questions? We did three things. First, a theoretical and background research. Then we conducted a systematic review. And out of this information we've received, we developed or translated this into a practice protocol. So a bit more about the theoretical background. You often hear people say lumbar spine instability of lumbar segmental instability, and there is a difference, and we need to explain this before we continue with our presentation. Lumbar spine instability concerns all three subsystems of stabilizing the lumbar spine, which is the active one concerning muscles and tendons, the passive one concerning ligaments, vertebrae and facet joints, and the neuro control subsystem. Lumbar segmental instability is only concerned the passive subsystem and only looking at a certain segment, so not the complete lumbar spine, but maybe at like 2 vertebrae, and is concerning the ligaments, vertebrae, and facet joints.
Now, when deciding to assess for lumbar spine instability, you first need to determine what you're assessing for. Now, we just discussed the 3 subsystems. You're either going to assess for the active subsystem, the passive subsystem, or the neural control subsystem. Now, this just to give you an idea, our PAP focuses on clinical diagnostic tests that are aimed at lumbar segmental instability. In other words, the passive subsystem. Now, before we get into clinical relevance for us and as fellow physiotherapists, I'd like you to maybe see a show of hands of how many of you actually know of any diagnostic tests for lumbar segmental instability. Just a quick show of hands.
Just raise your hands.
That you could use as a tool as a physiotherapist in a clinical setting. All right, a few of you?
Few,
good.
Not too many.
Well, to date, one of our biggest motives for this PAP was, to date, there's no research or there's no actual paper that states and that has compared all the available diagnostic tests that are out there in one and compared them according to their diagnostic accuracy to actually tell us what the most reliable tests are. Now, we all need tools as physiotherapists in order to rule in or rule out our hypothesis. Now, most patient complaints we see as physios are low back pain complaints. Now, it's known that LSI, lumbar segmental instability, is a cause for low back pain. Now, we wanted to provide physios with the correct knowledge and correct tools on what tests to use that are the most effective. Now, to understand the biomechanical and biopathological knowledge concerning the cause of a problem allows one to make a more specific and effective treatment plan because you know what direction you're going in. Now, therefore, knowing how to diagnose a known specific cause for low back pain is actually very useful to determine your treatment plan. Now, our systematic review, we did a research over 4 online databases. Now, this was to give us and allow us to compare and evaluate all these tests that are out there based on their diagnostic accuracy. Now, the diagnostic accuracy is determined by one's sensitivity and specificity, positive and negative likelihood ratio. Now, this led us to allow us to make a conclusion and for us to state what are currently the most accurate diagnostic tests out there for lumbar segmental instability. Now, just an overview of our methodology. Kindly refer to our PAP poster if you'd like to go in depth, but it just shows we had to cover 42,802 articles. In other words, a lot of reading. And we only came down to 4 that actually met our inclusion and exclusion criteria, and based off duplicates removed, we came down to 4 that we used in our results. This was a summary of our results table. These 4 articles presented with a total of 14 tests that are currently out there that we can use. Now, these tests presented with their sensitivity and specificity values, positive and negative likelihood ratios, and remarkably enough, the comparative measure each of these clinical trials used were all identical from Punjabi et al. Flexion extension radiographs. Now, based on our discussion and our whole thesis, we came down to a conclusion of 7 clinical tests that we believe are the most accurate out there for lumbar segmental instability. Now, this is just a table. Lester will go into more detail about these tests, but this table just shows you an overview of what currently tests you can use that are most accurate. Seems simple enough? Not really. Now, there is currently no golden standard to diagnose lumbar segmental instability, so how can one actually compare the standard of a test to a standard that isn't regarded as the best? So how do you compare how good your test is? Now, this also makes it difficult for new upcoming tests or people that develop new tests to be compared and evaluated. Each clinical test that we found, so all 40 of them, has only been clinically tested once. So we could not compare the results of one clinical trial to the same test results of another. Now this, it just shows the limitation in the research that's available. The research and theory that surrounds lumbar segmental as well as lumbar spine stability varies, with no consensus to an actual true definition as a whole what lumbar segmental stability actually is. Now this made it extremely difficult for us to actually come down to a search string that would lead us to the most accurate search results to provide us with the correct information. Now Lester will discuss our product and what our product entailed.
Yes, so what is our product actually? It's a practice protocol designed for Shinta Marta, our client, based off the conclusions of our systematic review. The outlines and the necessary information of every diagnostic test we found or selected are mentioned, and it's a HOAC2 based approach. So it helps you with the clinical reasoning behind the diagnosing of lumbar segmental instability. Why is this product useful? Well, it's very easy access to information. You can share it easily amongst colleagues. And it provides you with a clear pathway on diagnosing lumbar segmental instability. So, a bit more about HOAC2. Some of us might know it already, some of us don't. HOAC2 is a sort of pathway or steps you take within the clinical reasoning process, which starts with the collection of initial data. Then you generate a patient-identified problems list, also known as the PIPS list. Then you formulate an examination strategy, and then you conduct an examination. Now, the conclusions from our systematic review perfectly fit into conducting this examination, and that's also the main focus of our product. But the other steps before are also described. Good. The 7 tests. The first 2 are the passive lumbar extension test and the midline seal sign. According to their accuracy values, they can be used to rule in and rule out lumbar segmental instability. So that's why we categorize them together. The next categorization is the one of the interspinous gap change during lumbar flexion extension and the prone instability test, which are used to rule out according to their diagnosis values, and the PIAVM and the PPIVM extension and flexion are used to rule in. So that's kind of the setup of how we describe this test and in our product itself. Per each test, we have a table looking like this. You will see an image of the start and the end position. Instructions will be described. Also, a positive indication is described. Then the statistical values are described as well. So the outcome of the test will you can immediately see what this outcome means for your diagnosis. And then if you want to read a bit further into depth about these tests, the references are placed as well. So then you can look it up and read all about it. So this is just a sneaky preview of our product. So I recommend to look up our product, definitely, to have a complete overview.
I would just like to give a special thank you to Janneke de Vries for being our PAP coach and guiding us through our PAP. Shinta Marta, who's unfortunately not here, for being our client and giving us the opportunity to do this research, and then Boston Joker for being our second reviewer. Please do not hesitate to throw us with any questions if you will.
But not too much. Yeah, Bastian.
Yeah, thank you first of all for the presentation. I was just wondering, because I've read your paper, but I was wondering if you could tell me anything about the quality of those studies that you used to actually make the decision, we take this test into our toolbox. Because you, correct me if I'm wrong, you said that per test only one study has evaluated the specificity and sensitivity. So I was just wondering whether you could give us any input about the actual methodological quality of those studies.
Yeah, so we selected the test obviously also under accuracy scores, and if there was just one source, we had to deal with these scores. But for example, for one test, I think it's a Bayesian scale, which had within that article had a very small sample size. So then we thought like it doesn't really represent the population, so therefore we decided to cancel it out. So in that way we we made the decision to select which test and which not.
So it was a combination both on the theoretical aspect as well as how the clinical trials were actually performed and how many participants they used, the blinding. That's what we decided to use the Pedro scale as our quality checks, also to further rule in and rule out certain articles. But deciding upon which tests definitely looked at the methodological quality of how these clinical trials were performed, and that took into a lot of account how many assessors were there, how was the blinding, how many participants for each test, how were the results actually calculated, and then it also came down, so it came down to both interpreting the methodological approach as well as just the actual results they got. That's where we came down to our decisions.
Kai.
Did you choose a certain cutoff value or something to make the decision for ruling in or ruling out?
That's because there's no golden standard. We couldn't really decide how we were going to select according to what is known to be good and what is known to be bad. So we looked at the total amount of tests we had, and based on the points we just mentioned on the methodological approach, we actually came down to our own subjective decision based on our own knowledge on how a clinical trial should be performed, on what 7 tests should be in our conclusion. So we didn't have any specific cutoff values.
For the Pedro scale, for example, we did use like the ones with scored 7 or higher.
We did have a quality check for the article itself, but for an actual cutoff value for the values, the statistical values, because there's no golden standard, we couldn't come up with that.
Which is also one of the limitations, of course. Yeah.
All right, I guess.
Good.
I know.
Oh, sorry.
Yeah, don't.
Leave your notes on your phone.
Job, bro.
You send it to.
It's available on the drive as well. It's public.
We had it like.
I feel like I'm giving a TED talk.
The hands?
Yeah, I gotta use the hands.
All the hands.
Preparing for
Are we still Andreas? Andy?
He's busy in his macros.
Yeah.
Thank you. What's up, man?
Good.
Do we just start?
I think so.
Or do we wait? Oh, we should ask.
We good?
Let's go? Okay.
Hello, everybody. I'm Nick. This is Jason. Our studies on acromioclavicular joint diagnosis and rehab. In the past 3 years, Jason and I have both worked directly with Physio Holland and Sports Services and have kind of been able to see a lot of injuries with rugby, and that's kind of how we've come across our PAP project, our PAP. So then we had this little video.
Take the music off. Take off the.
It's not on.
Take off the sound.
So this kind of give you a little bit of an intro to the force of rugby that can happen. Some pretty good hits, and there's a lot of force that goes into those specific hits, as you can see right there. One more.
All right, yeah, so going into the forces, just going to throw some numbers at you guys. So the tackles have been measured at over 1,600 newtons, which is quite a bit of weight between bodies. The rate of injury has been recorded as high as 9.4 injuries per exposures. So per game, these are serious injuries. These aren't like lightly sprained ankles, cuts and bruises, stuff like that. And then of the injuries, 48 to 72% of these injuries happen from tackles. Not surprising. And then there's no actual data on shoulder injuries in total that we could find that was reliable or what have you, but of the amount of shoulder injuries, 30 to 40% of them are acromioclavicular joint injuries. So rugby players are really good at hurting each other. What do we do? What we wanted to do was create a diagnostic and rehab protocol to kind of follow each other up. We wanted to base the diagnostic protocol off of the Canadian C-spine rules, Ottawa ankle rules, and Ottawa knee rules. So just to give you an idea, the Canadian C-spine rules have a 95% negative predictive value, meaning that if it's all negative, there's only a 5% chance that someone actually has a severe injury, which is really nice. So that being said, we started a systematic review. We started out with 1,600 and change articles, and we ended up with 5. What's important to see is the criterion and reference standard. So it's all kind of different. There is a gold standard, which is AC joint injection, but unfortunately, only 2 of the articles actually had it. Right? But the other ones have been proven to be valid, and there's lots of kind of support behind them, which is nice. But it's also important to see the sample sizes are quite small, and that the quality was moderate to high in all of these studies, except for one, which was O'Brien, but we'll get into that perhaps a bit later. So these are our results, just to kind of show you guys what we dealt with. There were lots of kind of sporadic results across different tests, right? Not a lot of these studies actually reference their own reference standards in their study, which was kind of annoying, so we actually had to find our own, kind of clouding the entire field a little bit more. What we also found was that different studies classified different things. So we had acromioclavicular pathology, and then we also had abnormalities. So it's kind of important to distinguish between. But this is, just to kind of give you guys an idea. So what we did, we threw them all together, and we made this protocol. It should be done in less than 5 minutes. It's fairly easy. They're all manual tests. The only thing that we don't have is any kind of evidence supporting this. So this is just kind of a trial, right? So this isn't based off anything. We don't have any ratios or any kind of likelihood ratios or anything of how sensitive or specific or how effective this will be. Just kind of threw it together. So what happens is someone gets injured on the field. We come in and we have 2 specific tests to rule them in or out. And if you have if both are negative, then they can return to play immediately. If one or more is positive, then you should take them out of play. And what we recommend is more testing, right? So then you can really be more specific with what's happening and what have you. And then after you do the next 4 tests, then you decide whether they should stay in play, leave play, go for a radiograph, things of that nature, right?
Cool. So then based on what Jason finds in the assessment, and we can determine if they did go back to play, then we don't have to worry about the injury. If they did in fact have an injury, then we want to determine their rehab process to get them back to play as fast as possible. So similar to our review for the assessment of AC joint injuries, we did a separate review for the conservative rehabilitation of AC joint injuries. So in this, we found 3 systematic reviews and 4 cohort studies. Within the systematic reviews, there's a lot of differentiation and confusion when it comes to the specifics to good rehab, what is supposed to be included within it, what is not necessary. But Reed et al. Documented the most, brought forward a best practice guideline. So it has as we'll see in the next slide, it kind of breaks down the rehab process into 3 different stages, which we used in our rehab protocol or guideline. And there's nothing specific in what exercises should be used, what treatments should be used, but they give a good basis of what they believe should be implemented. Then within the cohort studies, that's when they have some specific therapies or use of tools. So Petri Shaw et al., they used just a sling for 3 weeks. This kind of implements, it showed what their rehab, their timeline for recovery would be just with this sling. So there's a lot of indications, stuff like that. But then within those 4 cohort studies, there were specific outcome measures that they could compare, that we compared them towards. So pain, strength, movement restriction, pre-injury activity level after rehab, and then there was a couple screening forms that they used, or questionnaires, such as the Quick Dash, in order to determine the patient's views on their own injury. So using all this information, we came up to our own conclusion of a guideline that is specific to AC joint injuries in certain phases of recovery. So within the acute phase, we see that sling or immobilization of some sort within the first week for up to 7 days is beneficial to recovery, as it allows the healing process to occur. Active assisted range of motion and passive range of motion to decrease the amount of restriction caused by scarring and tissue healing and everything. And then moving forward into the rehabilitation phase, it's a lot of scapular rotator cuff strengthening, proprioceptive exercises that we were able to get from the Coborn. They did a study on AC joint or scapular dyskinesia related post AC joint injury. So there was a lot of scapular dyskinesia within people that had previous AC joint injuries. So we inferred clinically that if someone has an AC joint, they could progress to scapular dyskinesia, and thus we took most of our rehabilitation phase exercises from that study, and then clinical reasoning from our work with rugby players already. And then the specifics to rugby in our final return to sport, it's all exercises that we found in separate studies that weren't necessary, we didn't include within our results, but using clinical reasoning, we're able to include them based on our knowledge and the knowledge that has been presented within the extra studies. So from this, we hope that Physio Holland can now try to implement our screening tool and our rehab guideline to help the rugby clubs that they will be working with, ARC in Amstelveen, AAC up in the north, and then Rugby Hilversum. Those are some of the clubs that they have worked with so far, and it looks like hopefully that this will speed up their rehab process and get them back to play even sooner than what we have seen so far. Does anybody have any questions? John?
Did you differentiate between the different injuries and different treatments that the AC joint, like an Amputee AC joint, or was it just like a broad, this is what you do in an AC joint? And if that is the case, then can you describe what an AC joint injury means?
So within the rehab, we focused on, based on the Rockwood scale, it's determined based on some criteria that 1, 2, and 3 Rockwood scale is the least, they say least significant injuries, where there's not as much, or the least amount of tissue damage. So the majority of our rehab protocol and conservative rehab is based on the lower, less drastic injury, so they don't have to go into the
Yeah, no, I think I could take it over. Yeah, so all of the studies that we had none of them were. So the people that were included in the studies had pain with movement, some abnormalities, but no like full tears or anything like that. We had one study where they had a couple of, I think it was grade 1 or grade 2 AC joint separations, which was nice, but they only had like 4 people. But for the most part, it was classified as abnormality. So if people had localized pain in the AC joint, and then were diagnosed with it using one of the reference standards. So it wasn't like traumatic injuries for the most part. It was mostly just painful shoulders. Yeah.
As for your implementation or Physioholland implementation, what is your recommendation? Can they use it, the diagnostic tool, right away? Is that good to go, so to speak? When it's hand to students?
Well, I think that it kind of depends on what level you want to implement it at. So there's obviously not, I guess we've spoken before because you were our coach, there's obviously not any kind of evidence to support the specific testing, but at the same time, there's not a lot of other tests. Well, there are other tests, but there aren't a lot of other things that you would do in these circumstances. So I think that it gives students a nice framework to work with, and I think that we would recommend implementing it, just with the asterisks. Yeah, there's not a lot of supporting evidence, but that being said, all of these tests are evidence-based, right? Right. So.
And then we also have within our product, we have instructions and visual aids to
user manuals. Yeah.
User manual to help with the implementation of this in a learning environment, which Physioholland has with the sports services.
Yes.
Anybody else?
No? Okay, cool.
Are we on time?
We're ahead of time.
Whoa! It's because the transitions are going.
I can use that for.
Yeah. Yeah, and you can put this into your neck.
Yeah, there was.
Should I put it on? Should I put it away?
Okay.
Shall we check the?
We are far ahead of schedule. So
Let's check the.
take your time.
Okay.
It's also not.
Yeah, we have some
doesn't
time.
make sense to start too early. So.
Okay.
You send it to Bob?
Yeah. No, to Buzz and Bob. Yes, true.
Yeah, both.
Both.
And it's also in the program. And with the right link.
You put?
Yeah.
Okay.
Something important, right?
Yeah, we could say something about Physioholland as well.
No. You've heard them enough.
Okay, so good morning, ladies and gentlemen.
Is your coach here?
Yes. So we would like, my name is Ksenia and this is Eva, and we would like to present our professional assignment project that's called Aquatic Therapy on Chronic Stroke. And we will start. So what and why? The purpose for this project was to create a practical guideline for working physiotherapists and their students, aquatic therapy for chronic stroke. Due to several reasons. Because it's relatively new modality, neurorehabilitation, and there is a small amount of evidence spread over the databases, and especially particularly on chronic stroke. And those RCTs that are available, they are covering one limitation and never complex multi-pathology patient. research. And also, currently, there is no practical guideline or collective review available, particularly again on chronic stroke, because majority of them are created for fibromyalgia, osteoarthritis, athlete injuries. And due to all these reasons, the working physiotherapist requires a lot of time to spend on personal research and critical analysis of on the effectiveness of aquatic stroke if he wants to implement this intervention in his rehab program. And due to the fact that aquatic therapy has a really broad rehab potential and it has a lot of water benefits that it can provide that will be overviewed afterwards, it is really important that people have easy to read, ready to use course, just a manual for practice. And it was also a client request that is based in Lithuania, and he wanted to use this guideline in his practice where there is no aquatic guidelines at all being developed. So this was also the request for the client to compose such a guideline. And because everything needs to be evidence-based in our field, that's why to compose the guideline, we needed to conduct the systematic review. And so we did this. So our thesis was called The Long-Term Effects of Aquatic Therapy on the Functional Recovery of Chronic Stroke Patients, Systematic Review. The stroke is the major cause of death and disability worldwide, and 60% of stroke survivors are moderately impaired, and they all would benefit from functional rehabilitation. Only 25% return to the level of daily participation compared to the same age community members who haven't had any stroke. And functional recovery tends to show a plateau in subacute to late rehab phase, and therefore the training on the functional recovery should be emphasized in chronic phase and well maintained as a long-term repetitive training. Also because based on some research, it tends to show like a great improvement if it's addressed well. So that's important. Also, patients show barriers to dry line therapy, such as fear of movement, decreased safety awareness, decreased balance, so it can prevent from acquiring their full rehab potential, and therefore some new interventions should be implemented, and it can be resolved by addition, for example, of aquatic therapy. And there are a lot of aquatic environment benefits, such as water temperature that is tolerated by people in any pain level, that is reducing muscle spasm and facilitate the relaxation. Buoyancy is offering the postural support, decreasing the overload on the joints, and allows the easing movement of the hemiplegic side. And the hydropressure is making the massage effect and eliminating muscle soreness by decreasing the vascular movement, and have a lot of effects on that. Then further we go to explain better the functional recovery, the main outcome why that we are basing our systematic review on. The functional recovery is used as an umbrella term for 5 limitations in this review, and is defined as independent abilities for self-care, ADLs, and walking. And we present several, to be clear, 5 limitations. So spasticity, mobility, muscle strength, balance, and fatigue. And we believe that improvement of all these 5 limitations will facilitate the functional recovery in the rehab. And to make it more easy to understand, we provided some short examples of goals to eliminate these problems and therefore contribute to the general functional recovery. So it goes step by step. So we will start from decreasing the spasticity and then moving into mobility, building up the muscle strength, improving the balance that is all correlated with muscle strength, and decreasing the fatigue levels, because this is important for the duration of and intensity of the training.
So now we'll tell you something about the methods part. Our research question, first of all, is what are the long-term effects of aquatic therapy as a part of rehabilitation program on functional recovery in chronic stroke patients. We also answer the sub-questions. Does aquatic therapy improve the cardiovascular fitness and the psycho-emotional state? Important for us was that we grade all articles with the Pedro scale and that our cutoff point is below 7. There you can see our inclusion and exclusion criteria, where the most important was that the articles are relevant to our picket items, the study design, language and recency, and that all articles compare to land-based therapy. Going over to results, we ended up with 8 articles, which an overall Pedro average from 9.6, which was really nice, I think. And all articles cover 2 to 3 limitations, and so they all show statistical significance. In the next table, you can see the individual study characteristics, such as frequency of intervention, number of participants, or clinometric tools. It's just a nice overview to see the outcomes. The next table groups the articles by outcome, including the clinometric tools. For example, for the specificity, all articles we shown the specificity used the modified effort scale, and with the other outcomes it was a bit harder because they used all different tests.
Okay, jumping into discussion. So the discussion itself was very extensive and thorough, so we shortened it as much as possible, and we are overviewing the general discussion points. So apparently it appeared that statistical significance is not always the clinical significance of the results, and we face this problem because despite all the positive results that we have found, that all the outcomes in the studies that we have selected had statistical significance, when we were analyzing between group differences, it appeared that only minor superior improvement was of the aquatic therapy compared to the control group of the dryland therapy, creating the room for discussion which exactly approach would be clinically significant and making the right effect in practice. So based on that, we based our choice of studies and exercises for the guideline. So the most clinically significant and relevant studies and its outcomes were chosen for our guideline that we are going to show later. And but it was pretty subjective because all the studies had different measurement tools and different setting of therapy. So our difference and comparison of these results was based on our subjective and some of the objective, of course, consideration. The combination of aquatic and conventional therapy was proving to be very effective by 3 articles, especially in limitations of muscle strength and mobility. It's proven that the most effective is the combination of aquatic and dryland therapy for the better outcome. And another discussion point is that there was some different magnitude for one limitation group, so let's say, but it was for spasticity and modified Ashworth scale, but it was all based on different duration and intensity of the project. So there were also some sub-questions as cardiovascular and psycho-emotional benefits. You can quickly see that this guy has well-developed cardiovascular system and is also very calm and in harmony with himself. So we can see that water is providing a lot of nice benefits. Quickly going to our guideline, since we like to talk a lot. To quickly overview the guideline, we created a flip book just to show you what have we done. So here it is, our guideline, aquatic therapy in chronic stroke. Just to see about the content and about the exercise programs that we have there. So it's written in very understandable way for students that are studying this and for physiotherapists that are working. So we included the definitions of stroke, aquatic therapy benefits of water, the very important thing, the contraindications, precautions, and patient safety parts, cardiovascular conditions, because it was one of the sub-questions that should be really addressed accurately and precisely. Pool environmental settings, all the environment and practical thing to set up, and exercise program. We started each of 5 limitations plus warm-up. We have 3 levels of progression for each of the exercise program, trying to be creative but as well based back on reality about the condition of our patient population. So it all should be adapted to the particular patient condition, and what we want to emphasize that it's never unified, it should be always adapted. Mobility, spasticity, muscle strength, balance, fatigue, so some cardiovascular references. So yeah, here it is. And some of our conclusions, that all in all the choice of inclusion of aquatic therapy to rehab program of chronic stroke patients has very strong evidence and will definitely facilitate the recovery of function, as well as improving the psycho-emotional state, cardiovascular fitness, avoiding the further cardiovascular problems, and all the 8 included studies showed significant statistical significance. Sorry for that. So yeah, that will be our conclusion, and we believe that our guideline is pretty relevant for our profession and is easy to use for any of the users. References, media references. Thank you. Any questions?
Yeah.
Yes, please.
In your research, did you find that hydrotherapy has to be a one-on-one, or can it be more of these exercises with the chronic stroke population also be kind of in a group?
It was a nice thing to consider, because group trainings is the thing that is mostly improving the psycho-emotional state. So we would advise to use the group training for like increase of socialization of people, and that they see that they're not alone, and it improves the depression possibility. Yeah, but also like it's advised to have one-on-one session with extremely hemiplegic, imbalanced patients and those who really need supervision one-on-one. And then also in guideline we said that assistance sometimes required for those patients if, let's say, the environment is not allowing one-on-one, but let's say there are 5 patients in the group, but then a very severe patient has an assistant next to him who is explaining and supporting and providing the safety.
Any other questions? No?
Yes?
How likely is it, let's say in Holland, for example, that people have the facilities?
Yeah.
Well, yeah, not each practice has their own pool, but there are, I think, a lot, because it's a lot of hospitals have pool settings, so you can just choose to go there.
It can also be just, let's say, if making this as a business idea or whatever, it can also be communicated with the public pools that have some open hours or some hours for training. So I don't think it's a problem to find a pool in Amsterdam that has 1 or 2 hours free each day to organize the private session and then invite your patients there, or one-on-one even easier. So, well, some of the rehab centers and hospitals are emphasizing the presence of swimming pool there, and that they have these facilities, and therefore it's like actually it's getting more and more spread and popular that facilities have a swimming pool. But I think if they don't possess it, then they should have some communication and collaboration with local pools.
In my experience in Holland, although we have water enough, of course, is that it's pretty hard to rent a pool for an hour or 2.
Yeah, I don't know how it is in Holland, but when I went to Austria, they had it was a hospital and a practice next to it, and they had a pool. And I think it's I'm not sure how it is in Holland, but I think it's really helpful.
Yeah, it could be, because in Malta, during the internship as well, our pool at the facility was more used by private trainers and physios than by the members of the team, because it was constantly just booked, but maybe it's just a business matter, but it was always booked for private sessions, and then physios were bringing their own patients there, like physios from outside. So, well, and in Lithuania as well, so I haven't faced the problem of finding the facility. It's all about money probably, and the country itself.
Yeah. Israel is also known for its therapies. And Holland, not that much.
Okay.
Water's the goal. Okay.
Anything?
No? Okay.
Good. Thank you very much.
Here. Is it alright? Can you hear me? Okay, perfect.
Monday, Tuesday.
Monday, Tuesday. Yeah, we're here.
Should do it.
Can you hear me? Yeah.
Okay.
Apparently.
Oh, send it?
I did. Yeah.
Send under no subject. Yes, every good student.
Minutes.
Yeah. I think we wait a couple of minutes, or?
You're in a slow, smooth way.
5 minutes.
Let's wait a couple of minutes.
this button? Yeah, it works now.
That works.
Yes, 1, 2. Yeah, we're great.
Good for the live stream.
Shall we start then?
Well, welcome everyone. We are Martin and Matthias. Welcome YouTubers. Welcome Mom. We'll be talking, as you may see, about Kinesiotape. You know probably those colored band we see on many sports players. It's quite a new trend now. And we realized a randomized controlled trial as a pilot study.
Okay, we're going to start with the client here. Then we'll go a bit deeper in the clinical relevancy of the project and the methodology, the results, and the conclusions. Okay, so first, the client. So we work with the CTR, which is a placement, an internship placement that some students might know. I know that Jacqueline here knows it. It's a part of the Erasmus Hospital, which is in Brussels, and it's specialized in traumatology and neurology, most of it. So, because we were working with stroke patients, that was an ideal placement. We were working, oh sorry, I had to come back. We were working with Caroline there, who was the spokesperson of the CTR and who was also a supervisor for the PAP. Before anything starts, we had to go through a tough ethical committee approval. We had to submit a lot of papers, so for those who would like to do that, you need to prepare a solid project proposal because we had to think of it before starting everything. So get prepared if you want to do such a research.
We'll get into clinical relevance of the subject. So as we said, and as you may have heard before in different presentations, we targeted stroke patients, which is a rather worldwide cause of disability. It's the second worldwide cause according to the World Health Organization. And it causes about 5 million of permanently disabled people per year. And within those people, 8 out of 10 stroke survivors suffer from hemiplegia. And in hemiplegia, shoulder pain is up to 72% of those patients, big problem. And in this category as well, we focus on glenohumeral subluxation because the most recent literature said that this is the most contributing factor, despite some controversials that remain in the subject. So this is the main target group we focused on, and the new intervention we approached because of ineffective strapping and slicks technique, as you may have heard of Homotrain Barrefine, sorry for my German, and other slings. Those have been proven ineffective in the literature. So we thought about the new way with the new trends of the Dr. K's tape, colored, and it's nice, elastic, and composed of several tape we applied together on one joint, as you can see on the photo here. And it's based on the MTC manual that you can see the photo here.
So that's not exactly the montage we realized, but it shows a bit what it looks like.
So because slings and tape have been ineffective to tackle the issue in a systematic manner, we decided to investigate the effects of Kinesiotape.
Okay, so we have a research question here. That was our research question. So we have the pie-cut method that shows up with the bold words. So basically, our question was, is Kinesiotape during 6 weeks an efficient way to reduce shoulder pain and improve ADLs amongst this post-stroke population? So we're going to go through the methodology. So the general procedure we did, we're going to start with the recruitment procedure, which is of course the beginning of any study of that kind. So we started with 117 inpatient at the CTR, which is the whole population. And after applying our selection criteria that you can see here, I'm going to give a few of them after, we ended up with 14 eligible patients. So the patient had to be at least 24 hours after the strokes, so it means not in an acute stage, but rather in a subacute or stroke or chronic stroke. And they had to be referred by the facilities GP and by the physiotherapist in charge of the treatment. Major inclusion criteria were shoulder pain, decrease in activities and participation, and in range of motion. A positive load and shift test that you can find on Physiopedia, or the physiotutors present here did a small video about it. So the load and shift test was to determine the glenohumeral laxity in order to evaluate the subluxation present. The main exclusion criteria were the exclusion of patients with post-rotator cuff injuries, which might bias the study. After the recruitment procedure, Matt realized the anonymization and the randomization of the patient so I can be blinded. The whole goal of the procedure was to realize a single blinded RCT. So Matt did this so I can do the data collection with the assessment. So both groups were following the same treatment, as you can see here, except that the intervention group was given 5 days a week of kinesiotape treatment. So to show you how it was working, basically, this is the kind of time schedule we could have during a week. So I was taking the data collection on Monday morning, then Matt was spending 15 minutes with the patient to apply the tape or not apply the tape. The goal was so I was be blind, basically. And the Friday was the opposite way. So Matt was spending 15 minutes with the patient to remove or not the tape, and I was spending 20 minutes with him to do the data collection. Unfortunately, due to time restriction, we could only spend 9 weeks at the facility. So after we had 14 participants, we made them sign the informed consent, which resulted in only 8 participants, and we had 1 dropout. So at the end, we had 7 patients to analyze in 2 different groups. So you can see the descriptive data here. Unfortunately, due to the poor amount of people we could recruit for this study, we consider the statistical significance not reached.
I'll run you.
That's all right. Okay, the data collection, we're going to speak about clinometrics. I know you guys like that. So first, the classic, the visual analog scale, which shows that it was something reliable to evaluate pain. So the basic question was, in the last 24 hours, how would you rate your shoulder pain? 0 being no pain at all, 10 being the worst pain possible. And we also used the SPADI, Shoulder and Pain Disability Index, a complicated name, but it's definitely a handy tool when it comes to evaluate 2 major parts of the rehabilitation, which are pain and functionalities. And especially the fact that it holds in only 1 piece of paper. That's definitely handy, and you can print it easily. We also evaluated the active range of motion, so we can assess the general motion, active motion of the patient on the overall articulation, the overall joint. We follow this using the hemiplegic shoulder pain pattern. So flexion, abduction, and external rotation. After this, we realized an ANOVA following SPSS, comparing variances between groups, and we use Excel as a support for the data.
I'll run you quickly through the discussion and the results. So we first looked at the pain levels with the VAS and the SPADI pain score. We can see that the intervention group showed slight trends of improvement more than the control group, and it remains trends because the statistical relevance was not achieved, as Martin said. We can also see here different ranges between the results here. I'll discuss them further. We looked at the functional levels, and here we had more interesting results because the trends showed the intervention group to have a better difficulty reduction and improvement in general active range of motion. However, if you look at the trend, they're quite similar. The baseline is different, so to be careful with those results. That led us to investigate further on each patient and the trend they showed between the first day and the last day of the 6 weeks, and compare this data, and we clearly see that there are differences in baseline, there are differences in improvement, especially the pink one, patient number 3 over there, or the patient number 2 down in difficulties. So we had a thorough discussion based on literature, based on expertise from our clients. And this led us to have some different limitations. The main one was the sample size, as already mentioned for the statistical analysis. We had less than 10 patients, so we could not achieve statistically relevant ANOVA with the statistical package. Moreover, we found different confounding factors, as shown on the graph before. Walk you through quickly, but we can see different stroke phases among the participants and also concurrent treatment at the facility, because not the same physiotherapist was involved in treatment of the same patient. Different physiotherapists had an input. Moreover, placebo effect was not investigated, and as physiotherapists we know that it's quite taking a big part of the treatment. And I cannot say it more, time was the biggest limitation we had. Only 9 weeks to run all the experiments and recruit the patients, etc., etc. And we also, fun facts, accumulated together 30,000 kilometers and more than 25 meters of tape. So, some recommendations from all this discussion and results. We had a 6-week intervention with the measurements every Monday and Friday. And we strongly recommend, because this didn't show any relevance in the end, to do the baseline measurements, have a midterm at 3 weeks, and a follow-up after the 6 weeks of intervention. Also, another point was to report spasticity. We didn't take it into consideration because we had exclusion criteria that was a total flaccid limb. So we changed a bit the research and also report spasticity to investigate this confounding factor. And amongst other, anticipate the other confounding factors as the procedure with one physiotherapist and the same shoulder treatment and procedure rehabilitation, and limit other concrete treatments as said. And that's especially for the CTR, that is our client, and that will go into our product. And then we made some suggestions that are more general to the scientific world and other physiotherapists that are interested in this topic. And we strongly recommend then to do an RCT with 3 different groups investigating the placebo effect, KT tape, and a control group without Kinesiotaping. The statistical analysis, we ran a power analysis before starting everything based on different and recent studies using the standard deviations. And we showed and we found that more than 16 participants per group should be at least present, whether we have 2 or 3 groups, to show correct effect size of the sample. Additionally, the multi-professional approach should be considered with physiotherapists acting with neuropsychologists or speech therapists to investigate further the communication of each stroke patient, as you may have heard of aphasia and other communication issues. And lastly was to target a specific stroke phase. We firstly targeted subacute and chronic to be able to recruit more patients, and it turns out that is one of the confounding factors. So next research should be focused on only subacute or only chronic patients. Yeah. And we recommend subacute patients.
Yeah, and as we've shown before, I mean the research before, like Xenia or even Tani this morning, said that main of the rehabilitation, I mean at least the recovering of the stroke occurs in the subacute phase and
reaches a plateau, yes.
the earlier. Which come to conclusions. In regard to the literature we observed, I mean the recent literature we could find about this subject, and when we compare them to our trends, we see a similar trends. Logical. And yeah, we realized after this study that the Kinesiotape was safe to apply. I don't know if Matt can say that it was easy to apply because he was applying the tape, so I don't know for the easiness, but he probably does. And yeah, our results are stating that Kinesiotape may reduce pain level and improve shoulder range of motion and functional abilities, but thus with statistical evidence we can't reach it, so we can't affirm it. So basically, yeah, further research is required to confirm such things. Yeah. So our aim for the product was to to put all those recommendations, suggestions, and our conclusion, and to transfer it to a new study proposal with adaptation from our findings and from our expertise, from our coach expertise as well, Bastien, and from our client expertise, Caroline. Hi, Caroline, if you're listening to us. So yeah, basically we did a new study proposal. We don't have it here, but we did it. We sent it to our coach as well, and this aimed to guide the future researcher that would like to conduct such research. Last of all, yeah, we would like to thank Bastien, who's been elected Coach of the Year, if I remember correctly, and who's been a great support in this PAP, Caroline Draps, who is not here, and of course the participants of this study and all the people that helped us during this investigation. Here are a few references, and if you have questions, that's the moment. Thank you.
How did you suggest in the future studies to sort of tackle either the aphasia communication difficulties in filling out a questionnaire, and that you had to probably translate it in French?
So, if I understand your question, how did we translate everything into French and then apply?
Well, no, just for the future studies,
Yeah.
how did you suggest that that was going to be tackled? Or was that a point that you guys...
So there are two things. I don't know if you want to answer.
Yeah, you can go on.
The first one is from the most recent literature targeting the same topic, so Kinesiotaping and stroke patients in shoulder pain. No spasticity was reported, and they usually targeted a patient with already some movements, but no spastic arm. So we decided to go with this and put as an exclusion criteria the spasticity, if there was any spasticity, or totally flaccid limb, so no recovery could be achieved within the 6 weeks. And for further research, we also found in May, I think, the last literature, May 2017, in this topic, saying that the spasticity should also be investigated, at least reported, to be analyzed further on and anticipate this confounding factor. I don't know if that answer your question?
Does that answer the question?
I'll talk to you.
Okay.
Yeah, Sam?
Any feedback from patients, like how was their reaction about this tape and about this intervention?
Well, we only had positive feedback, but as we said, the placebo effect might play a role in that. So some of them had their fancy tapes and they were like, ooh, it's going to be better. But that does not mean that it improves something. So they received it, let's say, well. If we look at the informed consent, we had 14 eligible patients and 8 of them signed the consent. So the public received it good, but it's not an overall thing, I guess. So because of the colors and all the trends, they like it, but that's all I can say.
It's still not generally accepted because sometimes the patient wonder, oh, is there something up with the color? Is it red because I'm going to get this type of treatment then? Or is it black because it's bad? Or is it blue because it's going to be nice? So that's the first question of every patient almost. And then once you apply on the skin and they feel how it lies on the skin, and you can wear it without almost feeling it. You can go swimming with it, and you can just, without worrying, have it here supporting your shoulder into the joint.
Yeah.
And you can go swimming or carry on your activity. So it's quite comfortable to wear, and that's the main outcome.
I guess the fact that they didn't know what it was a plus, but they were not scared, but they were curious about it. So they asked a few questions, but one said it was all right. More questions? Bastien?
To your knowledge or to your understanding, what would be the main advice concerning the data analysis for another group of students replicating this study?
I would say don't waste your time collecting data every week, because basically that's what we did, but we had to, because if we were following what the literature did, that's one thing. We could have do it the way we wanted, but literature was collecting data every week, at the beginning of the week and at the end of the week. And in the end, we didn't use those data. We only use the baseline measurement and the post-intervention measurement. So I would say don't waste your time to do this collection, because you might not use them and you might not find something. Assuming that in 1 week it is definitely challenging to achieve a minimal detectable change in such important impairment, especially with that treatment, and we still don't know if it's efficient or not even after that study.
If I can add something as well, just to finish the question, the answer. For the PAP, I wouldn't recommend it, because the PAP is 1 year, 1.5 year stream. So to do the PAP 1, so do the project proposal, do the research, and then analyze the findings and conclude. So one of our recommendations in the project is to run on 6 weeks with the baseline measurement, midterm, and follow-up, and then to do that for at least a year. So that's the biggest recommendation, would be over time, take a long amount of time to have new patients coming in and run the procedure over 6 weeks and conclude and have a follow-up eventually at 6 months, but have a whole bunch of new patients coming throughout the year, and that will lead to better conclusion, I think.
And review the selection criteria as well. We realized that this muscle tonus thing, for example, we realized that was an issue because it was different in some patients. So this needed to be noted somewhere, at least recorded, so we can have the data further to investigate on this. So I think that that's something to take into consideration. And the phase as well. The stroke phase is definitely important. But the time, as we said, the time is really challenging because we only had not even a semester to accomplish this. I mean, it's quite complicated, but yeah, time is an issue. More questions? Then we're done. Thank you for your time.
Just put it in my pocket. Just gonna move this out of the way.
Do you want me to do the thing for you?
I'll do it.
Should we start?
Should we start? Yeah.
Welcome to our PAP presentation. I'm Sylvia Ohago and this is Jordan Dehara, and the topic for our PAP is land-based injury prevention of shoulder injuries in swimmers, a systematic review and an information booklet. So the content of the presentation is the project history, systematic review, and then we talk a little bit about our information booklet, and then you have the time to ask your questions.
Okay, the project started with our client Jason Pearson, who is a physiotherapist at Physio Holland working at the Dolphin Swimming Club. It was highlighted that the club didn't have a standardised land-based training programme for the swimmers. In addition, there was no form of preventative intervention or screening. The most common site of injury seen at the club was at the shoulder joint. Coaches are constantly seeking new techniques to improve performance levels in athletes. However, the most important thing is being able to perform during competition. Therefore, reducing the risk of injury for optimal performance throughout the season is essential. Swimming is a unique sport that combines the strength of all extremities, the high demand of cardiovascular system, and in a non-weight bearing environment. The injury rate per 1,000 hours of training is 4 for males and 3.78 for females. And overuse injuries being more frequent than acute injuries. The most prevalent site is by far the joint, the shoulder joint, ranging from 40 to 91%. There are several risk factors in swimming which emerge from our research, which can be seen in this table. Repetitive movements in the shoulder are produced by smaller muscles in comparison to the lower extremities. Excessive mobility at the glenohumeral joint and the scapulothoracic joint is balanced by the stability of the AC joint and the SC joint. The ligamentous system alongside the musculotendinous system is assisting stability, allowing the shoulder to withstand a large amount of force in a big range of motion. It became evident that this was a multifactorial problem and a required complex intervention program. This led us to our research question: what is the most effective land-based injury prevention program for shoulder injuries / pain in swimming?
So the systematic review is a randomized was based on randomized control trials and cohort studies that discussed the following pathologies: shoulder injuries, shoulder pain, instability, glenohumeral internal rotation deficit, glenohumeral laxity, shoulder scapular dyskinesia, cramps, tears, tendinitis. The following database were searched: PubMed, Medline, Sinal, Pedro, Science Direct, Spot Discus, and then the Javier library was used to retrieve the articles. Articles were included if they had participants of swimmers and overhead sports, and were written in English. Articles were also included if they discussed any form of land-based interventions. Articles were excluded if they did not discuss any form of injury prevention, if they were published before the year 2000, and if they did not meet the grading to prerequisites set by the authors. That's 6 out of 9 for the modified Cochrane grading list, and a 6 out of 8 for the Newcastle Ottawa scale. Before the grading of the articles, 2 tables were created, one for the demographic data of the participants, and then the other to summarize the article, the result of the articles. Sorry. The modified Cochrane grading list was used to grade for the randomized control trials and also to assess for the risk of bias, while the Newcastle Ottawa scale was used to grade the cohort studies.
Our research methods resulted in 10 RCTs and 2 cohort studies being graded above the threshold. 3 of the articles focused on swimmers and the remaining 8 focused on overhead sports. 6 RCTs scored 6 out of 9, 3 scored 7 out of 8, 7 out of 9, and 1 scored 8 out of 9. From the cohorts, 1 scored 7 out of 8 and the other scored 6 out of 8. A decrease in score was either due to issues with blinding, poor follow-up procedures, or there was no mention of the patients at the baseline level that were at the baseline level. Oh, you don't. The results from the RCTs are as follows. Bracing may be beneficial for muscular imbalances, glenohumeral laxity and instability. Taping showed an immediate significant improvement in pain-free shoulder movement, but no other physical differences were noted. Angular and non-angular stretching provides significant improvements for athletes with altered range of motion. Manual stabilization used during horizontal abduction increases shoulder range of motion, and PNF was also seen to exhibit improvements, especially when vibrations were added to the interventions. Muscle energy techniques can be used to increase horizontal abduction and internal rotation. The use of generalized strength training program may not be the most effective means for improving weaknesses around the shoulder, but when individualized to the athlete, there may be some benefit. And local and general fatigue experienced after the swimming sessions can potentially be reduced by low-level laser therapy. From the cohorts, several areas in water and dry land practices were identified to be putting the shoulder at risk, such as continuous long distance swimming, lack of specificity of training, and inconsistent training dosages compared to current research. Core strengthening and cross trainings were frequently performed and were believed to be of some benefit in preventing shoulder pain.
So this limitation to our study, there were not articles available that related specifically to the research question. so we had to like improvise in some ways. There was an inability to retrieve some articles because maybe most of them were to be paid for or some of them were unavailable. The year of publication and the language of study, we think probably limiting the language of study to only English and can be quite challenging because maybe we have some articles out there that are written in all other languages that might have been useful. The number of articles, we had like a less amount of articles, and in some articles we had like a very small amount of participants, which can also which can also make the method and the result of the articles not be reliable. And then in conclusion, in recent times, the main focus is to treat and rehabilitate injuries, competitive swimmers after an injury, rather than focusing on preventing the injury from happening in the first place. So we believe that creating a treatment program that focuses on strength training, stretching programs, and other forms of exercises can help in reducing the risk of having any of the injuries. So for future research, we advise that a standardized injury screening tool should be created, and the efficacy of strength training endurance exercises should be established, and a cross comparison of interventions to find out which is much effective than the other should also be researched on.
Okay, we created 2 information booklets, one longer version, one shorter version, the shorter one for practicality purposes. The information booklet was split into these sections: an introduction explaining the prevalence of shoulder injuries, the causes and the risk factors associated. They explained our systematic review findings, also a short description of preventative interventions, how we were going to integrate the program into the current practices of the swimming club, general guidelines regarding training principles, some methods for progression, supplementary interventions which may show some benefit, and finally some final recommendations which we had for the coach. This is a screenshot of the full version of the information booklet. In bold is the intervention, a small description of the intervention below, including the indication for this part of the program, and the frequency at which the exercises should be performed. The exercises are split into bullet points, has the items you need, a small description of the exercise, how to perform it, and some pictures to help. This is the shortened version of the booklet. The document contains all the general information but condensed the exercises and indications into a table format. And the last 2 columns explain the frequency of the exercises and how you're going to integrate it into the training.
We would like to thank our client, Jason Person, and our coach, Bastian, for all the support, and also Estavello for helping us with the research strain. And these are our references. You can go to the link to see the references, and thank you for your attention. That is it. Questions, please?
So looking at the interventions that the paper had, they focused very much on just localized exercises for the shoulder. And I wondered if, in your opinion, since swimming neuromuscularly involves cross-body stuff, those shoulders, and then the contralateral leg, and lots of control, whether it's better to do a more holistic exercise out of water routine that does involve the shoulder but might also involve the lower limb, just to make sure that you're making that pattern of movement active.
We noticed from the articles that it seemed to be, like as you said, focused on the shoulder in itself. But from our previous research prior to the study, we figured out that the movements required in swimming is whole body, obviously. And also we found in the cohort studies, they mentioned that maybe a holistic approach should be used, including the core and lower extremities. So in the information booklet, we added exercises or more functional exercises, not specific just to the shoulder joint. So, for example, we did some carries and some core stability exercises. We kind of tried to integrate a little bit more, but we didn't find RCTs focused on specifically on reducing the risk of shoulder injuries in swimmers or overhead athletes. Yeah.
Did you guys find anything about transfer from land exercises to the water? Because I know that this is a big challenge.
Oh, like the transference of the effects of it.
Exactly.
I specifically can't remember.
No, we didn't actually find like any article that said, okay, it's good to transfer, but most articles we found, they combined the both, like the inland training in relation to their regular training in water pools and everything, yeah. So there is none that said, okay, we can live in water and focus on land, or we can leave land and focus on in water. Most of them combine the both.
The one thing which was mentioned in both cohort studies was that cross trainings was frequently used, so out of land cycling, rowing, all that sort of thing, and it has shown some benefit in reducing the risk of shoulder injury. But regarding transference of like strengthening exercise and stretching exercises, it wasn't like specifically mentioned in the article. But obviously, from our knowledge as physios, you can probably understand that there may be some benefit of and transference into the actual sport itself.
Sorry. Did any of the papers say when they implemented the interventions? Was it immediately prior to swimming, or was it just hours? Were there hours difference, or was there a way that they tried to construct a sort of timetable? And if so, what were the reasons behind?
From what I remember, it didn't mention whether the practices were the on land was done before or after, but it did mention that they integrated it into their normal training routine. If we use the Dolphin Swimming Club as an example, they do their swimming routines, I think 5 times a week, and then they do their trainings in the morning of that day, or they train whenever they want throughout the other days, but they've got to complete their on-land training. Oh, actually, we can add regarding integrating the on-land training into the normal routine. There is from all the articles, they all said that they did have current on-land training programs, but they were more like generalized. There wasn't specific to the current research. That's what we found in one of them. Like the coaches just used their experience. They didn't actually have hard facts to go by regarding research. Yeah.
One last question. Thanks, guys, for the presentation. Is this already implemented? And I know it's fresh and you've just finished it, but have you spoken to your client about implementation?
No, he sent an email just saying that it's going to be of benefit to the club, and they'll be implemented as soon as possible. We haven't received any feedback yet, but I don't know. I'll bump into him probably sometime soon and ask him then.
fast with a weakness. Do I put this? Where do I put this? Okay, so this is our presentation on esophagectomy, and what we thought we would do is just show you this is a bit different. We thought we'd show you the end product before we begin, because this is give you some direction as to where we're heading, because we're going to go a bit all over the place. So this might just be an idea for you to start off with. Martin was our client. He ordinarily works with patients prior to their esophagectomy, but he wanted us to look at patients when they come out of having an esophagectomy and what these patients should do in their rehabilitation and what they need to do.
All right, so the main reason why we're doing this is because patients who have esophageal cancer, they are at quite a high risk. The problem is that esophageal cancer is the 8th most common cancer, and 99.5% of the tumors found are malignant. Therefore, now the most common way of curative treatment is an esophagectomy. John and I went to see one last year, and what they do is they completely extract the esophagus and the top part of the stomach. They bring the stomach up through the diaphragm and sew it up. So these patients now have no esophagus and the food just goes through. This causes several problems, and the survival rates for the patients after 5 years post-surgery is only 20%. So out of 100, 80 will die within the first 5 years. Therefore, our aim was to see if post-surgical physiotherapy could benefit these patients and change these numbers, turn them around.
So essentially what we did was we split the project into 3 areas. So we did 3 articles, and we're going to talk you through those articles now. The first one we did was a qualitative study. So this was speaking to patients about their needs and experiences after esophagectomy.
Right. So since it was a qualitative study, what we did was interview these patients. They were Martin's patients that Martin was already treating from the AMC, and they were either interviewed in person in this building or through Skype if they weren't able to make it. 12 patients were contacted. These 12 patients, we had our inclusion and exclusion criteria. 3 of them were excluded because of their conditions getting worse and them having to go into the hospital. 9 were then still available. Out of those 9, 2 of them did not respond. So out of those 9, 7 were interviewed in the end. 1 of them through Skype and 6 in person. These interviews were conducted for the period of 10 months. And the baseline measurements show what was also found in literature, that most of the patients with esophageal cancer are male and around the ages of 50 to 80 years old. Many of these patients, as you can see, had no physiotherapy prior to their hospital admission, and many of them did have physiotherapy after the hospital, but they had to find them themselves. So the dynamics of the interviews, we decided to make them very informal and conversational, since it was a qualitative study and we wanted them to feel free to just speak and tell us their experiences without any sort of restraint. And at first, a questionnaire was made with the client's wishes and to try and figure out the information that he was still missing. And as more interviews were performed and the interviewers got a better sense of how these interviews went, then the interviews evolved in a very natural manner and questions were asked. The recordings were later transcribed and or translated if the interviews were performed in Dutch, because some of them, we'll talk about the limitations later.
Okay, so the analysis of the interviews of the transcriptions that was initially done by Mel. She was using that for her PhD, so she wanted to use this program Max QDA for so she could practice basically for a PhD. So basically, from that, some themes were developed, and these were the themes that came out of the interview. That you can see them on the left-hand side, and then on the right-hand side were all the sub-themes. So yeah, essentially the main two. Well, we'll talk about what we were interested in shortly. After we got them from Mel in that format, they were then put into Excel. So you can see underneath the bit that says segment, that's all the quote. Those are the quotes. That's not all of them, of course. That's just one example from some of the patients. Then they were put into charts, so tables, so we could easily compare and contrast different opinions. And then after that, we made interpretations. So before we made the interpretations, which are here, so basically we used the main quotes to sort of think, what did we feel about, what did we, about our impression of what they said. We also contrasted similarities between themes, and that will come up later. So essentially the strongest overlap that we saw was between coping and the activities that the patients were able to do after their esophagectomy, and we were wondering why that might be, and we thought that basically these patients were put into situations which they'd never experienced before, but which of course were sort of activities which were important to them and which they were once able to do, these everyday activities, and that demanded not only physical strength but also emotional and social, and that's really the thing that we took out of it is this other side that they require from their treatment, the physical in addition to the social and emotional needs, and that was represented through this chart here. So you can see in the middle, these are all the exercises, the needs that they had. So the exercise needs to be personalised and staggered, but then around this needs to be a constant. You need to constantly ensure that their emotional and their social support network is there, and we use this in the final product in the following way. So for example, in terms of the guidance and the motivation, all the way through the booklet, this is an example from the booklet, we made sure that they were encouraged to continue going. So in this one you can see at the top there's a quote that says, there may be ups and downs, but it's all part of the building of heading in the right direction, and just basically to keep going and supporting them. Another example is for them to monitor their progress, which they said they wanted to do. So then we provided an exercise log. Another one was that they asked for specific information, and that was apparent all the way through the exercises, but also in terms of we gave information as to why we were doing certain things. So that's really what we found. In terms of the limitations, of course, a couple of them, one of them was in another language, and then we were thinking about, well, maybe that means that it lacks the emotional depth that is needed for a qualitative study, but that's debatable. And then we were wondering whether there's external validity, but we can certainly say, since all the patients came from the AMC, that there's certainly external validity towards that hospital, and we're happy with that. So then we're going to move on now to discussing Article 2.
Yeah. So in Article 2, I wanted to research the use of tailored programs versus just generalized programs. And I did this through finding articles in the following databases. And the outcome measures that were mostly gathered in these studies were patient awareness, quality of life, body composition, and physical activity. Out of all the articles found, 9 were finally included in the systematic review, and they came from the 4 countries shown in the slide. They showed that tailoring does have a positive and significant effect. However, the largest effect size was between tailored interventions and no intervention at all, so control waitlist groups. And there was a very small effect size between tailored and non-tailored but good fitting programs, meaning that even if the program didn't specifically have the person's name on it, which would be a factor in tailoring, but it did keep into account the person's form of life, and it was good fitting in that way, that it would also be effective. and positive. The intervention and comparison group changed quite a bit because the comparison group was, as I mentioned, either a waitlist control, but it could also be just usual care or good fitting general feedback. And that was one of the limitations in this study, which I will mention further later. So yes, one of the biggest limitations in the systematic review is that there are no studies out there that show that are specific to the esophageal population, esophageal cancer population that we were looking into. Therefore, I had to make my deductions out of just the general population of everyone and see it as a sort of psychological characteristic of, is tailoring just going to make that person want be more motivated? Also, the differences of tailoring amongst the studies were not the same. You know, there was no sort of guideline on this is what you have to do in order to tailor. Each study had their own definition to how to tailor something. And also, as I mentioned, the outcomes before, many of them were subjective and self-reported, and that brings into question the internal validity of these outcome measures. However, in conclusion, it was deducted that the use of tailored treatment is advocated since it can do no harm, and in the studies, since it shows a positive effect, that it will increase the person's urge and drive to continue into the program. But further research does suggest to use more objective measuring tools. For example, instead of having the person have a self-reported physical activity, to use an accelerometer or a step counter. Also, long-term follow-ups are suggested for further research, as many of these were only after 6 months was the longest term. And of course, when you prepare a rehabilitation program, what you want is for the patient to continue this for the rest of their lives, because that's what is going to help them in the end. Yeah, so the link to the final program was, as I said before, since it is not specifically necessary for the patient to have their name on a document, and good fitting tailored treatment, good fitting non-tailored treatment also shows a positive effect. That is what was put into the final product. Everything that's in here has to do with people who have had an esophagectomy, and for example, when it talks about 1 week post-surgery ICANN, and those are goals, and they are very realistic goals for these people, so they will continuously feel motivated and supported in their process.
Okay, so finally, so we know now what the patients wanted, what their experiences was, and we know that tailored is advocated, so we're still left with what exercises to give to the patients, and that's because really there's no research out there at all about esophagectomy, post-esophagectomy exercises. So then this was the aim of this final review, and it pretty much continued on from, the aim was to continue on from using the outcomes that Martin used in his pre-esophagectomy paper for his PhD, which you can see in the outcome section there. Read through, like many of you, many hundreds and thousands of articles, and we ended up with 7. The main reason why they were excluded was because the interventions weren't something that we could use in physiotherapy. And these were the main outcome areas: the functioning, the strength, cardiorespiratory fitness, quality of life and fatigue. And they all used they didn't just use one specific intervention to measure that outcome. They used an awful lot of combined measures together, so like an exercise program. And that actually, which we have time later, we'll mention, proved quite difficult to identify what it was, what intervention it was that caused the significant results. And here you can just see an example of the different papers and the different interventions that they used. So here are the results. That's probably quite overwhelming to see. So essentially, this is what we found, that physical functional capacity can improve, and strength. Lower extremity can. Only one paper found that. Upper extremity, it didn't really matter what the exercise groups did. It didn't make any significant changes between the intervention in the control group. As for the rest, there were significant changes within the intervention group. The one strange thing was that the fatigue, as you can see there in bold, it was the control group which improved in fatigue levels rather than the intervention group, which was very strange, and in our paper we discussed the reasons why. The main limitations of this study were essentially whether you can use papers that were based upon lung and breast cancer patients and other thoracic cancer patients and apply that to post-Esophagectomy. And other papers have sort of done something similar, but that's probably the standout because there was a big leap from saying that it's a thoracic surgery to then saying therefore we can apply the same intervention as for lung and esophagectomy. And then the other intervention, the other problem was what we mentioned earlier, whether we can apply, since they were all used together, whether we can use, it's very difficult to say that one intervention caused significant changes in an outcome. So really this is what we were left with, that you can use aerobic exercises programs such as walking to improve physical functioning. Lower extremity can be improved. Maximum heart rate of 50% can improve cardiorespiratory fitness, and fatigue levels will also improve after chemo treatment. And then we used that with our initial research on the interviews to create the exercises, which were sitting to stand, with lots of specific details like the patient asked for in terms of when to stop and what intensity to do. Then we did lunges, stair climbing, walking, and cycling. These were all for the first 4 weeks, and then after 4 weeks the intensity went up, just like the patients wanted a staggered progression level. So really that's what our paper looked like. It all came back to this. We want to thank, of course, Sebastian for helping us the whole way through, and we'd invite any questions that you have about any of these papers.
Yes, Jackie?
I have a question about the whole document. Because you said that language was a little bit of a barrier in the interview, do you think if this English document is presented to the Dutch hospital, that you'll have the same kind of limitation in that way?
Yeah, actually, one of the aims was when we created the booklet was to create it so it could be easily translated into Dutch. So that's something that hopefully we can help us out.
And to add to that, the document, the reason why it's easily translated into Dutch is because there isn't a lot of medical lingo in there, since it's created for patients that don't have that knowledge in order so that they can understand as well. And hopefully, since it's in English, and it can also be distributed to more countries.
Any questions from anyone who's not doing a PhD in Physiotherapy? Okay, well then we're...
It's actually not a question, so that saves...
that saves the embarrassment.
In addition to what Jackie said,
yeah.
Thanks for the presentation, by the way. It's really valuable what you did, personally for me, but also for the patients. Actually, this booklet is already used in the current study I'm doing, not one by one, but the results of this booklet are already implemented in a tele-rehabilitation program I'm currently running to investigate its feasibility.
Yeah.
And it's really nice to see that those simple functional exercises are of enormous value for those patients, especially 4 to 5 weeks after surgery. I think I've seen now 6 of them, and there's a 100% score in how important these exercises are for all those patients. So yeah, it's really useful for them. And I'm still thinking of how to implement this booklet by translating it, or to implement that in a tele-rehabilitation system. But that depends on the outcomes of this study, which I'll expect at the end of this year. So thank you very much.
Thank you.
How's this?
Yeah. Okay. Thanks. Okay. What if a child gets sick? What if a child is developing normally, everything going as planned, and nothing seems to be out of the ordinary? But suddenly a massive tumor decides to grow in this little person's brain. I'm Damara, and I'm here to present to you my bachelor thesis, a physiotherapeutic introduction to pediatric brain tumors. First one to be all by myself, because unfortunately my partner dropped out at the end of part 1, but since I was already much involved in this project, I decided to continue by myself. I'm doing my project for the Prinses Maxima Center, which is a really big pediatric oncology hospital, which is currently being built in Utrecht, the center of Holland. My client is representative for this hospital, but before I tell you anything more, I would like to show you a little video.
Welcome to the Prinses Maxima Center. The first thing you will see when entering is the welcome desk. By climbing a small pair of steps, children can look behind it. Everything in the hospital is specially fitted for children. Across from the welcome desk are the doctor's offices. Here they will tell you what's going on with you, and you can ask anything you want. It's always sad hearing that you are sick, but the doctor will tell you that they all do their very best to make you better. Further down the hall, you will find the treatment room. This is where unpleasant things happen, like shots or a small tube up your nose. So you have to be tough sometimes. You get a special bead after every treatment, intervention, or procedure. Together, these beads make a colorful chain. The Prinses Maxima Center is going to get a lot bigger. If you go outside, you will see that they are building a brand new hospital so that as many children as possible can be cured from cancer.
Okay. The reason I decided to show you this video is because I think it gives you a bit of a better understanding of what I'm actually talking about and why this is really relevant. The Prinses Maxima Center is currently being built in Utrecht. And of course we already know a little bit about pediatrics because we are in pediatrics right now. We've had an extensive course in neurology and we covered a little bit of oncology. But what if all of these 3 domains come together? Each year, over 400 children are diagnosed with cancer in Holland. There's been a massive improvement in healthcare for these children over the past decades, with currently a survival rate of around 75%. However, the second most common type of childhood cancer are brain tumors. And brain tumors, also the deadliest type of cancer for children. The prognosis is much worse for these children. Only 1 out of 3 children won't be alive anymore after 5 years. And if you do survive it, unfortunately the statistics are not really in your favor. 60% is left with disabling long-term side effects from either the treatment or the tumor or a combination of all these. Examples are endocrinopathies, declined physical performance, neuropathies, seizure disorders, and a cognitive impairment. And I think we can all imagine that this can severely impact the quality of life of these children as they grow up as well. This has been well studied, and one study even stated that in comparison with all childhood cancer survivors, survivors of childhood brain tumors report the poorest health-related quality of life, with impairments in multiple domains of psychosocial functioning, including education, employment, marital status, ability to drive, and living independently. And this should not be the case. It shouldn't be that these children have such severe long-term side effects from the treatment. It shouldn't be that the prognosis is so much worse for these children. And it definitely shouldn't be that out of all children that are diagnosed with a type of childhood cancer, 1 out of 4 won't be here anymore after 5 years. Not only should this change, this can change. And this is where the Princess Máxima Center steps in. A huge pediatric oncology hospital with the aim to bring all the knowledge and researchers about pediatric oncology together to provide the best possible care for these children. Think about the best doctors, the best specialists, the best multidisciplinary team, all working in one hospital. With the arrival of the Princess Máxima Center, the Netherlands acquire a top position in the field of pediatric oncology. Not only in Europe, but globally. And this will really help to fulfill their ambition. Cure more than 90% of all children with cancer. But in order to do this, we need knowledge. We need to know what are these tumors, what are brain tumors, what are any other type of childhood cancer. As you can probably already guess, in this multidisciplinary approach, physiotherapists play a big role. And it has been seen that these physiotherapists don't really have enough knowledge yet about, for example, brain tumors. They have sometimes a lack of experience, but definitely a lack of theoretical knowledge. Therefore, evidence statements are currently being developed. One is made about pediatric brain tumors, where I'm a part of. An evidence statement is a preliminary national guideline. The aim is to make it into a multidisciplinary international guideline for the entire world to use. But we're not there yet, and we're only at the first step, making evidence statements. Every evidence statement is divided into 2 sections. Section 1, my part, which was a literature review of general knowledge. Basically, what I try to answer, what do we as physiotherapists need to know about pediatric brain tumor? What do we need to know before we go on to section 2, which is a systematic review of assessment tools and intervention strategies, which is currently under development by a specialized pediatric physiotherapist. But before you can apply all this practical knowledge, we need to go back to the basics, because how well can your clinical reasoning really be if you lack theoretical knowledge? Therefore, the aim of my literature review was to analyze and critically appraise current knowledge on pediatric brain tumors, to set up the first section of this evidence statement. It was targeted at both physiotherapists as well as students from both bachelor and master students. My client is also a guest lecturer for a lot of educations all around the world for both master and bachelor students, and therefore he really aimed this also to be at students. How did I do it? I followed a 3-step process: identifying the literature, screening it, and performing a quality assessment. In the end, I was left with guidelines, systematic reviews, a lot of medical books, and a few online websites. Basically, this meant that I could basically set up my tent in a library because I was there 24/7. A lot of this information comes from books and not from the journal articles that we're used to doing a lot of things with. And this is really a switch for me, and I think it was a very interesting aspect of this. Now I'm very happy to say that I have my final product done, and I've handed this over to my client. It's quite an extensive booklet covering a lot of topics about pediatric brain tumors. For example, neuroanatomy. Of course, we have had some background in neurology, but do we also really know it? And also, do we know things specific to pediatric brain tumors? Types of brain tumors. What is the difference, or is there a difference between adult brain tumors and pediatric brain tumors? There is a big difference, and this is also all explained in this chapter. There are a lot of different types of brain tumors. Of course, I couldn't explain all of them. Therefore, I really had to decide which ones do I use in order for it to become a very clear picture. The clinical presentation was more aimed at physiotherapists, so I really went into the physical aspect as well. Sometimes I need a little bit of help with Mbaka because I went too much into ADLs and physiotherapy language, but it needs to be a very broad booklet and also readable for other people. Therefore, now I kept it into physiotherapy, but also easy to read for everyone. The last but not least was the adverse effects of treatment and long-term residual deficits. This is where really physiotherapy starts, and this is where we come in. In an acute stage, you probably won't see many children with brain tumors because they're too sick. But in a later stage, we kick in and we do our job. Unfortunately, I can't really tell you all about my project as much as I would love to, but I would like to tell you a little bit about what's next. because this project is not done yet. And there's currently, the evidence statement is still in development, and my project is sent to a big pediatric oncologist and physiotherapist team, and a big team of students from a master study of pediatric physiotherapy. And they are going to take all of my limitations and recommendations that I addressed in order to finalize these evidence statements. It's then going to be converted into an educational tool as well, online e-learning method, most likely. And this is all with one goal: to cure more than 90% of all children with cancer. Thank you for listening. Questions? Yes. Yeah, I chose not to explain it too much, at the time limit as well. But do you have a specific question about it? Or? Yeah, the book was, I used the AACODS checklist, which is one was very new to me as well. It's officially used for grey literature, but it was very applicable to my to books, medical books. So I've decided to change them a little bit, but keep that checklist. But I must say that was a very challenging new aspect, because it's not the journal articles we were used to. Well, not the entire, I used sections of the book in the final product, but for the grading, it was very extensive, so I used a lot of the books completely in order to grade it properly. Yeah. Any other questions?
You said that your aim was to review the general knowledge and that you spent a lot of time reading, but did you actually get experience in the clinical setting working with pediatric patients?
If I work with the children, unfortunately not. This is not allowed. It's privacy issues. I did try to spend a day with these children, just attend in the hospital. However, this is really not by law not allowed. But looking back at it, I must honestly admit that I don't think that would have increased the quality of my project, because I think the strength is that I'm very objective, because I know what I know from the books, from what I know from my own background. But if I would have seen a lot of very sick children, or ones that do a little bit better, I think this would have made my subjectivity come a little bit more to the front of my project, and that's not the aim of it. So, but for my next internship, I'm actually going to work with pediatric oncology patients. So that's very nice. Bob?
Do you see any consequences for the school curriculum?
If you want. Depends. What do you exactly mean?
No, but seriously, you have the pediatrics course now?
Yeah.
You want to see that change?
Well, I've spoken about this with my client as well. He's very much into teaching as well and guest lectures. So I think this would be a very interesting aspect, especially because the hospital is going to be very big and there are going to be a lot of jobs in the future. For me, this is a passion and something I'm really passionate about. But in case there are more people in ESP, I think it would be a great opportunity if there will be some sort of relation still in the future with my client. But I must say, so far in the pediatrics course, we don't cover any oncology. He is already offered, so if you want.
Okay, bus is not here. You will record it.
Yeah.
Okay.
Put it all in my pockets. Yes. Thanks.
I just like? Okay. Sure.
Yeah, your hair is going to be.
Oh, it's fine. Here.
I'm just going to.
Oh, yeah. That's.
How you doing?
Thanks.
Yeah.
No, I might show it, but I don't have it. Now people hear me?
Yeah,
all over the world.
I think they can hear me.
Okay, yours is much higher. I don't have to talk them down.
Maybe try to put it up more.
Okay. Wait. It's both not sitting.
Yeah.
Breathe in 7 times. Okay, last session before a very short break. 20 minutes. Gives us the time to start again.
Remember, click down there afterwards.
Yeah.
Yeah.
Do you have
Too early.
Yeah.
Okay, so camera ready? Okay, go ahead.
Okay.
Oh, is there sound?
Yeah,
Click there.
in the video.
Hang on, we'll just restart it.
She will not quit. She's a machine and
Next slide. Alright, brilliant. Good afternoon. My name is Pierre-Louis Denard and this is Natalie Noonan. So we've done our PAPs together on a rehab program and return to play guidelines for CrossFit athletes. So Tyson Sanchez was actually my CI in the first internship. He's based in San Francisco. And so what we knew already, what we talked about together was that in overhead sports, there's already a high prevalence of shoulder injuries. What we also knew, because he works a lot with CrossFit athletes, is that CrossFit is a very intense sport. As you saw from the video, it's usually the maximum amount of work in the shortest amount of time. You're actually often working till failure. And in addition to that, you have a lot of overhead movements. The flagship movements such as the snatch, there's always an overhead movement with a lot of load. So we had that knowledge and we thought, okay, we had a hypothesis come up that CrossFit athletes have a similar prevalence of shoulder injuries to other traditional overhead athletes. And we actually found 7 studies that supported this hypothesis. So this was our base and we went ahead with our methods.
So we wanted to test our hypothesis about shoulder injuries. So we created a survey and we distributed that survey to 8 different countries across the world. It yielded a total of 535 responses. The majority of them came from the Netherlands. And the survey was shared on Facebook, CrossFit Facebook groups. The survey did in fact confirm our hypothesis that the shoulder area is the most injured and that it was mainly due to the overhead exercises. And so now that we knew that the shoulder was the most commonly injured area, that's where we began our literature review. The criteria that we used to find our literature was we wanted athletic populations that were participating in overhead sports, such as swimming, weightlifting, handball. And the interventions needed to be exercise therapy in relation to the shoulder joint complex. The control was no intervention at all, and the outcome was measured by body function and sport-specific performance. So we used keywords such as range of motion, performance, and return to play. There was no set time frame for the actual treatment, but we did want to make sure that the participants were participating in a organized team on a regular basis. So that yielded a total of 10 RCTs and 5 narrative reviews. You can see them over there. They're very recent. The RCTs were graded using the modified Cochrane, which is based on a 10-point scale, and the narrative reviews were graded based on the JB Notari, which is a 7-point grade scale.
Okay, so once we graded our articles, remember that we're looking for literature in order to make this rehab program. So we were looking for a consensus, again, for shoulder injuries in overhead athletes. And the strongest consensus revolved around strengthening the rotator cuff muscles. There was also a strong consensus for reducing the forward humeral head posture, so bringing it backward, as well as increasing internal rotation range of movement, specifically using the cross-body stretch and the sleeper stretch. And there was some moderate consensus around use of plyometrics, as well as using the core, spine, and lower extremities for that transfer of kinetic energy in overhead movement. There was low consensus, surprisingly, with eccentric contractions, not because they didn't work, but actually they didn't prove superior to concentric contractions. So, as well as that, there was anything that was external aid, such as shoulder bracing or taping, that was also of low consensus. If we go to the next slide, we wanted to include return to play guidelines in our product. So we got a lot of return to play guidelines from the narrative reviews, and this is actually a condensed version. The important thing to note is that they came in sort of subjective, mobility, strength, and functional criteria. Subjective was stuff to do with patient satisfaction. In the mobility criteria, we got a lot of cutoff values, so range of motion, left versus right. And in the strength, same thing with isokinetic strength ratios, especially in protraction and retraction. We haven't included those values in there, but just to give you an idea. And the functional criteria was to do with quality of movement, the proper lifting mechanics in a CrossFit flagship movement, such as the snatch. So that was the bulk of our review. And we're going to show you the product now. But first, just to review what we did. Remember, we had a hypothesis that CrossFit athletes have a high prevalence of shoulder injuries similar to traditional overhead sports. We confirmed that hypothesis with a survey. So then we made a literature review on the shoulder joint in order to make a program. And once we had the results, what you've just seen, we translate that into a product, the return to play program, the return to play guidelines with the prevention program. And this is what it looks like. So we have one page for the rehab and prevention program, and we have one page of return to play guideline used by the clinician in his return to play decision.
So the product was a great way for us to respond to the findings of our survey, as well as the most recent research that's out there on CrossFit. If you remember from the video, the CrossFit is televised worldwide in an elite level. So there's over 12,300 CrossFit centers worldwide. The participation is growing, and due to that, there's a higher risk of injury incidents. So there's a higher indication for prevention and intervention.
And therefore, if there's a higher indication for prevention and intervention, then what we've done as a product, it's a very nice framework for potentially a more expansive shoulder rehab program for CrossFit, or a more expansive low back or knees, because those were also common areas that our survey respondents told us that they injured. Obviously, we encourage high quality studies looking at only CrossFit populations, because we had to use overhead populations in our reviews, in our literature review, because there were no studies using only CrossFit populations, so it opens up a new area of research. But the last thing to end on, which is actually quite more interesting for us, is that CrossFit is potentially a very marketable and profitable sport for us physios, because 52% of our respondents said that they went straight to a physio when they got injured for any body area. So even though we may not know the sport yet, it's probably worth looking into it, because it's definitely something that we can profit from. And that's it. Thank you so much for listening.
Any questions?
Sure, yeah.
Go on. Do you focus on any preventative measures that can be used? What I've heard about CrossFit is that people think, right, I really want to get fit now, and they jump into CrossFit and they get injured because it's very intense overhead stuff. And so did you find two things: those who are more predisposed to shoulder injuries, and any way of implementing what you're doing to prevent the injuries in the first place?
So your question was, did we find? Can you
forget the first one? The second one is probably.
No,
Did you
go
find
ahead.
that any of these things can be used to prevent injuries from happening rather than a treatment for the injuries once?
Right. Okay. Right. So the literature we looked at was to do with shoulder injury prevention and rehabilitation. So, for example, one of the studies that we used in literature review was a prevention program used for handball, where the control group ended up with less injuries in the season. So they did these exercises at the beginning of the season and had less injuries during the season. So these exercises were definitely in the aim of preventing, but also in rehabilitation. So to answer your question, yes, these exercises were in a spirit of prevention.
That's quite a nice way of you using this within most CrossFit centres for even those who aren't injured in the first place. You know, so this
Absolutely.
Yeah, way for beginners to
absolutely
home exercise as well.
And that's what the product is. It's very simple. It's easy for people who are very busy to follow in their schedules. Yeah.
You said that you spread a survey around.
Yeah.
Did you make that survey?
We did make that survey. Yeah.
And how did you decide to make it, or what format to have it in?
It was a Google survey, and there were about 10 questions focusing, and it was about their injury trend. So, what do they injure the most? Could they identify what movement or exercise caused their injury? How long did it take them to return to play? Did they see a medical practitioner or not? And the countries were selected to. There's a map of CrossFit centers across the world, and with the highest concentrations, we picked those countries.
And one more related to this. In your literature review, your PICO said that the population from your PICO was led in CrossFit in overhand sports?
No, it wasn't. There isn't any literature specific to that, so we had to be creative in our literature search, and that's why we chose overhead sports. So it wasn't CrossFit. It was all these other sports up here, like weightlifting, handball, baseball, volleyball.
So we would have liked to include CrossFit in the actual review, but because we're really the first intervention study on CrossFit, we had to use sports that involved CrossFit movements or overhead movements. Weightlifting and powerlifting probably were the closest things to that, but that actually exposes probably the main limitation is that in all these sports they do overhead movements but not in a loaded position. CrossFit has overhead movements but with heavy loads. So that's why it's interesting and encouraging to have more studies with exclusive CrossFit populations in the future. Yeah.
How were you planning on implementing this into practice? For example, the program.
Oh, right on.
Is it like does everyone do it or does?
So the client Tyson Sanchez in San Francisco, he has close contact. He gets his patients from these CrossFit centers, and so what he has done now is taken this product, gone to the CrossFit centers, told them about it, and it can be used as sort of a branding tool as we specialize in CrossFit athletes. But it also, the return to play guidelines were handed out to CrossFit trainers at the gyms. So that was the blueprint for implementing it. And San Francisco was actually where CrossFit was born, so it's the highest concentration of CrossFit centers in the world there. It's quite a nice starting point.
Thank you first of all for the presentation and for a nice product. My question for the product is now, because you have displayed those 6 exercises. Question number 1, were those the most dominant exercises out of the articles that you found? And question number 2, are those only suggestions, or as a CrossFit athlete, if I do those exercises, they will be beneficial?
I understand. The first question was that, so in the study there were 10 randomized controlled trials. In those randomized controlled trials, we saw trends in exercises that were being used in the intervention for overhead or for shoulder injury problems. So we selected those exercises that were in accordance with the consensus. So if there was strong consensus for strengthening rotator cuff muscles, we would select exercises from the RCTs that aim for strengthening rotator cuff muscles. I forgot the second part of the question.
Yeah, the second part of the question, because the exercises that you have here are quite specific. Are those the exercises to go with, or are those just examples?
Well, we wanted to select the exercises that had a strong consensus based on the literature. So our product mainly represents the consensus from the strong consensus and moderate. We didn't include any of the weak consensus.
It was what was yielding from the literature review. So there are suggestions, but based on the best literature that we found.
Yeah.
Yeah, that I understand, but if you look at plyometrics, this is obviously not the only plyometric exercises.
Yeah.
The question now is there any variance, or is this just a suggestion? You've chosen for those 6 to display those 6, right?
So this exercise, for example, was from an RCT which was looking at a handball team, and since that had a lot of injury, statistically significant impact on their injury prevention, then we took that. But by all means, it can be also swapped by the clinician, I guess, because.
Yeah, we also mentioned alternative ways of doing the exercise in the product. So different positions, and it's really set up to be easy for the person. So for example, this one over here is you can use it with a weight, or if you don't have a weight, you can use it with the water bottle. Fill it with water. So.
What you missed is that it was also meant for the San Francisco working population who do CrossFit after work. So the aim of this product was also to do it so they could do their prevention or rehab
at the convenience
break, in their office or something like that. So. Yeah. Okay, thank you so much for listening.
Thank you. Oh, yes.
Yeah, absolutely.
It sounds a little bit skeptical, but I come back to it. Is there actually any reason to promote it? Because I'm thinking about it.
To promote the sport?
Yeah.
It's just like any other sport. If you compete in a sport competitively, you have to be aware of your body and watch out for injuries. So the prevalence of the shoulder injuries in this sport is the same as any other sport would be if you're doing it competitively as well.
I would answer it differently. I would say that the video you saw, that is the elite category of CrossFit, where these athletes are well and truly prepared for what they're trying to do. But CrossFit is very trendy, and what I would just not recommend it to is, for example, a layperson who want to pick up a new sport and then who does CrossFit straight away without never done maybe general strength training, because then, as I said, the principle of CrossFit, which is quoted on their website, is the maximum amount of work in the shortest amount of time, and you are often working until failure. So that obviously doesn't sound good from a clinical point of view if you've never done it. So
to answer your question, I think that I would say that it just depends on your level of athletic history and if you have good health insurance.
Or also your previous history of injuries as well.
Yeah.
Yeah. Thank you.
Ja, das hast du dir selber schon angemeldet.
Ich habe meins angemacht.
Also ich nicht, oder? Ja, geht. Works. Okay. Good afternoon, everyone. Mira and myself would like to thank you for coming to listen to our PUB presentation, and we warmly welcome you. For our PUB, we dive deep into the topic of cryostimulation in the scope of musculoskeletal rehabilitation, and we're really looking forward to share our findings with you today.
Does anyone know what cryostimulation is? No?
Yes, I do. Like an ice bath.
It's like an ice bath. That is close, but cryostimulation is actually a cold application that involves stepping into a chamber and being exposed to temperatures down to minus 130 degrees for about 3 minutes. And we would like to show you what that looks like.
Where's the tone? We need the tone.
It's no audio.
That's strange.
And it's strange. Yeah, did anyone recognize the subject in the cryo chamber? No? No idea? Lester! Alright. So cryostimulation is currently used for systemic rheumatoid and inflammatory conditions, pain conditions and fibromyalgia, dermatologic conditions, depressive symptoms, and most recently also in musculoskeletal rehabilitation, what we based our PUB on.
Therefore, our literature review investigated the evidence for the use of cryostimulation in musculoskeletal rehabilitation, or more specifically in muscular damage. We assessed the quality of 104 articles, and we screened them on inclusion and exclusion criteria, as well as a cryostimulation specific grading tool that we developed ourselves. In the end, we ended up with 3 articles that passed the grading tool, and 2 of those articles suggest a positive effect of cryostimulation on the recovery of muscular damage, which is not a lot of articles, and this suggests or underlines the fact that it's a very new topic that still needs to be investigated. The lack of the studies, the lack of the quality of those studies actually, suggests that more research needs to be done, and the evidence that we have at this moment still remains kind of a black hole. When we look at the hypotheses of why this intervention is supposed to work, there are some suggestions. The 2 most investigated domains that the studies have been looking at for the muscular recovery are pain and inflammation, which are both suggested to decrease after the cryotherapy treatment. The hypothesis for the mechanism of the decrease of pain is so-called cold-induced neuropraxia, which is a temporary loss of pain sensation. Another hypothesis would be the acute activation of the sympathetic nervous system once the person is in the chamber, which elicits a fight and flight response and suppresses pain perception. And another one would be a post-treatment activation of the parasympathetic nervous system, which works more on a psychological pathway of the pain decrease. If we look at the inflammatory response, this is due to an enhancement of anti-inflammatory cytokines, a decrease of inflammatory markers, which is actually suggested to be due to a vasoconstriction, which blocks the migration of leukocytes to the site of injury. Despite those hypotheses, as I said before, the quality of the studies was relatively poor as they just passed our quality assessment, so the evidence is still kind of controversial. Yet, cryostimulation is increasingly used in sports medicine and in sports recovery. For example, it was used at the World Soccer Cup in Brazil in 2014, even though we do not really have too much reliable evidence about the benefits of the intervention, also as well as the adverse effects that this intervention might have due to the extreme nature of it. So, Mira, what do you think we should do now?
Well, actually, I think we should just write our own study protocol.
That's a great idea.
Based on our extensive literature review, we knew all the flaws of the other studies and how we could correct them. So that's what we did. We wrote a protocol for a high-quality randomized controlled trial investigating the effect of cryostimulation in combination with physiotherapy in patients with muscle strains. So based on our research, we thought a good study should be a long-term study. It should include a heterogeneous study population with muscle strains. It should include randomized recruitment and blinded allocation, clear eligibility criteria, exact outcome measures, and also documentation of adverse effects. So just to give you a quick overview of the setup of our study, take a look at the picture we included here. So you see the patient has an injury, goes to Physiomed, sees a physiotherapist who screens the patient for eligibility criteria and also contraindications for cryostimulation. The brief measurements are taken, the patient receives the physiotherapy treatment, goes into the chamber, comes out of the chamber, post measurements are taken, and that's how it continues. And then after 1 year, the patient comes back and we measure the re-injury occurrence. It wouldn't be a good protocol if we hadn't tested it, so that's what we did. We had a pilot study and would like to show you what it looked like. Just now it didn't have audio, so...
Before it did.
Before it did.
So we don't know. Okay.
No? Strange. Andreas, could you maybe help us for a second? Thanks.
Thank you. So now you got a little insight of what the actual execution of the study would look like, which will hopefully happen in the future at some point. At this point, we would like to thank Bob van den Burg as our PAP coach for his ongoing support throughout the PAP process.
We would also like our client Ivo Timessen, who's sitting in the back, for his continued support, his feedback, and also his trust on a collegial basis. And thank you to Timo
and Charles for their ongoing support during this process and the good PAP moments and the bad PAP moments.
Now we're happy to answer your questions.
First of all, if you would like to have a look at the references, we have a Google Drive folder where we collected our poster, our thesis, as well as our product, and a reference list for you. If you're interested at it, have a look.
Thank you. Frank?
It might be a bit stupid, but can you do this lying down if you can't stand?
It hasn't been done yet, lying down.
No.
Eva?
Can you also do it locally? Because now you do a whole body thing, but if it's a local muscle strain?
Yeah, they have also local applications. But
Yeah.
we investigated the cryo chamber where you go in as a whole, but they also have applications that you just put on your leg and then it only cools down your leg.
Yeah, but they say that because this is a whole body application, they say that it surmounts the effect of local cooling because it has a global response, that the body has a global response to the treatment compared to just local cooling.
Yes.
Just
Well, would like to compliment you because even though you had a study, the quality of the studies that you found, when that is disappointing, then it's sad. It's nice that you found a new opportunity to give us interesting information. My question is, if you want to use it as a physiotherapist, how can you afford the cryo chamber? Isn't that extremely expensive?
It is an expensive treatment, and that's also why we think that it is really important to actually investigate the effect of it, the benefits, but also the adverse effects. It is now implemented in Physiomed. That's where we did the pilot study as well. So that would include, for example, a business plan to actually calculate the financial benefits of this treatment.
It is a very expensive treatment, and so far only big sports club or big physiotherapy practices can afford it.
What is the price of a chair, do you know?
I think around 50,000, I would estimate. Ivo? That is correct.
Thank you. Anne?
Do you know if there's any contraindications for patients-wise that there are certain patients with certain conditions that cannot go in a chamber?
Yes. For instance, if you have high blood pressure, you shouldn't go into a cryo chamber.
So there's a whole list of absolute and relative contraindications. So the relative one, you need to get agreement from a physician, and there's absolute ones. We're happy to provide you with a list, but there's absolute ones where a person should definitely not go into
Also,
a cryo chamber.
If you have open wounds, for instance, you shouldn't go into a chamber. There's also safety procedures. For instance, you have to cover. You saw Lester covered his face. You have to put gloves on. All your extremities need to be covered because otherwise you're exposed to risk for frostbites. Huh?
I might have missed it, but now, what's the main difference or advantage of using this at minus 130 and not an ice pack, which is obviously less than that? Why? What effect does this have more than an ice pack?
A local ice pack?
Yeah, for example.
Yeah.
Or an ice bath.
An ice bath. Well, that's actually something. There have been some studies out there that compared the ice bath to the whole body cryotherapy, and those few studies, they didn't find a big difference. However, the mechanism of it is very different. The temperatures are very different. An ice bath does not go down to minus 140 degrees. On the other hand, water conducts cold much faster than air. But the difference is also still investigated because there is a difference, but they don't really know yet how significant the difference actually is.
And the reason why for athletes they choose to use the cryo chambers is that it's a lot more comfortable to go into such a chamber than jumping into an ice bath.
Which is actually true. We did it ourselves.
More questions?
Yeah, I think it was quite clear that you started with basically stating that the amount of evidence on this treatment is quite low at the moment. But I was intrigued by the slide that was accompanying that. It said there's no reliable evidence. Can you explain that? What do you mean by reliable evidence?
We did find studies to suggest a positive effect, but the studies were still, they just made it into our literature review, so it just passed our quality assessment, which means it's still not very reliable. Also, it was only 3 studies included. Does that explain it?
So the lack of evidence is not based on negative findings saying that it doesn't work. It's more that the quality of the studies is not sufficient in order to explain the hypotheses how it works.
Exactly. So that led us there to say there's still no evidence in the end until now.
I see. Yeah, I like this. I prefer this last way of putting it, I would say. Technically spoken. Okay. Right on schedule. So thank you very much.
Thank you. Oh,
I have to like connect my laptop, so I tried it yesterday.
Turn this off.
As long as this.
Yeah, I'm not gonna try. Better? Okay. Hi everyone. Most of you people know me. My name is Ehsan, but for the people over there, I'm going to. Okay, I lost my notes for a second. My product was two information. Booklets, online information booklets for the patients of the Sport Medical Center in Amsterdam. And you might wonder why I'm alone. I wasn't alone. I'm going to explain it very short, the story of me being alone standing here. But first, let's take a look to the content of my introduction. So I'm going to start with a short introduction and explain to you about the history, and then I'm going to introduce my client to you, and then I'm going to after that I'm going to talk about my product, which I produce my product. Is this the whole time? Really? Oh yeah, okay. Okay. Thanks. So yeah, and then okay. So I'm gonna start with the introduction. As I explained, the project plan I was with Kaylee, but due to circumstances, personal circumstances, she couldn't continue with the project, so I had to finish the final product by my own. But she was helping me and during the and finish the project plan with me. And then my client, as I said, is Sport Medical Center Amsterdam, Peter Offerman and Michiel Lubert, and the coach Bob Vandenberg. So very short history regarding my client. Sport Medical Center is one of the biggest sport injury centers in the Netherlands, with 300 patients a day and 45 physiotherapists working in the practice. And to show you, and I use the product of my PAP to upload in their website, and I show you a very how it's implemented in this website. As you can, I think most of you understand what's the meaning of this and how does it work. The patients and visitors of the website can click on this body figures and they find information regarding. They will guide it to a document, and then this document has some information regarding their problems. And I use my I made two information booklets regarding knee and hip joint, and they will be used in this for their website. Okay, so now like the purpose why I choose to why did I try to make these products, because as you all know, internet is a part of our lifestyle these days, and we all using internet as a source which we all trust, which is sometimes it's a right thing or wrong thing. But specifically regarding health, and more specifically about the country, the Netherlands, the 60.7% of the people in the Netherlands, they think finding information regarding health is a good way, and it's a trustful way to find their answers. And the research also shows if the patients be able to find the right information before they visiting clinicians, it has advantages and it's beneficial for the treatment or the rest of the way. So this is my the product characteristics. As I told you, two different joints, and then I make these products easy to understand for the visitors, for the patients, by using hyperlinks and videos and pictures. I'm going to show you my products to you later on, but to give you an idea, after some meetings with my client and coach, we decided about hip joint and knee joint. As I explained already, I started with the structural anatomy explanation, and then biomechanics and movement of these two joints, and then most common injuries, as you can see in this table, and most importantly, which I use my systematic literature review in a conservative intervention for hip osteoarthritis and ACL, anterior cruciate ligament injuries for the knee joint. And then of course I explained the operative intervention inside the booklet. So I'm not going to keep you waiting more than this. I'm going to show you my like this is the hip product. Just as you can see, I start with explanation regarding anatomic terms, and then the movement. The population who are living in that area of Amsterdam are mostly educated, and the patients of this specific of Amsterdam Medical Center are mostly involved in sports, and that's why the level of the information is not so low, but in a way that academic and understandable for those. As you can see, I use videos, hyperlinks to videos and pictures, and Yeah, and then I use my literature review to explain to you in this part of this of the product, and then at the end, as you can see, the operative procedure for total hip replacement. Like, for example, this is one video. Like this is the way that, like in Dutch, in a way that they can prepare themselves for the total hip replacement. And the knee also, if just a very short, very short. And then I'm going to start with my literature review regarding this. Again, as I said, like same structure, but regarding the knee joint. Exactly the same structure. And okay. And now I'm going to talk about the hip osteoarthritis, which was one of the systematic literature review that I have done. Conservative evidence-based practice treatments for hip osteoarthritis. I used randomized controlled trials, controlled clinical trials, and the studies had to include adults with clinical and radiological of hip osteoarthritis, and had to investigate the conservative treatments. In English language, I exclude the studies that use operation as intervention. These are the sources that I used, but not only for the whole product. I used a lot of different sources, as you can see. Like after my initial research, I found 436 articles inside the different databases and sources, and 162 articles were removed due to duplication. 274 articles were screened, and at the end, like if I don't want to explain all of this to you, I had end up with 7 articles, which you can see them here inside this in this table. They mostly compared manual therapy, exercise therapy, and combination of these two, manual and exercise therapy, with control group, with GP normal medical care or patient education. And the results, exercise therapy was the one that 6 of these articles mentioned that it reduced pain and improved the physical function. Manual therapy had a short-term effect regarding pain. I can explain the outcome and the way that they are they measure this if you ask me later on, and but combination of these two doesn't show any effect. And one of the articles mentioned to the time that split it between these two, exercise therapy and manual therapy, maybe couldn't let the effect be significant. When it comes to knee ACL injuries, again the same procedure. I used the randomized controlled trials, controlled clinical trials, and participants with had to diagnose with positive clinical examination of ACL rupture. And I also used researches that studies that there were like multiple damage to different parts of the knee. But if I could extract the results of the ACL, and I exclude the studies that the inflammatory arthroplasty or end stage of osteoarthritis. So again, these are my findings. 985 articles were found, And after inclusion and exclusion criteria applied, 6 articles were included in this study. This is the studies that I include in my systematic literature review, and they compare physical therapy, functional bracing, balance training, and activity modification as their intervention, and they compare these with like different exercises. For example, open kinetic chain exercise for knee with closed kinetic chain exercises for knee, and they compare these together. It's very difficult actually to decide if the patient should go through the conservative treatment or should go through the ACL reconstruction, because but most traditionally they use the activity level of the patient as a determination for going through the conservative treatment or not. But after this literature review, I would offer physical therapy, functional bracing, and balance training and activity modification could help patients with ACL injuries. But again, it depends to the activity level of the patient. And that was my presentation.
Okay. Questions? Jose?
Yes. Sure.
I have a question.
Yes.
Is the website already used?
They had a presentation inside the clinic, and they're going to use it, but they haven't used it yet. No.
I was wondering, and you say that people are well educated, but if you have the website in English and a professional language, did you check if people can?
Yeah, that's one of the reasons that they haven't used it, because we were supposed to, Kaylee and I were supposed to do it together. So Kaylee was supposed to do the Dutch part, so we were supposed to do it in 2 languages, but the most importantly was the Dutch language. But that's the main reason that they haven't used it yet. I think I'm kind of sure that they are trying to translate it and take the parts that they need and use it in the website. But there was a presentation inside the clinic, and yeah, that was they were like they are going to use it.
I had contact with the client, which I begged him to make sure that it's online already, but he said, well, the company who has to do it takes a lot of time. So it's not published, but for sure it will be.
Okay, I ask another question. Yes, you had the website is for patients that you can see what they can expect.
No, yeah, kind of. You can say yes.
And then I think the findings of your research is what is the best treatment.
Yes.
So how they?
The one part of the product is that yeah.
Wait for my question.
Yes.
So why don't you first need to inform your colleagues, the PTs, what's the best treatment before you put it on the website? How did you make sure that they were aware of the best treatment?
I've like throughout this project, I was reading, like we had meetings, and like even the articles, they were like I shared my findings, and then what I have write in the document especially regarding the conservative treatment for ACL and hip osteoarthritis is completely checked by Michiel, or mostly by Michiel, and it's and that's they are my clients and they accepted it. I don't know if I answered your question, but I have shared my findings with them, and then put them in the document. Yeah. Thanks.
Yeah, whether they actually use the interventions like this, that's always
Anybody else? Well, actually, it's actually on time. Thank you very much.
Thanks.
Hello? Mine's on?
Hello? Yeah.
It's on the top, there's a little button.
Yeah, but the first should be supposed to be switched off.
Okay. Try it again. Hello?
It's on, right?
Is it working? Hello? Yeah.
Okay, and the other one? This one.
Yeah, I think mine's.
Okay. No worries. 2 more minutes.
Yeah.
Right on schedule.
Look at the coach now and then for the time management.
Okay, cool.
I'm in and out of the room, so I have to prepare the other room as well.
All right.
Okay, good luck.
Thank you.
Okay, thank you.
Can we start? Okay, good afternoon everyone. My name is Jermo and this is my thesis partner George. We would like to present our thesis to you, but first of all I would like all of you a question I'd like to ask you. Who of you has had a headache at least once in the last year? So who of you has had a headache at least once in the last 12 months? Please raise your hand if that's the case. That's a lot. It could be due to the exam that we have these days.
ESP?
Actually, the WHO made a report about the headaches, and they estimated that almost half of the adult population has had a headache at least once in the last year. So this is a huge number. And not only that, the World Health Organization also estimated that all headache disorders combined are the 3rd highest cause of years lost to disability. Also, it comes with a major financial burden, the headaches. For example, a study by Steiner et al.
they estimated that the financial cost due to lost working hours and working days is approximately 1.5 billion pounds in the UK alone. So you can imagine what the costs are if we combine all countries together. But what do we actually know about tension type headache? Well, actually not so much. The cause is still relatively unknown. We do know that it's characterized by bilateral pressing on the frontal area and the occipital area of the skull. We know that it's mild to moderate intensity, and we know that it's not provoked by physical activity. So what is the clinical relevance for us as a physiotherapist? Well, we know there's a major financial burden on society. We know there's a major burden for the individual itself who's suffering from the headaches. And interestingly enough, there isn't any evidence-based guideline for physiotherapists in treating tension type headache. So that also brings us to the thesis. So the aim of our thesis was to investigate physiotherapeutic interventions in treating tension type headache based on scientific research. Well, how did we do it? We looked at RCTs and systematic reviews, and we divided the articles into 4 groups. So we divided the groups into manual therapy articles. That's the group of manual therapy.
Inclusion.
Manual therapy. We had a group of exercise therapy, a group of behavioral therapy, and a group of other physiotherapeutic modalities. So the last group were articles that did not fit in any of the other 3 groups. For example, EMG biofeedback. Okay. Can you go next? Next slide. Okay. So inclusion criteria. We included articles that had only focusing on physiotherapeutic interventions. They had to be published in the language of English or Dutch. They had to be published between 1989 and 2016. We included articles who use subjects of all ages and male and female. Okay. The exclusion criteria. We excluded articles which used pharmacological interventions. We excluded animal studies, articles that were published in a language other than English or Dutch, and studies that were published before 1989. Okay? So that brings us to our search strategy for retrieving the articles. We looked in 4 medical databases. We looked at Medline, CNAL, Cochrane, and Pedro. And in these databases, we retrieved 301 articles. Of those 301 articles, we removed 190 duplicates, and the remaining articles we did a quality check, and we used the CASP screening checklist for the quality. After the quality check, we ended up with 8 RCTs and 6 systematic reviews. Okay, and George is going to explain us something about the actual findings of the included articles.
Okay, so once we're looking at the results with 6 systematic reviews and 8 RCTs, we've split into our 4 main intervention groups. When we were analyzing the systematic reviews, we saw favorable effects within all of the manual therapy systematic reviews, although all of them had inconsistencies within their study designs and their interventions chosen, leading to no solid conclusions being made. For the exercise systematic reviews, that was very similar. The interventions which were chosen were very different from between the studies, leading to no conclusions or no conclusions on the true effectiveness of exercise on tension type headache. In the behavioral group, there was quite an extensive study done with 44 articles, but this again, they weren't able to draw conclusions because of the lack of evidence in the study. Looking at our randomized control trials, in the manual therapy trials, some interventions which proved significant were cervical, soft tissue massage and trigger point therapy, as well as mobilizations, manipulations, and a combination of these, all with significant results. The exercise therapy group showed significant results with a strength program of the upper body and trapezius in specific. Behavioral groups, some of the interventions which which were significant were mindfulness-based stress reduction, guided imagery, and relaxation therapy. In our final group, the other physiotherapeutic modalities, the biofeedback was proven no better than relaxation therapy, with basic relaxation exercises, and both superficial dry needling and intramuscular dry needling were both seen to be significant from baseline. So, what can we conclude from that? We saw significant results from all 4 intervention groups regarding headache intensity, duration, and frequency, although there was a lack of homogeneity within the study designs and the choice of interventions. So therefore we conclude that there was a poor quality of evidence to make a solid statement regarding the true effectiveness of physiotherapeutic interventions in treating tension-type headache. Where does this lead us as physiotherapists? So what we've done for our final product, we've made a flow chart looking specifically at the interventions, but you can't have a flow chart without a screening and an assessment. And on the back side of the flowchart, we've got a bit of a description of how you can interpret the flowchart. So from the assessment and patient history and screening, one can take into consideration specific outcomes and from that determine which of the intervention groups the specific patient fits into. So whether they have maybe a deep neck flexor deficiency, they can have some cervical muscle strengthening, isometric endurance strengthening. If they have a lack of coping strategies, we can put them more into the behavioral group and maybe give them one of the behavioral therapies, such as cognitive behavioral therapy, mindfulness-based stress reduction, and so on. So we also were unable to encourage or discourage the use of dry needling because of the lack of evidence, and the use of EMG biofeedback was discouraged mainly due to the cost, its high cost, and similar findings with a basic relaxation program. So, what can we recommend? So in future studies, we'd like that the quality of the articles is better, showing similarities within the interventions chosen, the study designs, and also some larger study groups to be looked at. And that's it. So we've got our references there. Lastly, we'd like to thank our coach Jan Jaap for his guidance in the scientific field, and Arend for the practical point of view. We hope that this final product is of use to our client and is shared between physiotherapists when found of value. Thank you, and any questions, please?
You speak about that you recommend to homogenize the research. What would be the tool? What is something can be
advise to make the study be based on the same outcome?
Yeah, so maybe look at the intervention, look at the studies that have been done, and maybe do them again, so that we have more studies with similar designs. At the moment, the choice of interventions is all over the place. The choice of exercise that you use is not consistent.
Yes.
So
it basically makes it very hard to compare the studies as well, because they all have a different study design, so it's very hard to compare them with each other. And above all, there were a lot of articles also excluded because they just didn't have a high quality. We used to cast a screening checklist, and it's like 8 or 9 questions, and they look, for example, if the examiners were blinded, how big was the study group, and all these things combined gave an indication of the quality of the articles. And we found that a lot of articles had to be excluded because the quality just wasn't good enough. So I think it's very important for future researchers as well that they make sure that the quality of the articles are good, and that they make sure that they all use the same study design, so that you can make better conclusions on the actual true effectiveness.
Yeah, you guys described 3 different groups, and one group was a manual therapy group. So what are the criteria, or what are the characteristics of people that fall into that group?
So manual therapy was looked at, we described it as actually so manipulations, mobilizations, and massage, and so the patient having to be the active participants in the therapy, rather than maybe in the exercise group. So it was very broad, the manual therapy, so it wasn't just mobilizations or manipulations. It kind of incorporated a lot of different types of manual therapy.
And when you look at the flowchart that we ended up with, it basically states all the interventions that were proven to be effective, and also passed our grading of the quality of the articles. Let me see, where is it? So, where is it? Yeah. So here, when you see the yellow box, these are all the interventions that are proven to be effective for exercise therapy. In the green box, you see all the interventions that are proven to be effective for behavioral therapy, and the blue one are all the interventions that are proved to be effective for manual therapy. And I also have to state that we think it's important to always choose a biopsychosocial model, so that you combine all 3 in your treatment. However, if you see that someone has deep neck flexors, you choose to focus more on the exercise intervention. But I think, or actually we think, that it's important to always include all 3, but you just focus on the part where you see your patient is scoring the lowest on.
Thank you for a nice presentation. You stated in the beginning very quickly what the tension type headache is. Can you tell me a little bit more about the other types of headaches, and maybe again what the tension type headache is?
Well, that's the funny thing. Tension type headache is still relatively unknown, so we don't know that much about it. We do know that what I just said, also that there is mild to moderate intensity. But there are also some studies that suggest that there is a neurological link between tension type headache. But all these studies are just, they're not conclusive.
What is the definition that you use for tension type headache?
Sorry?
What is the definition that you used for including tension type headache?
We used the bilateral pressing or tightening in the frontal or occipital area of the skull.
So this is according.
Definition of tension type headache.
Our definition was according to the International Headache Society's definition of tension type headache, which was already quite vague and could actually be also be combined with a migraine, or quite often you have. Patients that have tension type headache and a migraine, or tension type headache and cervicogenic type of headache. So I think the whole headache umbrella term or whole headache topic is very diverse, and there's over 200 different types of headaches, so it's very difficult to be precise in what is exactly a tension type headache.
Do you see any change in the future? Because one of your advices is that more research needs to be done. It's very vague at this moment. A lot of intervention research has been done, but the outcome is actually vague. Is that also has that also to do with the definition of the possibility to divide different types of headaches?
Yeah, I think so. Like George already said, there are more than 200 different types of headaches according to the International Classification of Headache Disorders. So that already says something about the complexity of headaches. So I think there's a lot of overlap in headaches, but it also is very complex. So I think that's very important to mention as well.
One last question. Is the product only for your client, or is it also possible for other people to access this product?
Well, yes, other people, we would allow other people to be accessed if they would like. They could get in contact with us, but we don't have it on any platform at the moment where other people could access it. They'd have to get it from us.
We'll make sure that it's published, maybe on the ESP website if that's possible. We'll make sure that access is for everyone who wants to read it and thinks it's interesting.
Yeah. One last question possible for the
I don't know if it's the purpose of this presentation, but you said that a flowchart cannot actually be without a part related on assessment and screening. Eh? So
yes.
You haven't presented that now, but I am still curious if you can maybe briefly say something about that part.
Well, yeah, that wasn't our main focus of our study, but so we were looking at assessments and patient assessment tools which would guide the physiotherapist towards one of the intervention groups. So in the physical examination, you can have a look at. We did find some articles though which had consensus over specific tests used, with deep neck flexor muscle function, looking at posture, so cervical range of motion, and then maybe for strength, craniocervical flexion test. But yeah, again, we didn't go into too much. We just found these, and then they linked towards our treatments and what we had found.
And these measurement instruments that we mentioned in the assessment part are all based on scientific literature. So we did back it up with scientific literature. For example, the CCFT, the craniocervical flexion endurance test. That one is there's a consensus statement saying that it's important to use that test as an assessment. And that test, for example, guides you to the intervention. Then you can say, okay, maybe we should focus on the exercise therapy, because I saw during the CCFT test that this patient scores low on the CCFT. So that's how it's based on, so they're all interwoven with each other.
Thank you.
Okay, thank you very much. Heel bescheiden kom ik zo aanschuifelen.
touch me. Cheers. Let's wait for them.
Okay, scroll down.
Oh, good. Okay. Okay, hi guys, welcome. Welcome to our PUB presentation. Thank you for all being here. I'm Dan.
I'm Annette.
And we're going to tell you a little bit about our project, which is titled Physiotherapeutic Screening, Assessment, Treatment and Prevention Methods of Central Sensitization in Osteoarthritis, with as an aim to develop an evidence-based clinical handbook. So Annette, can you tell us a little bit about what we did and why?
Well, we all encounter pain as physiotherapists and medicine in general, or healthcare. It's arguably the #1 thing encountered in practice. But there's a lot of ideas about pain and uncertainty, especially chronic pain or persistent pain. And our goal was to transfer what's been developing in pain science and research to practice. And so our goal was to clarify things and simplify things for physios and students about persistent pain. So first of all, we narrowed down the terminology to use persistent pain. And throughout our research about pain, we've come to see that there are pain mechanisms, and we chose to focus on central sensitization, which is a developing topic in persistent pain research. We chose to focus on osteoarthritis because this is a pathology in which all of the pain mechanisms can be encountered, and then our end product is a clinical handbook, which can be used by physios and students.
So, what is the clinical relevance? Why do we want to get away from the idea of the pathology as osteoarthritis and focus more on the pain mechanism classifications within osteoarthritis? Because traditionally it's seen as a nociceptive pathology, so there's a degeneration and that causes pain. But more recently we've seen that 36% of patients with osteoarthritis actually have central sensitization as their main contributor to their pain picture. To make it even more complex, there's discussion that there are also neuropathic components to the pain in osteoarthritis. And this recognition of pain mechanisms is not well taken up by the clinicians, let's say. And that explains the high rate of patient dissatisfaction with osteoarthritis treatment that is currently a topic. Moreover, another problem is that the effects of treatment on central sensitization in osteoarthritis are not well established. So we wanted to dive into that and aid in changing the treatment paradigm that is apparently needed.
So we looked at the evidence and overall, we decided to write 2 systematic reviews. I focused on screening and assessment, and Dan on treatment and prevention. My research question was, what are valid and reliable clinically applicable methods for screening and assessment of central sensitization in osteoarthritis proposed in best recent research? In other words, we're looking for tools that can be used in the clinic that directly assess for and screen for central sensitization in osteoarthritis patients.
My focus was on the treatment and prevention part of it. So what I wanted to look at is what are currently proposed treatments for central sensitization, and what is their effect specifically on pain intensity ratings within osteoarthritis. So we started our search. We decided to search in PubMed and Pedro, and did so extensively, because if you want to know a little bit about pain, you have to do a lot of reading, trust me. Then we decided our inclusion criteria.
So for screening and assessment, in order to be included in my systematic review, subjects had to be diagnosed with osteoarthritis. Tools that were included in this articles had to check for central sensitization. The article had to be published within the last 10 years, and outcome measures had to be applicable in the clinic and relevant to physiotherapy.
My criteria were very similar. The main difference was that I looked at one outcome measure, pain intensity, which would make it very easy to compare different outcomes. Also published last 10 years. For the treatment articles, I only included RCTs, and subjects had to be diagnosed with osteoarthritis, often done by radiography.
And then in order to grade the quality of the articles, we used a variety of tools. As Dan used only RCTs, he used the Pedro scale, and I had a variety of non-randomized trials and systematic reviews in my systematic review. So I used the Robens and the AmStar checklist for systematic reviews. So for my results, I ended up with 46 articles, which is quite a good amount of articles, 42 non-randomized trials, and 4 systematic reviews. They all turned out to be high-quality studies. None were excluded due to quality after grading. And only 3 of the 42 trials scored the lowest score possible on the Robens, which means there was a higher risk of bias, and this was due to confounding factors, or one study was missing outcome measures. The screening, overall, the screening tools, or the recommendations for screening were using radiography and checking for risk factors for developing central sensitization. And for assessment, recommendations included direct and indirect measures of central sensitization. In history taking, pain and non-pain should be considered, and in the examination, hyperalgesia, allodynia, wind-up, referred pain, and tenderness should be taken into account. So this table on the right, you just have it summarizes the tool that was recommended in my systematic review. The next column shows the type of tool and where it can be used during the assessment process, either in screening or in a history taking, etc., and whether it's an indirect or direct measure of central sensitization. And then the following column shows you how many studies were using that tool, and then the average study quality for each tool.
So in my results, I found that most of the interventions proposed had a large perception adapting component to them. So they all focused on cognition, on behavior, on information processing. I ended up with 16 studies included, all ranging from 5 out of 10 to 9 out of 10 on the Pedro scale. In the table you see on the right-hand side, there are the 6 studies that showed the significant difference between the intervention and the control group. All the other studies did not do so. And it seems from here that pain coping skills tends to be something we should consider using when encountered with these patients.
So for the discussion, we came to the conclusion that osteoarthritis pain is complex and diverse. So this calls for a multidimensional approach within a biopsychosocial framework. A mechanism-based approach is feasible, and objective and subjective measures should be used. However, there's still a lot of questions about standardized protocols about these measures. So that's something to narrow down for future studies. And the interventions should, as Dan mentioned, target reconceptualization of pain. One of the main limitations in our reviews were that the majority of our studies focus on hip and knee osteoarthritis, and as we all know, there are different types of osteoarthritis that touch the hand or the spine. So when generalizing our results, this should be done with caution.
Also, another limitation is that central sensitization specific intervention should actually include exercise, general exercise. We chose not to include this because there is a large body of research on exercise in osteoarthritis, but not coming from the same angle as we were trying to get at. Another one is that intervention trials do not take pain mechanisms in osteoarthritis into account. That means that you have your group subject with osteoarthritis, but there's never looked at, okay, is there central sensitization in this person or not? Which means that your treatment might not be specific enough. But
so breaking news, we got our hands on a soon-to-be published article where this is actually done. So the future of treating pain should focus on finding the source of the pain, meaning the underlying mechanism, which will lead to more appropriate treatment and better response, more positive response to physiotherapy. This is that sneak preview of this article. We had a Skype with one of the main researchers in this field, and he sent us this article, which will soon be published, where he's confirming our results.
In conclusion, we call for a mechanism-based approach to osteoarthritis pain. No screening assessment gold standards is there yet, but we recommend a set of clinically relevant criteria, soon to be confirmed by other researchers, which is nice. Central sensitization assessment should be an outcome measure in intervention research as well, and best available evidence at the moment favors interventions with a focus on adapting cognitions, behaviors, belief, information processing, including exercise therapy. Thank you.
Thank you. And we would like to thank Nefeli, our client, Nefeli, our client, who's not here, but she's watching by thanks to Physiotutors, and Vasiliki, our coach.
Thank you. Any questions? No?
Yeah, you've mentioned the mechanism-based approach several times. So if I'm the clinician and I haven't read that much about this specific central sensitization, and I do see a patient like that, tell me then exactly, or can you take me through a few steps? What must I specifically do? Because the mechanism-based approach doesn't tell me that.
Well, that's the nice thing that links to our product, because we created a product for clinicians that have this specific question.
Yeah, conveniently, we added some examples. So, for example, in our product, we try to make it simplify the topic really for clinicians and explain with an introduction about pain, central sensitization, what is it, and how it can be assessed and treated in osteoarthritis patients. Then we go through step by step each process. And so, for example, in screening, we really try to break it down for you. And then central sensitization, when it comes to a mechanism-based approach, we have the points to cover in sensory testing, for example. That really, what's the word?
Okay, well, let's take, so to keep it concrete, yeah, so that and understandable for people that are not so it's an expert in this topic now. Can you go back to that one slide? I mean, what, for example, how do I test increased pain response in the dorsal horn? What must I do? Where must I touch, or how must I screen, or what tool do I use to test that?
Quantitative sensory testing is the most objective way to do that. And so there's still a lot of questions about which part of, there's many forms of quantitative sensory testing that are recommended in the literature that we included in our reviews. So, for example, pressure point threshold, or heat pain threshold. These are the tools. We give a toolbox of tools that can be easily accessible and used in the clinic. And so, for example, you can test using any one of these tools, pressure pain threshold, in the clinic. And in our handbook, well, it's not here, but in the handbook, it's a 100-page handbook. We go through step by step exactly how this can be done. So we really try to simplify it, because quantitative sensory testing can be kind of intimidating when you hear the term. But that was the goal of our handbook, really, to break it down.
More questions? Yes, please.
How is your client going to use this product?
She's very involved in research on this topic, so this was interesting for her just to already get an idea of how this research can be applied in the clinic. She said that she would use this in practice. She was really happy with our product.
She's involved in research, so she's not clinically applying it on patients.
It's a nice tool.
Yeah. 300 pages.
Yeah, 100 pages, lots of work.
Yeah.
Yeah, well, the how we came to be, or how Nefelli came to be our client was perhaps a little different than the standard procedure.
Your critical opinion about it. If your client cannot use it, do you think you could make use of it somehow?
I mean, what she will, because I know she's active on the social media now, she's starting something up, so she has a platform where she easily can provide other practitioners with information, such as this complete handbook, which will be a nice resource.
But I know you're interested also in this topic, that's why you chose it, so
Yeah.
I think you will use it, or you will collaborate with your client.
Well, one kind of cool thing is that over these past few months, after we finished our product in February, we contacted some lead researchers in this field, and they were really excited about our product and impressed with our work. So they suggested that maybe we can collaborate with them in the future. So there's maybe some possibility for collaboration in the future in that sense with them. That's not exactly our main client, but yeah, it's other people who are in this field.
All right, any other questions?
How can we get our hands on the handbook?
You can email me at vandenakker.dan@gmail.com, and for a special fee, it might be yours.
No, yeah, we can email it to you, or we can somehow email it to ESP.
All right.
Thanks, guys.
Thank you very much.
Yeah, we put these on. Put these on the jacket and did you check the casting? Yeah, I'm checking it now. Yeah, I have 2 hands, so.
Yeah.
And there's 3 cameras.
Well, we have some other technical problems in the other room as well. So.
What is this?
Okay. Deze mag ik alleen daar nog eens.
Okay.
Okay. Does it work or no?
Where I am.
It's not working, right? Is it? Okay. Okay. I don't know. Yes. Is it possible to make it bigger? Oh no. Presentation? Yeah, full screen. No.
This is
weird.
But that is the full screen.
How is that working?
That's the full screen.
Yeah, but we want to not see the top of the screen. That's a lot.
I think it's because it's casting. I can't make it bigger.
That's alright.
This is all I can do.
Yeah. Okay, well, let's go. Yeah, you go. Alright, so when they're ready. Yeah. Alright.
Welcome everyone to our presentation. I'm Eva Bednarczyk and this is Anna Serafini. And today we're presenting our thesis called Hypermobility and Proprioception. How do they relate to each other and are physical activity and muscle fatigue of influence on this relationship? Our subtitle was our product, which is called Implications for a Pilot Study to Investigate if Proprioception is Altered in Healthy People with Generalized Joint Hypermobility. The coach for this project is Vasiliki Folia, and the client is Mark Scheper, who is not here right now, but he might be later. He is a PhD candidate who is performing research at the AMC, where his main focus is hypermobility and related symptoms in children. So today we're going to show you what our product was and how we came up with the idea and how our 2 literature reviews that we conducted actually contribute to that product in the end. First of all, we need to define hypermobility. Hypermobility, which is also called double jointedness, refers to joints that stretch further than normal. Generalized joint hypermobility is common and occurs in about 10 to 20% of the healthy population, which is normally not accompanied by any pain or musculoskeletal complaints. But when it is called a hypermobility syndrome. Since March 2017, there have been 2 new terms that have been created to cover this hypermobility syndrome spectrum. They are hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder. For now, we're not going to go into the distinction because it's very detailed, but we will call it hypermobility syndromes or symptomatic hypermobility. So far it has been shown that people with a hypermobility syndrome have decreased proprioception, but it is unclear whether this decrease in proprioception is due to their laxity or due to something else. This is why for our research protocol, which we created for our client, we came up with the research question, which is proprioception altered in healthy individuals with generalized joint hypermobility compared to non-hypermobile individuals? If this is the case, then the common laxity may be the cause for the decrease in proprioception, but if it is not, maybe something else in their pathology might be the reason for their decrease in proprioception. This will hopefully help clinicians to tailor their intervention programs towards the actual risk factors for injuries and pain in these patient categories, and not just the presenting pain or injuries as they occur. So in order to come up with a product that's a research protocol that had relevant other variables that might influence proprioception, we created 2 literature reviews. One of them was the effect of muscular fatigue on proprioception, and the other one was the effect of regular physical exercise on proprioception.
Okay, so I researched what is the effect of muscle fatigue on proprioception. We choose fatigue as a topic because fatigue is a common symptom in hypermobility people syndrome. We know also in the fatiguing activities mostly leads to injury, like at the end of a match, for example. We know that proprioception is mediated by sensory input derived from skin, ligaments, joint, and muscle receptors. Muscle receptors is seen that they've shown that play an important role in detecting joint position sense. So what we want to find is that if we fatigue a muscle, then there might be a change in proprioception. So I researched through database of PubMed and Google Scholar, and I am following the key terms, using appropriate key terms and Boolean operators. I screen the articles with inclusion-exclusion criteria, and I assess the quality of the tools with the Downs and Black checklist. These resulted in 14 articles that shows an overall lack of quality of studies. So 4 articles show that significant decrease in proprioception after a fatiguing protocol. 5 articles did partially support this decrease in proprioception, and 5 articles did not find any significant result in proprioception increase. So as a conclusion, we say that muscle may influence proprioception, but due to the lack of quality of the studies, it's difficult to give a definitive answer.
Right. My research question was, what is the effect of regular physical exercise on proprioceptive control? As we know that hypermobility syndrome, people with hypermobility syndromes, they have significant pain and disability. This may lead to pain-related kinesiophobia, which eventually can lead to deconditioning if it continues this way. It has been shown that physical exercise, and especially regular physical exercise, has a beneficial effect on many of our bodily systems, but it has never been actually shown that what the effect is on proprioception itself. If regular physical activity indeed has an effect or a positive effect on proprioception, then being and staying active may be a way for people with a hypermobility syndrome to prevent a decrease in proprioception and therefore also prevent an increase in risk of injury. I also did a systematic search in the databases of PubMed, Pedro and Google Scholar with relevant key terms, and after that I assessed the eligibility of the articles using the inclusion and exclusion criteria. I had two different types of studies that I included, so I used two different tools, which are the Downs and Black checklist for the cohort studies and the Joanna Briggs Institute checklist for the cross-sectional studies. After my search strategy, I had 21 eligible studies, of which 17 were included in the final review after the grading. Because there was not a big difference in the grading quality of the articles, there was not a large range of scores, I decided to take into account all articles equally and not take into account their actual quality. In total, there were 6 articles that found a significant effect of physical activity on proprioception, 8 articles that found partial evidence or inconclusive evidence, and 3 articles that did not find any evidence at all. So although the evidence is not unanimous on the effect of physical activity on proprioception, we think that because the majority of the articles shows either a significant effect or a partial effect, it still may be beneficial for proprioception.
So based on the findings of the 2 literature reviews, we made a protocol for a pilot study for our client. That will answer to the research question: do people with generalized joint hypermobility have decreased proprioception compared to people with no hypermobile joint? Then we will take muscle fatigue and activity.
Into account.
Activity. Physical activity into account. So if from this is a setup of our protocol, if proprioception in people with generalized joint hypermobility will show a decrease in that will show that ligament laxity can be a cause of this decrease on proprioception. Muscle fatigue, proprioception will be measured pre and post a muscle fatigue protocol, and if people with generalized joint hypermobility show more decreased proprioception than people with non-hypermobility syndrome, non-hypermobility joint, then we can say that fatigue have a greater influence in people with generalized joint hypermobility. If physical activity is beneficial for generalized joint hypermobility, then will be expected that more active hypermobile people will have a better proprioception outcome. And
So although we have not actually done this pilot study for now, so we cannot make any clinical suggestions on the results of this study, we can only tell you our expectations of what we will actually find. So for now, the actual implications for PT will actually be not very relevant at this moment, but we hope that in the future this research will lead to better strategies for treating people with a hypermobility syndrome, because then the treatment will be actually targeted towards the right factors, we hope. So yeah, that's kind of our product for now. We would like to thank Mark Scheper for his enthusiasm and his ideas throughout this project and his expertise in the field. We would like to thank Physiotherapy for her feedback and her motivation throughout the project. We would like to thank Bob for his second reviewer feedback, and especially Elon, who started with us during PAP 1 and partially PAP 2, but he decided to not finish with us for now. But we would like to thank him for all his help throughout the project. Are there any questions for now? Dan.
How do you measure proprioception?
We measure it on the Biodex machine. So we measure the threshold for detection of passive motion, which is part of a proprioception modality called motion sense. So basically we put the participants on the Biodex machine, and then from a 45-degree knee angle we will move their leg either towards extension or flexion, and they press a button when they notice the movement in their leg. And then the actual the timing of that will be the threshold for them, like how quickly they actually notice the movement. Mira? We use the Baton criteria, so I don't know if you want to explain that.
Yeah.
Well, we use the Baton criteria. There are 4 criteria that you measure bilaterally, which is the hyperextension of the knees, hyperextension of the elbows, the passive extension of the little finger, and the opposition of the thumb towards the flexor side of the forearm. You measure those bilaterally. Each one that scores like a normal or like a further than normal range of motion, more than 5 degrees difference, with a normal range of motion, that will be counted as positive, gets 1 point. And then as a 5th criteria, you measure the forward flexion of the trunk and to see how the finger floor distance, if they can actually touch the floor. And this can give a 9th point. So in total you can get 9 points, and more than 5 points would be hypermobile in our case. Yes, sir?
Yeah. First of all, thanks for your presentation. Could you say something about the quality of those measurement tools?
Yes, I used the Down and Black's checklist, and it's shown as a valid tool for different types of study. So we based on a valid.
I mean proprioception.
Oh,
sorry.
Oh, okay.
So especially that one, because you explained how you did it.
Yeah.
Can you explain also what your own opinion is about that measurement in relation with?
Well, it is a valid tool, but there's a lot of discussion on the exact cutoff point for what actual hypermobility is. So sometimes they use 4, 5, 6. There's also different cutoff values for children, and so it's very hard to establish this because especially in children, hypermobility may be normal, whereas in elderly or like older people, the older you get, the less lax your ligaments will be.
And plus we didn't find any. We found. The Baton score and the assessment tool as the only way that we found.
Yeah, the only reliable way to measure this.
And so we rely on, we choose that one because we didn't find any other reliable tool.
Yeah, but it may also be influenced, like for example, if you've had an injury in one of your joints, then it may give a laxity, but it's not actually due to generalized joint hypermobility, but due to injuries or something like that. So in some joints you may have hypermobility due to another reason.
Yeah, because the measurement of the proprioception is done with how you explained it.
Mm-hmm.
Is that the best way to do that? Or let's say in other words, is that also the way we do it in clinical practice? Or
no.
Is there a huge difference?
No, it's not as functional as we would like it to be, especially because for fatigue it's usually more in a weight-bearing state that we would measure it. So for now it's not the best way to actually make clinical predictions or anything like that, but for our research for Mark, they have a Biodex machine at the AMC, so for him it's accessible, and the threshold for detection of passive motion is a very common and reliable way to measure proprioception. But clinically it's not the most useful tool. That's also why we suggested further on to use weight-bearing protocols.
Is there an alternative clinic?
Yeah, you have the ramp test and the...
No, that's for the fatigue protocol, but it doesn't assess.
There have been protocols that use like a functional squat mechanism, but we haven't really looked into that for now because we didn't have access to those ways of measuring proprioception for now. No.
Just 4 questions at least. First of all, I really want to give you a big compliment because I think it looks like a really well done study, and I really like the fact that it ends with a very concrete research protocol that your clients can start using.
Yeah.
Follow-up is really clear. So I just wanted to ask you, since he's not here, maybe you can share what was his response when he saw the protocol. How does he feel about it?
He was really happy with the protocol that we made. He had just positive comments about it. And
yeah, I mean, it's not complete. Like there's still some things that power analysis, for example, we don't have the knowledge to do that at the moment. But for him, doing that as his PhD candidate, for him that would be already a big step towards creating a research for him. And he said that he really wants to execute this, and that if we want to be part of it later on, then we can. And so hopefully he will conduct this research himself.
He will like also to do after a research study with pathological people. So with hypermobility syndrome, and so this will give it a basic to that support
to go further on.
To go further.
Yeah.
Yes. He will have.
Yeah.
That's seen as an idea.
There's no timeline or specific agreements for now, but he really likes the protocol as it is, and he says that he would like to execute it in the future.
Okay. Cool. Thanks.
All right.
You need some money, probably.
Yeah.
You've shown that there is research that shows the relationship between physical activity and muscle fatigue on proprioception. Is there any research that shows that there is any connection already between hypermobility and proprioception in any other form of, in any other way?
Between hypermobility and proprioception? Well, the thing was that there's already a study saying that the hypermobile symptomatic population has a decrease in proprioception. So that's why we also looked at this, and also one of our clients' researchers, he did a meta-analysis, and 2 of the intervention articles that he found showed that proprioception exercises actually had a beneficial effect on their patients. So that's why we chose proprioception as an interesting factor to look at for these patients. But because we don't know the cause of the decrease in proprioception, we wanted to go for the basics first and then go towards more the hypermobile, the symptomatic hypermobile population. I don't know if that answered your question, but.
Then in other words, yes.
Okay. Yeah. There is links, but it's not very structured or clinically relevant for now. Like, so we wanted to go further into that topic.
Okay.
Thank you.
You need a third. Whoa. Good luck, guys.
I should, yes. I don't know how this works though. I did nothing. We shouldn't mess with this. Hello. I am for sure it works. You can also just talk about it if not.
It's protected view. And then your content.
Did you not just want to connect your laptop? I thought that was the plan.
No, it should be alright. Because I don't download it already.
Yeah.
No.
Perfect. Okay, how do I find this?
It is on.
Can we use the one with the time, you think?
Yeah. I don't know how that one works. Yeah. So you have to give yours mine.
Yeah, that's fine. Or should I just put a timer? Do you have your phone? No.
Ja.
You can do it on this coming up.
Helemaal nog.
Do you want me to do your slides? Yeah, you do my slides. When do we start? Whenever they're ready, I guess. Was that me? No, it's me. Don't open it. Yeah, we have three whole teachers.
You can just tell them to sit down.
Can we start?
Andreas, are you good?
I'm not sure.
No, we have our client watching as well in Trinidad and Tobago, so...
She's used to the relaxed tempo, it's okay.
Carla, yeah.
Hi, Carla. What about time difference?
Yeah, it's 6 hours, so...
Good morning.
Sort of.
9 in the morning.
Sorry.
Are we okay? No? Oh.
It's all fine, Andrea? Nope.
We have time. Just nobody.
Yeah?
All right. Well, first of all, welcome everybody and thanks for staying as long as you have. My name is Anna, this is Claire and Rick, and we're going to talk about chronic low back pain in Trinidad and Tobago. For those who have not heard of it, it's a small island in the Caribbean next to Venezuela. We created an evidence-based intervention protocol and a internet prevention program for a clinic in Trinidad and Tobago. And you might say, okay, chronic low back pain, here we go again. We've heard all about it. Yes, it's true. All the evidence that's currently there, we've probably done 1,000 times already. However, low back pain is still a leading cause of disability in Trinidad and Tobago. And all the guidelines that are being used here, but also there, are Western guidelines. They're based on Western evidence on Western populations. We've all done internships in the Caribbean. Rick and I went to Trinidad and Claire went to Barbados. And in Trinidad we met our client, Carla. You can see her in the picture. During our internship we experienced a lot of things under which a lot of new patients that came in with low back pain, and we've seen a lot of chronic low back pain patients in the clinic. Within those patients, the lack of knowledge that they had about their body, about moving, about techniques, and just low back pain in general was very big. And also they presented with different illness beliefs than we are used to from more Western cultures, leading them to have a more passive coping style, an external locus of control, and there was a big lack of adherence to actual treatments. So with our client we decided to address the situation and make two products. One website for patient education for the entire of Trinidad and Tobago, and a treatment protocol for in the clinic to address the patients we just described. We did some preliminary research just to find out which other strategies we could use to reach those patients better than the current research, which led us to graded activity and motivational interviewing. Just by a show of hands, who has not heard of graded activity and or motivational interviewing or not used it? Who has used it in practice? Okay, not many people. We did a literature study with leading 2 research questions. We wanted to find out the efficacy of motivational interviewing to elicit illness belief and behavioral changes, and the effect of graded activity compared to other interventions in low back pain, chronic low back pain patients. Well, graded activity, first of all. Usually we use exercise in guidelines. Graded activity also uses exercise, but it uses a time contingent plan, a scheme, to really just step by step turn up the volume of a functional activity or exercise. And it doesn't focus on pain. Pain is kind of moved at the table, and you follow the time to build up. This makes your patient more active and less focused on pain. We found some research, however, not really connected to Trinidad and Tobago. There's no research done on low back pain in the Caribbean whatsoever. So the research we had to go off to is again yet more Western. All research, as you can see from RCTs we found, graded activity did show had great effects on both function, disability, and also pain that they did control for. But none was really statistically significantly better than other treatments. We also have 4 systematic reviews which also have positive effects, and one that really stood out is in Van der Giese. The short-term effect on return to work for graded activity intervention was really great, which eventually also can save economic costs.
Okay, so why motivational interviewing? It's more than just the physical aspects that are involved with the condition. There's also a lot of psychosocial aspects involved, especially in the rehabilitation process. And that's where the motivational interviewing comes in. So basically, motivational interviewing is kind of conversational style, which uses different strategies such as active listening, empathetic responding, to encourage a patient to take more of an active control in their own rehabilitation process. So as Anna mentioned, what we found with the population of Trinidad and Tobago is that they're really passive, so this is how we wanted to get them more involved in their own recovery. With the evidence we found, motivation interviewing is actually quite a new topic to be applied to chronic conditions. It's been used, it was devised to actually treat conditions like alcohol abuse, drug addiction, those kind of things. So there's actually limited evidence out there for chronic conditions such as low back pain. But we found 3 articles that measured adherence to exercise programs and physical functioning, which were the main things that we wanted to tackle with our protocols. So as you can see, they all show a positive trend and a positive trend towards effect. With only one showing specific. So in order to apply these findings to our protocol to make an effective protocol, we had to combine the results from both of the systematic review. And what we found was that motivation interviewing and graded activity are both beneficial, and they actually complement each other quite a lot. You have a large good effect on retaining patients, so getting patients to come back to treatment, and also improves treatment adherence. Whereas on the other hand, graded activity depends a lot on patient retention, so the two combined together just enhance the effects that they have on recovery. And throughout research, we found that MI is always referred to as not a standalone therapy. So the effects of motivation interviewing are enhancing with another form of therapy.
Yes, so now our products. First we start with the protocol. As not every chronic low back pain patient has negative illness beliefs or is benefited by a graded activity program, we made this flowchart. This flowchart is so to determine if our protocol is suitable for the patient, yes or no. If yes, of course we advise to use our protocol. Our protocol targets 3 different risk factors, which is illness belief, poor adherence self-management, and pain behavior. It incorporates the main principles of motivational interviewing and graded activity and is set up for use in the clinical setting. It is an 8-week program split into 3 different phases and approximately 11 treatments of 30 minutes in total. In order to achieve the goals in the 3 different phases, we provided 8 different tools as well, which will really help in the achievement of the goals. We have to say that an understanding of the principles of motivational interviewing and graded activity must be understood before the implementation of it. Within the protocol, we think it is very important to have patient education as well. So we refer to our website. This is an overview of how our website looks like. We were asked by our clients to come up with a website to aid in patients' education. This in order that patients have more understanding of their body, also of their spine, and they know exactly what to do in self-managing their back pain. We made 20 videos in total, focused on ADL activities. And for instance, this video of getting down to the floor safely. We first always show how not to perform it. Then we say exactly the steps you need to take while you do it great. And then at the last thing we show how to perform it correctly. Also, the descriptive information is adjusted to the target group and is next to it, so everyone can read it. So, conclusions for physical therapy. We can say that motivational interviewing and graded activity are both effective in the treatment of chronic low back pain. And they are even more effective when applied simultaneously. We made an easy-to-use protocol and website to adopt more healthy illness beliefs, enhance adherence to self-management, and this overall benefits in cutting physical therapeutic treatments, reducing number of patients, and more importantly, healthcare costs. We would like to thank our coach, Simone Andriessen, and our clients, Carla and Nicole, for their support as well. Thank you. Are there any questions?
Bram?
Is there a way you can study?
Yeah, there's a lot of courses which we didn't mention in the presentation, but in our thesis we refer the science to specific courses across the world. There's none in Trinidad and Tobago, which is unfortunate. There are some online learning courses that you can follow, and there's workshops that are held all over the world. So apparently some of the staff are going to go to one in America, like a conference where they explain all the principles, because it is, although it sounds pretty easy, it's actually really difficult when you actually get into all the steps that are involved, and it requires a lot of training and practice to understand the concept. So that's why, like, when we first got into this, we can just add it to the protocol, but actually looking into it, it does require quite significant training before applying it.
Yeah, it's not just a regular conversation you have with the patient, but it's really, you have to adapt the techniques for it as well, yeah, definitely.
Okay. I thought I knew all about the motivation.
Your inspiration, you say.
Yes. And I also doubt then if you can call motivational interviewing by itself as therapy. The way we dealt with it was more as a prerequisite to make people open for the graded activity. In the beginning you said that you wanted to adjust the treatments that we have for the different people from the different cultures. Yes, can you tell me something how you would adjust graded activity or motivational interviewing to people from another culture?
Well, the first thing we wanted to do is not necessarily adjust the treatments of graded activity and motivational interviewing, but we did see that the treatments that were used there now are more exercise-based. It's very hands-off, patient just exercising, but there's a big part of the population there that just does not understand the use of the exercises, does not do them at home, and is or not even able to really do the exercise because the educational level is so low. So we think using this intervention is already a step towards a way you can already just modify graded activity. You can choose whatever activity there is to your patient. It doesn't necessarily need to be one activity. It can be an exercise. It can be all kinds of stuff. So you can modify it to a level or an importance to the patients. We've seen a lot of patients that are very low level education, basically just sit at home and clean, but still have a lot of problems and they just don't understand what's happening. So you can even have as sweeping the floor as an exercise for them and modify it in a way that it's for them understandable what they're doing instead of having it as a complicated exercise of core training.
I I told you that you needed to do the exercises in the practice. Really.
They come into a PT practice and they come and we practice sweeping with people, we practice cleaning the floor, we practice gardening, we do all those things in a therapy session, but we see that for the patients that are not as educated, they do not relate to exercises such as cat and cow exercises, lumbar dissociation exercises. They just don't understand, so they don't do them. So if we stick to the more functional exercises for them, and we sweep the clinic with them in the clinic, and then they can sweep at home, and they can then increase that activity at home, it'll be more applicable to them.
Yeah, and the good thing also, because we have the website explaining everything, that people at home can watch it themselves again. And not only, how often do you go to a doctor and you forget half the time what he or she said?
Mel? Yes. There's one part of the presentation that you went through, I think it was you, Rick, that was a bit quickly, that was about the screening.
Yeah.
So part of it said we do screening, and if the screening is not, the screening is no, we refer to doctor, and if it's yes, we continue. So what do you screen on? And how does that process work?
It's just a general physio screening. So obviously when you have an intake, we do a physical therapy screening on red flags. It's just the first thing we wanted in our protocol, that a basic screening of a therapy session still should be applicable. And if they are then applicable, if physiotherapy is implied, then we screen them for actual use of our protocol in specific.
Yeah, this is really after the point you were having, like the patient history and the regular screening.
Yeah, okay, so it's the general screening for red flags, like if you do any diagnosis.
The first one, yeah.
Yeah.
Okay, and I have one more question, if I'm allowed. How exactly is the website used? Because the website is not attached to the Total Rehab website.
Correct.
It's not a product that they're going to hang on their website.
They probably will.
They're in the middle of refurbishing the entire website when we were in the process of making. You can go.
Yeah.
Yeah, they asked us for the website because they do want to link it to their website, not use it as their website. And she actually is, Carla is actually on a mission to really, in Trinidad, in the entire country, spread the knowledge. So through their Facebook, through their Instagram, social media, and their website, they want to use the single videos and just post them, use a little bit of the information and post them, kind of spread it in pieces, and then you can always refer back to the entire website.
Okay, thanks. I have asked Carla if she want to comment, and but she is not.
Oh.
Is not able to.
Well, it is Trinidad and Tobago, so you never know.
I could pass on the questions over there, but.
Any other questions?
Yes, I have one more question. Because you started already that, of course, lower back pain is very known in the Western society with a lot of
Guidelines.
And you were looking quite good. What's going on in Trinidad? People don't have a lot of experience and have another culture. Did they already do a pilot with some people there now, or do you know that?
Not that we're aware of, no.
But the protocol was used in your internship site?
They requested it, yeah.
Okay.
It hasn't been implemented yet.
They had another internship, where they?
Yeah, it was a completely different clientele, the people that approached the clinic, because I was in a really active location in the mountains in Canada. So, I mean, the concept is what they wanted, but it didn't really apply to their population because they were already so active. They didn't require the motivation to do things on their own. So it wasn't as applicable as we would have hoped. It should have been nice, but.
Anyone else?
All right, you make that.
Ja, also wirklich, guck mal, ob das sich bewegt.
Perfect. Yeah, good to go. Okay, so hi and welcome to our thesis presentation. My name is Jacqueline and this is Sophie, and we would like to present our thesis on physiotherapy interventions for children with asthma to improve their quality of life. So before we get going, we're just going to quickly test your asthma knowledge. So we're going to have a few questions up, and I want you guys to be interactive, raise up your hands, and we'll see where it all goes. So first things first, what is asthma? Is asthma an acute disease that results in the narrowing of the airway? So who says true? Okay, who says false? Awesome. So false is the right answer. So false is asthma is a chronic respiratory disease with acute exacerbations. So if an individual with asthma, for example, inhales an irritant, such as pollen, the sensitive airway then reacts. And this results in the contraction of the smooth muscle around the airway. This narrowing and overproduction of mucus often results in limited air being able to enter the lungs.
So second question, what percentage of the children in the world suffer from asthma? 0 to 5, 5 to 10, or 10 to 15? So who says is answer A, 0 to 5? Nobody? One person? B, 5 to 10? Yes, and C, 10 to 15. Yeah, the right answer is C. 14% of the children in the world suffer from asthma. And from the Global Asthma Network Report 2014, to give you an idea, in the United States, only 7 million children have asthma.
So how can you see that a child has asthma? Is it their frequent intermittent cough? Is it their wheezing? Is it their tightness in their chest and breathlessness during exercise? Is it their sedentary lifestyle and participation in sport? Is it their increase in social isolation, school absenteeism, and child and caregiver anxiety, or all the above? So who says A? I gave it away. B, C, or D? Awesome, okay. You guys are great. So D, all the above. So without the proper management of signs and symptoms and decrease in participation in activity, all these aspects play a role. So anxiety, sedentary lifestyle, and reduction in participation all come down into the spiraling mechanism that can result in a decrease in the child's quality of life.
And that's right. What about the asthmatic child's quality of life? According to Flapper et al., and despite the high quality care the asthmatic children receive in Europe, there is about 50% of children in Europe who suffer from persistent asthma and symptoms, which leads to a lower quality of life compared to their healthy peers. And however, there is only a very few studies who investigate the non-pharmaceutical intervention who have an impact on quality of life of this type of children. So, quality of life is an important indicator to measure the well-being of a child. So how to evaluate the quality of life? How to evaluate it in the most holistic way? So most studies are using some most of the literature has evaluated the asthmatic child quality of life through disease-specific questionnaire. And the most relevant for us is a Pediatric Asthma Quality of Life Questionnaire, which is called PAQLQ from Juniper et al. 1996. And in this questionnaire, all these aspects defining the quality of life are evaluated, meaning physical condition of the child, psychological condition, psychosocial, and also emotional and the close environment of the child.
So as physiotherapists, we want to provide our patients with evidence-based practice. So our research question that we're presenting you today is which evidence-based non-pharmaceutical interventions can we provide to improve an asthmatic child's quality of life? So to do this, we conducted a systematic review to gain more information on available interventions. And then we wanted to make this information accessible to caregivers of asthmatic children. And to us, caregivers include parents, teachers, and coaches that surround the child. And to do this, we wanted to use an online medium, so we created a website. So today we're just going to present both of our products, our systematic review, and our website, and then go through the general conclusions of our thesis.
So after completing our literature search, our systematic review investigated 16 RCTs, including participants with a wide range of severity of asthma from 6 years old to 18 years old. The primary outcome was quality of life, evaluated through disease-specific questionnaire, and secondary outcome were exercise capacity, respiratory function, morbidity, and caregiver quality of life. So the results of our study categorized 3 types of intervention. The first type is pure exercise physical intervention in the blue box. And the results show that aerobic exercise has a significant impact on quality of life, despite endurance exercise and respiratory exercise did not. The second type of intervention was pure education intervention, meaning very structured, specialized asthma education program, and also general asthma knowledge education, classical. And it was shown in our study that highly specialized educational programs have a greater impact on the quality of life. We mean structured educational programs. To give you an example, we had an article on the Roaring Adventure Puff, which is a specific program built up in Canada who helped the children to gain knowledge on asthma. The third block of intervention in red, which is mixed design intervention, combining aerobic intervention for the physical part and structured educational specific program for the educational part. And this mixed design intervention gather all the positive aspects of both aerobic and specific educational program and had a significant impact on the quality of life of the children, but also on the morbidity. So what increased in the asthmatic child's quality of life? The aerobic exercise increased their exercise capacity and respiratory capacity. The specific educational program have a positive impact on the disease management, and a positive impact of the morbidity, meaning decrease the number of acute attacks, hospital admissions, emergency hospital cares, school absenteeism. In a long-term perspective, it also decreased the long-term burden. And by this educational specific program, they also increase the caregiver education. With mixed intervention with aerobic exercise and specific educational program, we have also a decrease in morbidity with a decrease of school absenteeism and emergency hospital care, an increase in caregiver education leading to a better caregiver quality of life.
So from these results, we saw that there was a link between caregiver education and child quality of life through better management of disease and better knowledge as well. So we used Wix to design a simple website to provide some resources to caregivers. So the goals of our website included presenting information to caregivers. So we had our first section on general asthma knowledge. which covered what is exactly asthma and what are the signs and symptoms that these children may experience. The second part was all about quality of life. So what is pediatric quality of life? And how can an asthmatic child's quality of life be decreased compared to their healthy peers? And the third part was presenting our results on what non-pharmaceutical interventions are possible to increase an asthmatic child's quality of life. So, on March 27th, we launched our website, Improve Your Asthmatic Child's Quality of Life. From our pilot period, from March 27th to April 18th, we saw that there was 32 views on our website in many different countries, such as the Netherlands, Switzerland, Australia, Canada, and the United States.
So to conclude our PAP presentation, the key message is that our research suggests that a pediatric asthma physiotherapy rehabilitation program with a mixed intervention consisting of asthma-specific education and aerobic exercise improves the quality of life and some aspects of morbidity in asthmatic children. Further research would be necessary to determine which intensity and frequency of the interventions has the most optimal impact on the child's quality of life.
And we would like to thank our coach Jesse Alden and our client Camille Netter for their constant support throughout our thesis. And a really special thank you to Dr. Peter Klein and Sarah Van Dyne for their support in the practical application of our thesis in pediatric respirology. So thank you very much, and if you have any questions, you'd be more than welcome to answer them. Yes?
Asthma is very often treated multidisciplinary.
Yeah.
I didn't see it back in the presentation, but maybe in your educational part there is something. Can you explain something about that?
Yeah, definitely. There's a huge, and her question was about the multidisciplinary sort of aspect of treating a child with asthma. And definitely there is. In our website we really say that, okay, as a physiotherapist, the biggest thing is that we cannot administer the tests to test quality of life. It's really the general practitioner that has to do that. So already you're bringing in all those aspects of the multidisciplinary team, and also the nurses that sort of care, and the respirologists as well. Our thesis was mostly non-pharmaceutical aspects or interventions. So I think most of what our research was focusing on is what the physiotherapist can bring to the table. So.
Physiotherapist is doing a lot of education as well.
Yes.
And you said something about the teachers at school as well. What do you tell the teachers, and what do you educate families?
In the specific educational program, and for example, there is a lot in Canada where we find the literature. There is the educational program could be done at school, it could be done in rehabilitation center, and it could be done in sports with caregivers and everything. So the teacher, they are just part of one of the process. They get the knowledge from the healthcare professional, and they just rely the knowledge in the programs. It's not only could be done by teacher. There was a very interesting program that was the older children who were teaching to the younger children how to manage their asthma. So it was a peer knowledge that was very interesting, and it gave a very good results. Yeah.
Yeah.
To what age do you refer children to? Like up until what age?
Yeah, in our studies between 6 and 18 years old. So, yeah. Good question. Yeah.
Yeah, first, thanks for your presentation.
No problem.
Interesting project.
Yeah.
I've got a question for, it's related to the previous question, is what do you advise now for children? Do they have to go to the rehab center, or can they do it in private practice, especially when you want to do it multidisciplinary?
Yeah.
Can you say something about that?
I think,
criteria?
yeah, and I think from our research, we couldn't sort of derive that, but from our contacts with Peter and Sandra, they're basically saying that most of this can be done in a private practice, and only when the physiotherapist at the private practice sort of sees some red flags that they cannot address, will they then go to a more specific rehab center. It's mostly for care during the day. It won't be inpatient care. So I don't know if that...
Yeah, so the majority can be treated in a private practice.
Yeah,
Is that
yeah,
the conclusion?
yeah.
Okay, and can you say something about, because that is always a problem in literature, about the intensity and frequency, and do you have a sort of setup of the program? Or a range?
So unfortunately, all our studies evaluated different intensity, frequency, and modality of, especially in the exercise component. Definitely with the aerobic exercise, we saw that moderate to high intensity is more beneficial, but definitely future studies will have to investigate that, because that's still an aspect that unfortunately needs to be developed.
At this moment, can you give some guide?
From what we saw, basically for the exercise part of the mixed design intervention, it'd be sort of between 3 to 5 sessions a week.
Yeah.
And the education would be sort of ideally daily, but that's not realistic. So let's say at school, if there's many asthmatics in the class, if we use the example of the Roaring Adventures of Puff, that's actually a book. And it tells a story about a dragon. So it teaches all about, blowing and sort of using all those mechanisms in your daily life. So is that something that the education piece can be sort of addressed at school, at home, and in any sporting or activity fields.
How do you make them, how would you make the children more, because you were talking about like 3 to 5 times physiotherapy, which is of course, it's not possible.
Yeah.
And I think I have an asthmatic daughter.
Yeah.
I do recognize a lot of her problems.
Yeah.
But the main thing there was that she got independent of a physiotherapist.
Mm-hmm.
And that's why I'm asking, what is the education? Because I think people should be getting really independent, not going there like 3 to 5 times a week.
Yeah.
She's not going any times a week anymore.
Yeah.
But sometimes when she goes back, she needs something.
Yeah, for sure.
They taught me, for example, that she had to play trumpet, that we had to change our house, dust, because asthma is a reaction.
Yeah,
it's
for
an allergic reaction actually.
For sure.
And I kind of don't see it back in your...
And maybe the intervention, like the exercise 3 times a week, is something that the parents do, right? All of our thesis was around caregivers. So you, as the parent, you're saying, okay, we're not going to the physiotherapist for exercise 3 times a week, but she's playing soccer, she's playing volleyball, she's going in and she's swimming with her friends. She's actually at recess time going and playing with her friends instead of just sitting in the corner on her own. So maybe that's sort of where that would come to, if that makes some sense. Yeah. If you want to add anything. Yeah. Perfect. Okay. Well, thank you very much.
Thank you.
Do you know how to set it up with the USB?
Did you send it to
No, I said we could have the USB. Yeah, but we can also go to our email.
I guess it's over here.
Oh, it should be one of those then.
No, but you're not able to log out.
Did you send it via email?
No, it's on USB. Could it be on this computer then, on the USB?
Fuck you, man.
I think if we just go to the
Just
Is this good enough?
Hello.
Hello. Is that good enough?
Yeah, that's good enough. Just make sure that if you're both wide.
Okay. Yeah?
Just import it in school.
Yeah, I mean, we can, should actually prevent
Send it to you? Yeah, we can also send it by email.
Heb je jetzt die PowerPoint drauf? Yeah, if it's on here, it doesn't. Yeah, it's not on. It's not in here.
So get it in there.
Hmm?
Get it in there. Just track it in there.
Ja, dat is het paswoord al. Yeah,
will it be easier?
You can film that.
Okay, ready?
Yeah.
Good afternoon, ladies and gentlemen. I would like to thank everybody that is here watching us and everybody in home, our families and friends in Portugal and South Africa. Today, Marijke and I are going to be presenting our thesis. Our coach is Jan Voigt and client Anthony Rombach, who is representing the COP, which stands for Community of Prosthetic Practice. Our table of contents just shows what we're going to be discussing today and the aim of the study. So before anything, we'd like you to listen to a very short recording of one of our interviews.
Yeah. Yes. Very good. Okay. So you would just like it that the patients can be more aware of that there's nothing wrong with being disabled.
So this gentleman is one of the people that we had to interview, one of the healthcare workers interviewed from Mpumalanga province in South Africa. I believe that most of you could not really understand what he was saying. Is that true? Yeah, okay. Although there is a really big communication barrier, we need to remember that these people want the best for their patients, just like we do. So their needs need to be heard. This is why we decided to create this manual. Our introduction, why and how we did this. The purpose of this study is to create a pre-rehabilitation manual, on amputee. Mostly for transtibial and transfemoral amputation. We want these individuals to develop a better understanding on the whole rehabilitation process. We want them to understand the surgical procedure, the acute and subacute rehabilitation process. We want them to know how to prepare the stump for the fitting, amongst others. Unfortunately, there are great differences between developing countries and developed countries. Evidence-based guidelines and manuals are widely used in developed countries. The reality is very different in developing countries. Clinical guidelines should be adjusted so that healthcare workers, like the ones in Mpumalanga province, could use the same information as we can in a simplified way. While researching, we realized that the lack of literature is very, very real. Because of this, we decided to have very strict quality control and inclusion criteria. Besides this, we included our own qualitative study. With the help of our coach, our client, and Dr. Liesel, who is a South African researcher, we created a pre-pilot study based on the interviews that we made on the Mpumalanga healthcare workers who decided to share their experiences with us. Combination of quantitative and qualitative studies is very important for topics like this. And this is how we got to our end product, which is basically a framework. On the methods, on the qualitative study, we first started by making hypotheses on what we thought these healthcare workers in the Mpumalanga province would need or want. From this, we created a questionnaire. The interviews were done via Skype, and although we started with a list of 317 people, like you can see on the flowchart, that were given by Dr. Liesel, we ended up only with 25 transcribed interviews. This is because a lot of the individuals that could have been participants maybe didn't pick up their phones, the connection was too poor, their English was too poor, amongst other reasons. The data was analyzed through SPSS by creating themes and categories. These categories, through the categories, we were able to calculate frequencies, percentages, as well as p-values and correlations between them. Our methods on the quantitative portion. This is our research question, which is also in the title. And with this part, we aim to find literature on educational interventions and guidelines that could be used or that are used in developed countries and in developing countries. You can see in our PowerPoint the online database is used and how the narrowing process happened. We used for our grading tools the CASP tool and checklist and the AGREE. The CASP tool was used for the articles and the AGREE was used for the guidelines. In the end, we ended up with 2 qualitative studies, 2 quantitative studies, and 2 guidelines.
Okay guys, hello, I'm just going to talk about our results. So although SPSS was quite helpful for us to get frequency and percentages, unfortunately the correlations that we were looking for between our categories was of little significance or not significant at all. This could be due to our sample size, which was quite small, or also that SPSS was just not the right database for us to use with this study. So looking at our results from our interviews, we were shocked at how undeveloped the healthcare actually is in these communities. So 60% of the healthcare workers did not finish their high school or had any further trainings, and as we heard, their English was not on a very high level. Interestingly, only 48% of these participants were treating amputee patients, which shows that if we're sending them a bunch of complex guidelines, they won't really know how to interpret this. 60% stated that they don't use any equipment or have any equipment in the clinics that they are working. And 32% said that they had difficulty getting their patients to come to treatments as these patients felt ashamed of their own condition. Lastly, 84% said that they were treating patients with type 2 diabetes. And according to Litzelman et al. From 2006, this is one of the main causes of lower limb amputation in developing countries. So that's something we really wanted to focus on as well. Okay, Looking at our quantitative study, we ended up with 4 articles and 2 guidelines. The articles really created a framework for us for what we could include and exclude in our manual. And the guideline, especially van der Linde et al.'s clinical Dutch guideline for lower limb amputation, helped us to set up our framework for what we wanted to use in our manual. Okay. Some strengths and weaknesses. One of the weaknesses was the quality of literature on our topic was quite poor, and the interviews could have been of better quality. We had to call them via Skype, and it was across the world, so we didn't really have the best quality. Although 24 out of the 25 participants said that they receive informative pamphlets and manuals, none of them mentioned them receiving any manuals on or guidelines for amputee rehabilitation. The previous guidelines sent are probably too complex for these participants to understand, or they just simply don't reach their destination. The postal service in South Africa is not too great, I would know. They don't have any internet access, and they don't have their own Gmail accounts, so how are we going to get it to them? Okay. Participants mentioned that there is also no equipment available for them to use, and that there's a lack of general hygienic materials as gloves, gowns, and the rest. Healthcare workers share a common concern how the amputees feel about their own condition and how their communities and families react to this. That's why it's so important for us to bring more awareness to these communities that amputation, as the gentleman said before, is not the end of the world, and to be able to improve these quality of life of these patients.
As our conclusion, we reinforce the idea of using mixed research because it is necessary, this type of research, to meet the needs and really understand what is happening, what the reality is in rural areas of developing countries. The scientific world must take the time and effort to share the knowledge that has and is improving daily in the developed nations. We shouldn't make any more assumptions, which I feel like they have been happening for a while now. Time must put into interviewing healthcare workers and visiting these areas, having people on the field. Finally, we get to our final product. First is our manual, as you can see, the biggest portion of the PowerPoint. And then we have a pamphlet. We actually have it with us, so if you guys want to have a look, you can. The biggest idea, the first idea that we had was actually to turn this manual into an application. This might sound extremely crazy because we just said they don't have internet or computers. But the truth is that by 2019, at least more than 50% of the rural population will have access to a smartphone. This was said by Goldstuck 2014. Because of this, we believe that we could give them access to the information that is in our manual and more, if necessary. And this way they could have all the necessary knowledge to treat these patients on them at all times. Hopefully, in the future, this could be done, and we could make it a worldwide idea.
Just also to add that this is also a part of our entrepreneurship course, so we're actually busy trying to implement the app as soon as possible. Special thanks to our client, Anthony Rambach, and the rest of the coppers for allowing us to be part of this amazing project. Thank you to Jan Jaap, our coach, and our second reviewer, Marlene. And a special thank you also to Dr. Liesel and Jon for giving us all the information all the way from South Africa. And last but not least, thanks to all the healthcare workers in the Mpumalanga province for sharing their personal stories with us. Okay. Any questions?
Yeah. Yeah?
I'm assuming this is all public sector, hospitals and rehab centers.
This is basically like...
Healthcare workers are from the public sector?
Yes.
Yeah.
Yeah.
Are you thinking of implementing this in the private sector? Would this be beneficial there?
Well, we're more focusing on rural areas at the moment. That is the biggest problem, is the rural areas that don't really have access to any knowledge or any training. So that is the focal point at the moment.
We did also find out that a lot of them get trainings, but it's more for TB, for AIDS, you know, those type of trainings. But none of them actually receive any trainings for amputee patients. And it's not even public sectors, it's really like local clinics in those communities where there are no physiotherapists, or physio might come once a month to the place. And these community healthcare workers need to help these patients, but they just don't have the knowledge to do so. So we really want to focus on them, but the more the merrier. If the private want to take it over as well, like, why not? Yeah. Yeah.
Thank you very much for an interesting presentation. Also personally, there's lots of interest in this topic, but I have a question, and that is related to your methods. It might be the question that you've been dreading, but I'm going to ask it anyway.
Yeah.
Because you decided to do a qualitative study, or partially qualitative, and you transcribed your interviews, and then I would assume you coded the data,
Yes.
and you decided on categories, and then you threw everything in SPSS.
Yeah.
Mm-hmm.
That is a bit of a strange choice.
Yeah.
To do with qualitative data.
Yeah.
So could you explain a bit why you chose that, and
Yeah.
how did you then come to your themes?
Yeah, so, well, we actually wanted to use other type of analyzing, but we didn't have the knowledge or the resources at the moment, because we were going to have some support from some of the researchers, but we ended up not having the time or being able to have those resources. So then once we discussed between each other, with the coach and with the client, we decided that we'd use SPSS. But indeed, the problem was our sample was first way too little, and this is not the right type of data analyzing software even that we should be using for this type of data. Yeah.
Perfect, actually. That can give you a nice scientific publication.
Yeah.
Yeah, but not in.
But not in this. Yeah.
So, but it depends on how you deal with the data.
Yeah.
Yeah, we were like, that's just the thing. We were actually going to get more support from Liesl in South Africa on how we could, because it's part of her project as well in a way. She's also busy with this, so we would do the interviews and she would use this. But unfortunately at the end some things came up and she wasn't able to help us as much. So since we didn't really do any qualitative studies or in ESP, we were a bit stuck of what to use. So SPSS actually turned out to be a lot of work, because I had to go through all of because it was more open questions that the participants were giving. So I really had to go and make valid categories like a yes or no or a maybe for each of the questions, and try and put it in like that so we could get some statistics out of it. And that's why we also think our correlations were not significant at all, because we wanted to see if, for example, not finishing their education led to, not being able to treat their patients as well. But we just didn't get any significant results, because at the end we just didn't have enough knowledge to be able to do that. So that's definitely a point that needs to be improved, and we also said that in our discussion, if this would be analyzed better, I think a lot more could have come out of the articles, even more if someone who is doing this is actually a qualitative researcher. So all of it is also with Liesl as well, so she can dig in there even more and try to get more things out. But for us it was also just really important to just open the door, make that pilot study, let those people be heard, and from there, it's being taken further already by Liesl, also by Anthony. They've been there to give them trainings already, so it has been carrying on. But we just didn't have enough knowledge,
unfortunately,
to take that further. Yeah.
Any other questions?
Yeah.
For the presentation of a very interesting and needed topic.
I've maybe two questions. You did a lot of interviews with the healthcare providers at site. What was their biggest need to improve their quality of healthcare? And the other thing is, you also showed a little bit about the two products that you've made. Can you elaborate a little bit more on the prevention part of that topic?
Yeah.
Shall I start? Sure.
So, well, one of the main things that they actually were all talking about at the end was they wanted more trainings, they needed more equipment because they kept on saying they didn't have any equipment. There were no crutches, there were no wheelchairs, or patients had to share them with each other. So it was a lot of those basic things that we take for granted that they did not have there.
And I think I should add that the cultural factor is very important, because a lot of patients don't even go to the clinics because their families shame them and they're ashamed themselves of what has happened to them. And there's no transport either. There's no transport for a medication. It's even more basic than having crutches, you know, just getting them to go to the rehabilitation. Our main thing for the prevention was also focusing on the diabetes, because we were both actually quite shocked that 84% of them said yes to treating diabetes patients, but we don't even think those healthcare workers know that this can lead to an amputation, which is one of the leading causes. So that's why we actually decided later on, like, we're going to add a pamphlet. We would want to print them out a lot of times, put them everywhere in the clinics, so also they can show this to their patients when you're at home. Check your feet, check your wound, how is it looking, so it actually prevents the amputation from happening. Also, because with the culturalism, we were like, if this might take years before people see this as, as just something as part of life and not as a sin or as the devil, made you have this. So we just thought if we can prevent the amputation from actually happening, then at least we would have less amputee patients walking around. Yeah.
Thank you.
Okay. Anything else?
We need to change.
Okay. Thank you very much.
Thanks, Helen.
Thank you, Mom.
Ze mogen niet uitlopen. Dan gaat het helemaal mis.
Google Slides.
Oké. Zijn we nog op schema? Ja, ga ik boven de technische limieten.
Niet heel erg hoor. Moest je goed er een paar keer bij halen.
Maybe then it's better. It should be here in the spreadsheet.
Depends on who is, we can do this easier by.
So, the Italians, did you send it to me?
We sent it to Buzz, but it's already, I think, in the spreadsheet over there.
Yeah, but that's...
Wonders of nature. Is that on? Took a while. Upstairs we had some technical problems.
Thank you.
Okay, good luck.
Be holding. Yeah. 5 minutes. Sorry. Oh, just a minute. So, ready? Not ready. Yeah. Okay. All right. Okay. So, hello everyone from us now. I'm Alexandra and this is Sylvia. Welcome to our presentation called Physiotherapy in the ICU e-learning module, evaluation and ESP students experience. Our client was Mel Major over here from ASP and our coach Jesse Arden. Before we continue, I want to ask the few of you who are here if you have an experience in an ICU unit. Intense. Yeah, you had? 1, 2, 3, 4, 5, 6. All right. Okay, may I ask if you had any, were you prepared before going? No, really? Okay. That's good. I hope that highlights the importance of our presentation in the e-learning module. Yeah. Okay. Yeah. So to start the presentation with a definition of e-learning defined by Reme et al. Is a way of education which delivers the course materials electronically and enables the students to reach the learning objectives at any time and any place. A common problem in healthcare courses such as ESP is that the course is full of traditional courses and there's not much time for special courses such as this one. So that's when Mel came in and created this module called Physiotherapy in the ICU, created by her and Dr. Marieke van der Schaaf, I hope I spelled it correctly, AMC. And so Mel recognized this gap in the ESP curriculum regarding the lack of information on physiotherapy in the ICU. So the model was created, was first taking place in the summer of 2016 and was completed by a group of ESP students that took part of this pilot study, and since then it forms part of the ESP curriculum. So you can see a screenshot of the 7 modules of the e-learning module, including general introduction, ICU assessment, interventions, and way more. And a small example of an exercise you could find in the module. Nice one. And so what we did and what was our task from our client, we did a narrative review on available evaluation tools for e-learning modules. We did a qualitative research with ESP students to investigate their experience in regards to the module physiotherapy in the ICU, and we concluded with SWOT analysis of the module based on the results we received from our studies, and we gave recommendations to our client for any possible further improvement. The purpose of this was this thesis was intended to help our client revise the module and make possible further improvements to it.
So about the clinical relevance, since intensive care unit is a part of the physiotherapy field, it should be included in all the bachelor's programs to prepare the students for their internships and also in their future career if they want to work in a hospital. Although it is an important topic, there was not much information about it at ESP, so we were very interested to participate in the research of our client and assist her in evaluation of the pilot study, and in order to help future students in their education. So with the use of the findings of our thesis, the client is able to revise the module, and it also adds a great value to the ESP curriculum, and offering additional knowledge and makes a wider perspective to the students. For the sake of timing, I'm going to continue now with the results, but in the questions we are more than happy to tell about our methods. So the results of the narrative review we gained from the literature search. These were from the databases which you can see on the slides. And as a first step, we did a title scan, and then we read the methods. And for the remaining articles, we read the full articles. And this is how we came up with the 19 articles. Out of the 19 articles, only 3 included already existing evaluation tools. First of all, I would like to mention the IMMS, which is from Connolly et al. And they investigated the motivation of the students, and it includes the following 4 principles, which are attention, relevance, confidence, and satisfaction. The tool consists of 36 statements, and with a 5-point Likert type scale, where is 1 is not true and 5 is very true. The second one from Moreira et al. Investigated the reliability of the ELS and concluded that it is a highly developed questionnaire with a reliability of 0.95. The ELS has 26 statements, and it can be completed on a 7-point Likert type scale, and ranging from strongly disagree to strongly agree. It includes items about the content of the e-learning module, user-friendliness, testing methods, and personal factors which can highly affect the learning process. The third one, the UAQ, has 26 adjectives with their antonyms. The tool describes 6 categories. There is also a 7-point Likert type scale between the 2 columns, and the individual grades them based on his or her opinion. The reliability is ranging from 0.58 to 0.81, depending on the categories. And so the rest of our studies constructed their own ways of measurement. They also used pre- and post-knowledge tests, and qualitative ways, or they just used their own constructed question list. And every study investigated the students' perception on certain aspects of the module, such as user-friendliness, interactivity, ease of use, learning satisfaction, and advantages and disadvantages of the module.
All right, now I'm going to continue with a qualitative study. Before jumping into the results, just quickly mention how it worked out. We conducted all the students that completed the e-learning module during the summer period, and we were able to set up 2 focus group meetings with 4 and 3 students respectively. And we received we had video recordings of the interviews transcribed, and that led to our results. From the transcription we came up, and the analysis we came up with 5 final themes. The first one being students' experience regarding the module, content, technical aspect, user-friendliness, and the Google Plus community that was set up. Some of the positive comments received includes the transcripts, written transcripts provided along the module, the combination of video, audio, and written text, the Google Plus community, and the weekly emails from Mel with reminders and additional relevant content. Some of the codes we received, you will find them throughout the slides. It will be interesting. Students mentioned that they found the content of the module that was really close to real life, and it was well done, explain information, and they liked the idea of they were experiencing the patient and the family as well. Some recommendations were regarding the big articles that were used with the module, and that they did not have enough time to go through them. They were doing their internships, writing reports and everything, and that the module sometimes is a bit too general and not specified to certain conditions. Second theme, it's confidence regarding working in the ICU now after the completion of the module. So here we have 2 codes. One student saying feels totally prepared to see an ICU patient, and the other one saying not really prepared at all. The difference between these 2, first one did an internship in ICU, second one have never been into an ICU, so that highlights the importance of having a practical experience together with the theoretical part of the module. And going to the third theme, it's the value of the e-learning module regarding a bachelor's degree and the ESP. Every single student mentioned that highlighted the importance of having this module in ESP, and yeah, they were really happy with the idea. So theme number 4 is the perception of ICU before and after the completion of the module. Every student mentioned that they really the idea of ICU before and after the module changed. If you could see the first quote, I really like it. Students said, for me, my perception was changed. Of course, I was like a baby in a new situation. I did not know anything, and this course helped me. Yeah, so it was a great tool to get them familiar with ICU. And theme number 5, that was important for our clients, as she wanted to know how, when, and where the module was completed by the students, because some students were doing their internships, writing their theses, they were traveling. Some mentioned that they were in airports without internet, in hotels, and yeah, writing reports and everything. Here you can see the SWOT analysis regarding the module that we concluded with. We used all the information from the interviews and from the interviews of the students to make this. You can find it in our poster and to see all the details, as well as the recommendations. Those are some recommendations along the list we sent to our client. One of them is to include more detail, content information on physiology, pharmacology, and the difference between the healthcare professionals, and more information on specialized ICU such as neonatal care. And one more point was to improve the articles, how to utilize the articles by making small points or summaries instead of having to read through all of them. And another point would be to replace either the Dutch language in the videos used in the module with English, or put English subtitles instead.
So just to summarize, we found 3 already existing evaluation tools, but there are several ways to evaluate an e-learning module, and combining these methods can help to gather the sufficient data and to improve the educational tool in all the aspects. Because it is online education is very complex, and it has to satisfy several conditions such as user-friendliness, the delivered knowledge, exercises that involve all the participants, and they also have to be easily accessible. Furthermore, medical e-learning should provide evidence-based knowledge and innovative techniques. And it is important to measure all these aspects with the use of qualitative and quantitative measurement techniques. Regarding the qualitative research, we can conclude that the experience was the ESP students was overall positive regarding the ICU module, and they highlighted the fact that it was a gap within the ESP curriculum, but it is solved with this module. And during the focus group meetings, we have received valuable feedback, and also suggestions for improvement, which we formulated as our recommendations.
So, we'd like to thank our coach, Yasser Aaron, for his guidance throughout the whole period, constructive feedback, and of course our client, Mel Major, for her guidance, and congratulate for the module and everything. And last but not least, all the students who participated and took the time in our interviews. Yes, thank you. And that's it. Preferring for requests. And we're here for your questions, if any. I don't know if that's a good sign.
We were clear.
Okay. Yeah, Celia?
Sorry, I have a question because during my second internship, I was in ICU, and yeah, do you think the model can actually be used for all students all over the world, probably? Because similar to ESP, the physiotherapy students in Nigeria, they don't also have like any knowledge of the ICU until the internship. Do you think that it could be used for them as well, or it's only for like?
Yeah, I don't see why it couldn't. If someone has the knowledge of the English language, and they have, if I understand the setting is the same, students that study physiotherapy and they go to their internship without having a special course in the uni, it's the same thing with ESP, taking this course to prepare yourself for the internship. And one of the comments mentioned by the students, we didn't mention it, is that they would like to to see in the module a bit how the different intensive care units in different countries all over the world are and they work. So it's within our recommendation, at least for our client, it would be nice if we see it implemented. Well.
At what stage of the physiotherapy learning process, so like first, second, third year, for example, like would you implement the module like this? Because, for example, I took part in the pilot study, and I was doing the module when I was on my internship, and I was in an ICU setting. So that really helped me, but it would have helped me to prepare beforehand. So would you recommend this module in the first year, for example, or would that be too early?
Well, now they changed the idea, and I think the module is before the internships, so the students can prepare to work in an ICU.
Between the first and the second internship. No, it's after the second. Hold on, it's in the second summer. So they will actually done 3. But people can take it earlier, so they can either take it after their second or after their third internship. So they would be here early.
I think it would be more beneficial, for example, if it was like, I don't know how the plan is for the summer between first and second year, but for me, like after the hospital semester that we had, the second semester and first year, it would have been useful for me at that stage, because then my knowledge is already related to the hospital setting. Yeah, I don't know, maybe if something, it's not really a question rather than a comment, if it could be implemented at that stage, because the module actually really did help me at the time, but I would have felt more prepared if I received it before.
So the nice thing about e-learning is that it can be done at any time, anywhere, any place. So yeah.
No.
So that's good advice.
Yeah. Yeah. Any other questions?
Yeah, actually, can I don't have a question, I just want to say something. That's okay.
Sure.
Because I think I'm also actually want to give you a big compliment for the study that you did, because it really, really helped me. And you've seen, or Sylvia saw yesterday, the improvements that we've made. The module is starting to run again from Monday. Anybody with any spare time is welcome to join the e-learning. But it's so much better now already, and I'm sure that we can still improve a lot after this round. We're either going to have another thesis project evaluating the next part as well, so also the practical observation that people now will be doing. So I think, but all of this is actually evolving from what you have done, so I'm really thankful for that.
Yeah, and we're also happy to see the implementations happening already in the course. She told me yesterday, and she even mentioned the word, it looks awesome now. She said that too, so.
Yeah, that's great. Thanks, Eka.
Yeah. Yes.
Thanks for the client is important, of course. I was wondering, not only for this e-learning module, because we are developing all kinds of e-learning models, is it enough to offer it like an e-learning, or is it also necessary to have some not only online support but also offline support? Is that necessary, or can we just provide students with an online e-learning?
No, I think during the focus group meetings they also mentioned that somehow a practical experience is needed to be fully prepared to work in an ICU, and I think it's also in the course that they have to complete some hours in an ICU, and write a report.
I understand that, but I was also thinking support of let's say offline, that you have groups that you can discuss things, or of course you have your internship and you have your ICU experience, you have your online model, but it's also necessary to have discussion about certain topics. Is that necessary, or can we do that in other classes, or is it not necessary at all?
I think it's also that there is the Google Plus, and so they can ask questions and discuss, and I think Mel usually adds interesting articles there, so maybe that's it.
And to answer your questions, all the students reported positive feedback regarding the module, so we think it's necessary to be implemented together with the module itself.
Thank you very much.
Yeah, thank you.
for you, lady.
Thank you. Thank you. You put some. Yeah. Will work like that?
Yeah, just move around so it doesn't.
Okay. Oh God.
Don't walk around. This is yours.
Ah, wait. But it's not working. It's working.
It's working. I hear you very well.
Okay. Tu peux petit donner receive it?
Yeah, I sent it.
Okay.
Yes.
Yes, what do you now here? I just try to make you nervous.
You don't need. I'm already.
No. Wow. Almost the last one.
Yeah.
2 more to go.
Yeah. The beers are there at 5 o'clock approximately, so you better hurry up.
Okay, but maybe we can skip our presentation.
No. This is interesting. People want to hear it.
Oh, no, it's the last one. Yeah. Check whether they have it.
There's actually nobody yet. She's scared.
It should be in the... Can we start?
No. Wait.
It should be in the list of the presentations, the link to the presentation is public one. So if you have a link, you can just access it.
Is it working? Yeah. It's weird.
You can just exit out.
What do you mean? Cross?
Yeah, yes. And start presenting.
Okay.
Okay, so hello everybody. We'll start presenting our thesis. The subject was a qualitative study on how patient needs and experience and physical rehabilitation could be improved after intensive care unit discharge. So I'm Marion and here is Anina. So let's start with the intro. So being discharged from ICU can lead to long-term disabilities, such as physical, emotional, or mental functioning is substantial and could lead to issues in personal life. Apart from their disease or injury, many patients encounter several physical problems due to their stay in ICU. One of the most important one is ICU achial weakness, and can range from a slight muscle weakness to a total paralysis of the body. So some researchers already found a link to short and long-term morbidity, physical impairment, and mortality. Recovery after ICU, it's a long process, so you go from ICU stay to a general ward of hospital, to rehab center, and to finally returning home. However, patients could encounter many complications along the way. To address these issues, there is a growing need to identify and develop interventions that can improve patient outcome. So for that reason, our research question was, what are the patient need and experience after they have been discharged from ICU regarding the physical therapy? Why we did that? The purpose was to investigate how physical rehabilitation could be improved from the patient's perspective and to investigate what problems they encounter along the way. So why we did that? During one of my internship, I had to go in ICU, and we were discussing with Anina, and we thought, yeah, let's join male research. So yeah, it was a topic of interest for the both of us. The interest in physiotherapy field is that so many people experience ICU stay, and for example, in the United States, it's like more than 5.7 million of people who are annually there. The consequences of ICU stay could be dramatic, and yeah, the consequences stay for at least, could stay for at least 5 years, so it's quite important. So let's go on with the method.
Okay, so the participants we had for our research were 2 patients who had spent time in the ICU of the ANC. One of them had suffered from Lumbar and the other one had suffered from a strain of swine flu. You can see a table here that has the basic stats of our patients. The first step of our research was to start by a literature review in order for us to gain better understanding on the topics and what happens to patients during ICU and during the rehabilitation after the ICU. And based on the literature review, we could formulate the questions and topics we use then in the patient interviews. We used a pretty broad inclusion-exclusion criteria for the study because we wanted to make sure that we could get every possible article that discussed post-ICU patients and their rehabilitation. In the inclusion criteria, we agreed to use reliable sources, PubMed, Google Scholar, Pedro. We agreed also to use RCTs and reviews, and any studies published in English, French, or Finnish, because they're the fluent languages we speak. After that, we had a selection first by title, then by abstract, and finally by full text. I'm not going to go more into detail, otherwise we'll run out of time. After doing the literature review, we did interviews with the patients. And based on the literature review, we composed a questionnaire and topics that we wanted to discuss in the interviews with the patients. We decided to use a semi-structured interview so that the patient could speak more freely about their personal experiences and what had happened in their rehab process. And also we asked first a consent for the patients to video record the interviews, and after that we transcribed them, and then the transcriptions were divided into different topics.
Okay, let's go to the results. So for the literature part, the most important part was about the quality of sleep and delirium during the ICU stay, about the ICU acquired weakness, about the use of ICU diaries by healthcare professional and family member, and to finish about the limitation in the physical rehabilitation process. So about the interview, when we asked the patient about quality of sleep and delirium during the ICU stay, both of the patients didn't really have memory about their ICU stay. One was just saying that the only thing he remembered was a feeling of anxiety and fear, and he didn't trust his body or anything around him. And the second one had like a lot of hallucination, but at least they were good hallucinations, so he felt safe, so at least it's better. About ICU acquired weakness, both of the patients said they were really fatigued and they have like a significant weight loss. They were almost completely paralyzed at the end of the ICU stay. Concerning the physical rehabilitation, both of the patients told us that they were really happy with the physical therapy session and they really enjoyed them, and it was a great boost for them also for the mental recovery. One of our patients said that it was the most important moment of the day for me because it was the moment that I could fight my muscle weakness. Concerning the facilitator of recovery, we found that we already found in literature about the ICU diaries, but it was confirmed by our patient. They said that it was a great benefit for them and that helped them to understand what happened exactly during their ICU stay. And the new facilitator found during the interview were the visit from an ex-ICU patient, the recovery board, and self-motivation. We really like this quote. One of our patients says something, I will read it for you. I said to myself, I have 2 years and that's when my Olympic are. And I want to have that gold medal. And everything else, forget it. That's the only thing that is important in my life now. So it was quite strong. Regarding the barrier, we didn't find that many, but one of our patients said that the lack of organization from the healthcare practitioner in their appointment was really something we could improve. And to finish, we have a summary of barrier and facilitator that we found during the interview with the 2 patients.
Okay, so what discussion? The existing research discussed quite a bit in detail the quality of sleep and delirium in the ICU, and they found out that patients who were mechanically ventilated and had a lot of medication were more likely to have delirium. Delirium could range from very bad and nasty hallucinations to nice and soothing.
soothing ones, so it is very patient-specific how they experience it. From our research, patients reported that their quality of sleep in the ICU is poor because there's lights on in ICU all the time, at least during the day, and the machines make a lot of noise, and there's a lot of medical procedures done to patients during the day, so all that contributes to disturbed sleep, and it might even contribute to the fact that they experience delirium. ICU-acquired weakness was one of the most researched topics in the most recent literature. Existing research found that, again, patients who were mechanically ventilated, it contributed to the severity of muscle weakness. And both subjects from our research were ventilated during their ICU stay, and they suffered near full paralysis in ICU. However, they had great physical recovery, and at the end of their rehab process, they were pretty much independent in their ADLs. The facilitators and barriers, so what motivated or demotivated patients, in existing research, there could not be found much on what motivates or demotivates patients. But in our research, we found a few facilitators. One of them was the visit of an ex-ICU patient. The patient told us that hearing from a doctor is less motivating and convincing compared to when someone who's been in ICU because of the same disease. And they said that an ex-patient was a living proof that there is life after ICU, that that's not the end. Another facilitator that we found was the use of an implementation board. In the implementation board, it shows the expected recovery process of that illness, and the patient could relate it to his or her own rehab process to see where she was personally at that stage. And the barriers we found was tiredness, so patients reported that if they did too much the day before they had physio, they would be too tired to do physio, and they found that as a barrier. But also the lack of organization in healthcare, and with that they meant that they didn't know when the physio would come to give their treatment. So they waited the entire day not knowing when it would be, and that was very tiring for them. Therefore, our conclusion is that this research study confirms some previously in research identified facilitators, such as the use of the ICU diary, but we also found new facilitators and barriers. The most important new facilitator of recovery would have been the implementation board and the visit of an ex-ICU patient who had suffered from the same condition. Our recommendation for further research is to use a bigger sample size of patient with different pathologies and different reasons for ICU admission. It would be also interesting to see if there's a difference between being submitted because of an illness or because of a traumatic accident. We also would include the perspective of caregivers and family members, and we would also suggest to look more deeply into the visit of an ex-ICU patient, how that impacts the motivation of the patient in ICU, and how the use of an implementation board can motivate the patients. We would like to thank our coach Arden for help and guidance during the project, and our client Malmajor for help and guidance plus providing a very interesting topic. We also would like to thank the two participants who offered us the valuable information and shared their own personal stories with us. Here you can find our contact details if you have any questions or if you want to see our research. And if you have any questions, please feel free to ask. Anyone?
Sylvia.
You mentioned something about the use of implementation board. Can you kind of really describe what that is?
It's just okay. I'm confused now.
Okay, the implementation board is something one of our patients who we interviewed use in the rehab center setting. It's basically a timeline that shows the progression of the rehabilitation, and in the implementation board the patient could see where he is at the moment and what would be the next expected step. Yeah. With this one we also think there should be more research done because our patients were very motivated and they had a really good recovery, but if you have someone who's behind in their recovery, it might be also demotivating. So it would be interesting to see with a bigger sample size how the implementation board actually works, because with some patients it can be like a motivational boost because they can see what is the next step they can expect and they can see the end is near, sort of. You can see like, okay, this is how many next steps I need to take, and then I'm recovered. Anyone else?
Yeah, thanks for your presentation. I've got a question about the patient. Was that an average patient?
I think
Can you say something about that?
Oh, but
I think our patients were quite lucky in the sense that they had recovered really well. Because if you look at research, they see that patients might have still 5 years after problems that they not recovered to say they are not recovered to the same point as they were before their
one of our patients also said that he was like even stronger than before. Like he felt more fit than he was before the Guillain-Barré.
But one of them also said that, because we asked, would you be willing to take like a physical exercise test to see if you're at the standard of a normal person? And he said, I'm happy where I am at the moment. I function, I can go to work. And I don't want to get the verification that I might actually be there.
But what I can imagine is that there is a broad range of patients in ICU. After accidents, after illness, after. So my question is this representative for the whole population?
We would like to see more research, to see if it makes a difference whether because you were ill that you were in ICU or because of an accident, if that affects it. But even though people get submitted to ICU for different reasons, you can see that all patients who have been in ICU, regardless of why they were there, might still have problems 5 years after. So there is similarities, even though their submission reason could be different.
Can I respond and help as well? Because it was never meant to be representative. It was meant to be a pilot study.
Yeah, it's pilot study.
So you guys piloted your own topic list and doing the interviews. And after that, with your results, I just completed interviews with 35 people who I think were representative for the larger population, exactly as you are recommending now. So for the pilot, it was fine, but it's true that these 2 patients were very positive about their recovery, and that doesn't seem to be coming out of my out of the follow-ups.
It also depends what stage they are in the rehab, because our patients were at the end of the rehab process, whereas if you interview someone who might be in the middle of the rehab, they might have a very different view.
Yeah.
What's happening.
Yeah, clear. Thank you very much.
Thank you.
Well, that's nice.
Thank you.
And now for
Just close it. Yeah, I think. I don't know.
I requested all of you guys to be together. That's why we have 3
Three in a row.
So everyone's gonna get like a.
Uh-oh.
relevant? Was there a connection to the clinical practice? Things like this. So, in this table, you can see how I compare the learning objectives to the actual categories of Bloom's taxonomy. Basically, there are categories based on which level the learning takes place. So what you can see from this table is that for the e-learning module, the learning takes place on the first 3 levels, which is remembering, understanding, and applying. So it is more in the first phases of the learning and not on the very high phases of learning. Then I looked at, do the questions fit the learning objectives? So 11 out of the 25 exam questions could be allocated very well. The rest of them, not that well. So we have some capacity to improve that, for example. Then there were no questions directly related to the learning objective 4 and 5. There can be different reasons for that, and I'm not such an expert in this. So I made the recommendation to Mel, and I'm actually quite curious how she solved it. So we're coming to the quantitative part. Here in this table, you can basically see the average quiz score from students. We had I think 23 students who actually completed, and the final exam score. And you can also see in red, I had the student who scored the lowest, and he was also quite low on the final exam. And in green, I had the student who actually scored on average on the quizzes the highest, and this student was also comparably high in the very end. So we can say there is an association between them. Then, from the Google Analytics, I got a lot of tables from Google Analytics, so I really cannot show you all. I wanted to show you the one divided by gender. So can we actually see that there are more females or males taking the course? Yes, we can. I think it's also due to because there are more female students in ESP. We can see, for example, pages per session, that males view more pages per session, and they also stay longer per session, and females are quicker in this regard. Then, concerning the device category, it was, in Google Analytics you can see, did the user actually log in from desktop, from a mobile, or tablet? And you can clearly see most people log in from a desktop, and I want to draw your attention to the bounce rate especially, because the bounce rate is the percentage of people who actually click backwards. That can be, for example, due to you are frustrated, yeah? Something doesn't work, it's not nice. So we see that this amount is actually the greatest with mobile devices, yeah? 54%. And also, of course, the average session duration was also the shortest with mobile. So that can be, for example, you can just not see the module very well. So, coming to the discussion. I think it's very important that we get this e-learning module to a good quality, because it will be part of the ESP curriculum. So it was really nice that there was a pilot beforehand that we could evaluate it. My limitations were a small number of interviews, so there were only 2 people. For this purpose, it was still okay, I think, but of course it would have been better with even more people. Only one person was actively involved in the coding process, so usually if you do qualitative research, it's much nicer and better for the reliability to have a bigger team of people doing it together. Google Analytics, it only shows the sessions, not the amount of users responsible for these sessions. So it could have been that either one person logged in many times, or there were many people logging in once each. We don't know. And the admin also shows as a user, so maybe Mel also logged in and it kind of, there's a distortion maybe, we don't know. So, the conclusions of the whole thing, the strength, the interactiveness, really nice, yeah? The simplicity of the Google setup, it's very clear. The degree of difficulty is really good. Formative quizzes were really good. And it's very suitable for students who begin learning about the ICU. The weaknesses contain the technical aspects and a lacking degree of critical alignment. Suggested improvements include an easier sign-up procedure that corresponds to the technical aspects now, multi-responsiveness. It should look the same on mobile device than on a desktop. The resources should be available directly in the module. Refilming the videos using a GoPro, modifying learning objective number 4, and improving the summative exam questions. This is my product, very end. So I basically made a practical time planning for implementing the changes for Mel. Yeah, and my references, very end, my acknowledgement. Yeah, I want to thank my co-chair, Ardo, client Mel Major, and my interviewees who are not here today, unfortunately, Bastian Stocker and Avi Fitrio. And if there are any questions in the end, you are more than free to ask them.
Could you go back to the results table, the Google Analytics table? Because when I was looking at your thesis and the data, I thought this is interesting. If you look at the bounce rate, at the top table, because what I understood is that bounce rate is also people navigating away from the site without, or the page without interacting with it.
Yes,
so that's people visiting the module but deciding no, and they're not interacting with it. So you see the bounce rate is higher for females than for males.
Yeah.
No, I'm just wondering if you can think of any explanation for this. Also, the duration, the session duration time, is lower for females than for males.
Yeah, so there are different possible causes for this. Like, for example, about the duration, it could be.
I want to hear from her.
I mean, it could be that the males are just more, they take more time to really get into it. Or it could be the females, they are just smarter because they get it faster. So we don't really know that. About the bounce rate, it could be that females are slightly impatient. So if it doesn't work, you just click back right away. We don't know.
Okay.
Could be possible.
Yeah, I think it's the first one. The one
You think?
The smart one.
Okay. Yeah, Timo.
I think you said you had 23 users in the end?
Yes.
How many were there starting?
35.
Okay, excellent. But, and did you have any data about the ones that quit? Because those are,
Yes.
I think, also interesting.
Yes, we have data for them as well. We also saw, I couldn't include everything because I'm also a bit worried that I would run out of time because it's a huge project. Yes, we have data about them. We also have, we can see at which point they dropped out, for example. So that was quite interesting to see. We, for example, saw also that the people who actually dropped out did it very early on. So as soon as they were over the half, all people continued. Yeah.
I even contacted because I wanted to also know about the dropouts. There were actually only 4 dropouts that had started already and had decided to quit. And most of them, or all of them actually quit because they either didn't have internet access where they were, or they didn't have time. So there was too much pressure on them already, PhD pressure. But the others, the other 11, they dropped out because they never started.
Yeah, okay, that is also a possibility.
Mel? One more question.
Yeah, spoken to her very personally. I heard via my coach that she was satisfied with the whole thing. But I'm actually myself quite curious if it worked out or not, or...
It's interesting because the exam, you were quite harsh, but rightfully so, on the exam.
Yes.
It was a really bad exam. So that's completely changed.
Okay.
And in the last module that ran, the pass rate was much higher, and I didn't get any negative feedback.
Good.
But I guess we wouldn't if the pass rate is high. So I think that was a good change. And that was another one of the major changes. And the new Google site, so we're hanging the module in the Google sites now, makes it work for every device.
Really nice.
All those hiccups that people said is a user friendliness, and that also came from their study. You know, with the links and the clicking and the hyperlinks not working or whatever, that sort of thing.
That's very nice, yeah.
Yeah.
Okay, thank you very much.
All right, we're finished?
Yeah.
Time for a drink?
There is still beer outside.
Maybe some last words for YouTube. Thanks for watching.